2 yıldır hepimiz COVID-19 nedeniyle hem bilgi kirliliğinde boğulduk hem pek çok yanlış bilgi edindik. Hayatlarımız bir noktada dondu kaldı.
Ülkemiz COVID-19'dan maddi manevi çok çekti ve de hala da çekmeye devam ediyor. Amacımız bundan bir an evvel kurtulmak. Bir an evvel kurtulmanın yolu da doğru bilgi edinmek.
Göğüs hastalıkları uzmanlarının oluşturduğu Türk Thoracic Derneği, pandemi farkındalığı yaratmak ve akciğer hastalıkları konusunda bir kongre düzenliyor.
Türk Thoracic Derneği, Türkiye'nin göğüs hastalıkları alanında en etkin, en köklü kuruluşlarından biri.
Sizleri 26-27 Şubat tarihlerinde Türk Thoracic Derneği'nin düzenlemiş olduğu online COVID-19 ve akciğer hastalıkları ile ilgili bilgilendirmeye davet etmek istiyorum.
İnternet üzerinden yayınlanacak olan bu online kongrede konu COVID-19 ve akciğer hastalıkları.
Katılımınız dediğim gibi çok önemli.
Hepimiz davetliyiz.
Hepinizi bilgilenmek için bu kongreye davet ediyoruz.
Doğru bilgiye ulaşmamızı sağlayan tüm sağlıkçılarımıza teşekkürler.
Türk Thoracic Derneği 26 ve 27 Şubat'ta halk için akciğer hastalıkları ve COVID-19 kongresini düzenliyor.
COVID-19 ve akciğer hastalıkları ile ilgili merak ettiğiniz birçok sorunun cevabını bu kongrede bulabileceksiniz.
Ülkemizin göğüs hastalıkları alanındaki en köklü derneği olan Türk Thoracic Derneği tarafından
sizler için hazırlanan ve katılımın ücretsiz olduğu bu kongrede koronavirüs ve pek çok akciğer hastalığı hakkında en yeni bilgiler konunun uzmanları tarafından aktarılacak ve sorularınız canlı olarak yanıtlanacaktır.
Katılım tamamen ücretsiz olup Türk Thoracic Derneği'nin YouTube, Twitter, Instagram ve Facebook sayfalarından ulaşılabilir olacak.
Bu kongre sizin için.
Bu kongre sizin için, hepimiz için.
Kaçırmayın derim. Hepimiz davetliyiz.
Bekliyoruz.
Türk Thoracic Derneği 26-27 Şubat tarihlerinde halk için akciğer hastalıkları ve COVID-19 kongresi düzenliyor.
Üstelik internetten yayınlanacak. Yani herkes gelebilir, herkes katılabilir, herkes öğrenebilir. Sakın kaçırmayın.
Harika bir kongre yapılıyor. Kongreyi takip edelim.
Türkiye'de göğüs hastalıkları alanında en etkili, en eski dernek olan Türk Thoracic Derneği de bu amaçla geçen yıl olduğu gibi bir akciğer hastalıkları ve COVID-19 açık halk kongresi düzenliyor.
Tıp camiasında önemli bir dernek, önemli bir kuruluş Türk Thoracic Derneği.
İyi ki varsın Türk Thoracic Derneği.
İki yıldır hepimiz COVID-19 nedeniyle hem bilgi kirliliğinde boğulduk hem pek çok yanlış bilgi edindik. Hayatlarımız bir noktada dondu kaldı.
Ülkemiz COVID-19'dan maddi manevi çok çekti ve de hala da çekmeye devam ediyor. Amacımız bundan bir an evvel kurtulmak. Bir an evvel kurtulmanın yolu da doğru bilgi edinmek.
Göğüs hastalıkları uzmanlarının oluşturduğu Türk Thoracic Derneği, pandemi farkındalığı yaratmak ve akciğer hastalıkları konusunda bir kongre düzenliyor.
Türk Thoracic Derneği, Türkiye'nin göğüs hastalıkları alanında en etkin, en köklü kuruluşlarından biri.
sizleri 26-27 Şubat tarihlerinde Türk Thoracic Derneği'nin düzenlemiş olduğu online COVID-19 ve akciğer hastalıkları ile ilgili bilgilendirmeye davet etmek istiyorum.
İnternet üzerinden yayınlanacak olan bu online kongrede konu COVID-19 ve akciğer hastalıkları.
Katılımınız dediğim gibi çok önemli.
Hepimiz davetliyiz.
Hepinizi bilgilenmek için bu kongreye davet ediyoruz.
Doğru bilgiye ulaşmamızı sağlayan tüm sağlıkçılarımıza teşekkürler.
Türk Thoracic Derneği 26 ve 27 Şubat'ta halk için akciğer hastalıkları ve COVID-19 kongresini düzenliyor.
Covid-19 ve akciğer hastalıkları ile ilgili merak ettiğiniz birçok sorunun cevabını bu kongrede bulabileceksiniz.
Ülkemizin göğüs hastalıkları alanındaki en köklü derneği olan Türk Thoracic Derneği tarafından
Sizler için hazırlanan ve katılımın ücretsiz olduğu bu kongrede koronavirüs ve pek çok akciğer hastalığı hakkında en yeni bilgiler konunun uzmanları tarafından aktarılacak ve sorularınız canlı olarak yanıtlanacaktır.
Katılım tamamen ücretsiz olup Türk Thoracic Derneği'nin YouTube, Twitter, Instagram ve Facebook sayfalarından ulaşılabilir olacak.
Bu kongre sizin için.
Bu kongre sizin için, hepimiz için.
Kaçırmayın derim. Hepimiz davetliyiz.
bekliyoruz.
Türk Thoracic Derneği 26-27 Şubat tarihlerinde halk için akciğer hastalıkları ve COVID-19 kongresi düzenliyor.
Üstelik internetten yayınlanacak. Yani herkes gelebilir, herkes katılabilir, herkes öğrenebilir. Sakın kaçırmayın.
Harika bir kongre yapılıyor. Kongreyi takip edin.
Türkiye'de göğüs hastalıkları alanında en etkili, en eski dernek olan Türk Thoracic Derneği de bu amaçla geçen yıl olduğu gibi bir akciğer hastalıkları ve COVID-19 açık halk kongresi düzenliyor.
Tıp camiasında önemli bir dernek, önemli bir kuruluş Türk Thoracic Derneği.
İyi ki varsın Türk Thoracic Derneği.
İki yıldır hepimiz Covid-19 nedeniyle hem bilgi kirliliğinde boğulduk hem pek çok yanlış bilgi edindik. Hayatlarımız bir noktada dondu kaldı.
Ülkemiz Covid-19'dan maddi manevi çok çekti ve de hala da çekmeye devam ediyor. Amacımız bundan bir an evvel kurtulmak. Bir an evvel kurtulmanın yolu da doğru bilgi edinmek.
Göğüs hastalıkları uzmanlarının oluşturduğu Türk Thoracic Derneği, pandemi farkındalığı yaratmak ve akciğer hastalıkları konusunda bir kongre düzenliyor.
Türk Thoracic Derneği, Türkiye'nin göğüs hastalıkları alanında en etkin, en köklü kuruluşlarından biri.
Sizleri 26-27 Şubat tarihlerinde Türk Thoracic Derneği'nin düzenlemiş olduğu online COVID-19 ve akciğer hastalıkları ile ilgili bilgilendirmeye davet etmek istiyorum.
İnternet üzerinden yayınlanacak olan bu online kongrede konu COVID-19 ve akciğer hastalıkları.
Katılımınız dediğim gibi çok önemli.
Hepimiz davetliyiz.
Hepinizi bilgilenmek için bu kongreye davet ediyoruz.
Doğru bilgiye ulaşmamızı sağlayan tüm sağlıkçılarımıza teşekkürler.
Türk Thoracic Derneği 26 ve 27 Şubat'ta halk için akciğer hastalıkları ve COVID-19 kongresini düzenliyor.
Covid-19 ve akciğer hastalıkları ile ilgili merak ettiğiniz birçok sorunun cevabını bu kongrede bulabileceksiniz.
Ülkemizin göğüs hastalıkları alanındaki en köklü derneği olan Türk Thoracic Derneği tarafından
Sizler için hazırlanan ve katılımın ücretsiz olduğu bu kongrede koronavirüs ve pek çok akciğer hastalığı hakkında en yeni bilgiler konunun uzmanları tarafından aktarılacak ve sorularınız canlı olarak yanıtlanacaktır.
Katılım tamamen ücretsiz olup Türk Thoracic Derneği'nin YouTube, Twitter, Instagram ve Facebook sayfalarından ulaşılabilir olacak.
Bu kongre sizin için.
Bu kongre sizin için, hepimiz için.
Kaçırmayın derim. Hepimiz davetliyiz.
bekliyoruz.
Türk Thoracic Derneği 26-27 Şubat tarihlerinde halk için akciğer hastalıkları ve COVID-19 kongresi düzenliyor.
Üstelik internetten yayınlanacak. Yani herkes gelebilir, herkes katılabilir, herkes öğrenebilir. Sakın kaçırmayın.
Harika bir kongre yapılıyor. Kongreyi takip edin.
Türkiye'de göğüs hastalıkları alanında en etkili, en eski dernek olan Türk Thoracic Derneği de bu amaçla geçen yıl olduğu gibi bir akciğer hastalıkları ve COVID-19 açık halk kongresi düzenliyor.
Tıp camiasında önemli bir dernek, önemli bir kuruluş Türk Thoracic Derneği.
İyi ki varsın Türk Thoracic Derneği.
2 yıldır hepimiz COVID-19 nedeniyle hem bilgi kirliliğinde boğulduk hem pek çok yanlış bilgi edindik. Hayatlarımız bir noktada dondu kaldı.
Ülkemiz Covid-19'dan maddi manevi çok çekti ve de hala da çekmeye devam ediyor. Amacımız bundan bir an evvel kurtulmak. Bir an evvel kurtulmanın yolu da doğru bilgi edinmek.
Göğüs hastalıkları uzmanlarının oluşturduğu Türk Thoracic Derneği, pandemi farkındalığı yaratmak ve akciğer hastalıkları konusunda bir kongre düzenliyor.
Türk Thoracic Derneği, Türkiye'nin göğüs hastalıkları alanında en etkin, en köklü kuruluşlarından biri.
Sizleri 26-27 Şubat tarihlerinde Türk Thoracic Derneği'nin düzenlemiş olduğu online COVID-19 ve akciğer hastalıkları ile ilgili bilgilendirmeye davet etmek istiyorum.
İnternet üzerinden yayınlanacak olan bu online kongrede konu COVID-19 ve akciğer hastalıkları.
Katılımınız dediğim gibi çok önemli.
Hepimiz davetliyiz.
Hepinizi bilgilenmek için bu kongreye davet ediyoruz.
Doğru bilgiye ulaşmamızı sağlayan tüm sağlıkçılarımıza teşekkürler.
İki konuğumuz var. Konumuz Türk Thoracic Derneği'nin Halk için Akciğer Hastalıkları ve COVID-19 Kongresi. Önümüzdeki hafta sonu yani 26-27 Şubat tarihlerinde cumartesi pazar yapılacak bir halk kongresi ve çok kapsamlı bir programı olduğu göze çarpıyor.
Türk Thoracic Derneği hem COVID-19 konusunda hem de toplumda sık görülen akciğer hastalıkları konusunda halkımızı, hasta ve hasta yakınlarını aydınlatmak amacıyla düzenliyor bu kongreyi. İkincisi düzenleniyor. Ekim 2020 yılında 150 bin katılım olmuştu. Bu sene daha fazla katılım bekliyoruz. Çünkü yurt dışına da açıldık.
Salgının başından beri biz Türk Thoracic Derneği olarak, Türk Tabipler Birliği, Klinik Enfeksiyon Hastalıkları Derneği ve Halk Sağlığı Uzmanları Derneği başta olmak üzere bu tür uzmanlık örgütleri olarak doğru bilimsel bilgiyi halkla buluşturmak için çok çaba sarf ettik. Değişik mecralardan. Geçen yılda Füsun Hoca'nın da söylediği gibi böyle bir kongre yapmıştık. Oldukça geniş bir katılım oldu. Bu sene de aynı şeyi amaçladık. Doğru bilgiyi ve insanların çok kafasında takılan, bunların önemli bir kısmı COVID ile bağlantılı olan sorularını doğrudan ilgili konuyla ilgili bilim insanlarıyla buluşturmayı amaçladık. Umarım geniş bir katılım olur ve doğru bilgiye ulaşma konusunda halkımıza bir pencere açabiliriz.
Türk Thoracic Derneği'nin Instagram sayfalarından ulaşabilirsiniz konulara, konu başlıklarına, saatlerine ve bu oturumları tanıtan kısa videolar hazırladık. Hani nelerden söz edeceğiz bu oturumlarda? Gene bunlara da ulaşabilir halkımız.
Bilim dünyası ya da biz kendi şeyimizde, alanımızda düşünürsek tıp alanında kendi kongrelerimizi yaparız biz. Bir bilim dilimiz vardır. İşte dışarıdan anlaşılmayan, yarısı Latince, yarısı işte diğer yabancı dillerden olan bir jargonumuz vardır. Onlarla konuşuruz, tartışırız işte ve hayatı uygulamaya geçeriz. Ancak dışarıda da başka bir hayat sürüyor. Yaptığımız tartışmalar halkla pek fazla buluşmaz. Bu Covid'de ortaya çıkan bu işte info diye tanımladığımız durum belki bizi bu konu üzerinde yeniden düşünmek ve çözümler üretmek üzerine bir fırsat yarattı diyebiliriz. Belki böyle de bakabiliriz bu tür aktivitelere, halk kongresine ya da buna benzer daha önce derneğimizin yaptığı çeşitli küçük videolarla YouTube kanalından özellikle konunun uzmanlarıyla halka ulaşma konusunda biz bilim camiasına da, bilim insanlarına da başka bir görevi hatırlattı diye düşünüyorum.
Welcome to our
Böyle bir
Congress. In
fırsat
fact,
yarattı.
that was an important opportunity we are taking to inform the public. And
halk
Turkish Thoracic
sağlığını yakından
Society,
ilgilendiren ve
in
etkileyen
fact, is now
önemli
engaged in
konuları
this activity to inform the public
çeşitli
about the topic that
toplantılarında,
has been
konferanslarında filan
affecting the
kendisine dert
public
edin.
itself
Bunu
severely.
bir tür
You know, we thought
aktivizm
it was a concern for
şeyi
all of
haline
us. In fact,
getirebiliyor,
that is
vesilesi haline
now turned
getirebiliyor.
to
Pandemi
a kind of
neden bitmiyor?
activism
Kaderimiz
for the
mi?
society. The
Kaderimiz
pandemic
mi?
cannot be
Başlığını
over,
taşıyan ikinci
but
gün
is it our
27
destiny?
Şubat'ın
And
12
or
saat
that will
12'de
be the
başlayan
topic of discussion in a session that
konferansında
will start
bu çok
at 12
tayin edici bir
o'clock
soru.
on
Yani
the second day, the
herkesin
27th of
Türkiye'de
February.
dahil,
Well,
yani
that's
en
an important
azından benim
question
çevremde
for everyone
gözlemlediğim
around us,
herkesin kafasındaki en
and
önemli acil
everyone around
sorunlardan bir
myself,
tanesi.
everyone in
Şimdi bir
Turkey, in
yandan
fact,
arkadaşlar sosyal medya
is occupied
hesaplarımızı da
with
içeren
this
ve
question.
bu 26 ve 27'sinde
The
gerçekleşecek halk için akciğer hastalıkları ve COVID-19 kongresinin duyurusunu
Pulmonary
gösteriyor. Ben
diseases and
buradan bir kez
COVID-19
daha
Congress
Türk
for the
Toraks
public,
Derneği'nin YouTube
in fact, is going to take
hesabı, YouTube
place on the
televizyonu,
26th and
Türk Toraks
27th of
Derneği'nin
February,
yine Twitter
and this
hesabını,
shows the
Facebook hesabını ve
Congress,
Instagram hesabını
the
değerli
Facebook, Instagram, and
dinleyicilerimizden takip
Twitter
etmelerini
accounts
rica
of
ederim.
the Thoracic
Çünkü buralarda
Society, in fact,
özellikle
should
bu
be
kongre
followed
ve bunun
by
sonrasında
all those who are interested. I believe this will be to the interest of everyone.
Bizim uzmanlık derneğimiz olan Türk Toraks Derneği'nin halk için bir kongresi var ve bu kongrede senden destek
Well, you know,
rica
the
ediyoruz.
Turkish Thoracic
Akciğer
Society, in fact,
hastalıkları aslında bizim
is a
hastalık
society
yükü
of a
dediğimiz
certain
ülkemizdeki hastalık
specialization,
yükünün çok
and
büyük
now
bir
we are
kısmını oluşturuyor.
organizing
Özellikle
this
kronik akciğer hastalıkları, solunumsal
Congress, and
hastalıklar.
chronic
Hem
pulmonary
bu
diseases,
hastalıklarla
respiratory
ilgili
diseases create
bilgi
a
iletmek
big
hem de
part of the
COVID-19
disease
ilgili
burden, especially
infodemi
in our
diyoruz biz,
country.
yanlış
So we'd like
bilgi
to
salgınını
inform the public about the pulmonary
engellemek
diseases
ve
and
halka
also
doğru bilgiyi iletmek
COVID-19.
amacıyla
We are
gönüllülük
trying to
esasıyla
prevent
yapılan
the
bir kongre
epidemic.
bu.
Nerede oluyor
That is
peki?
the pandemic
Online
of
olacak.
the
Pandemi süreci boyunca biz doğru
disinformation.
bilgiyi ulaştırmak
And where does the
adına çok
Congress
çabaladık.
take place?
Böyle
It
bir halk
will
kongresiyle de
be an
yani
online congress,
halkımıza
and we put a
ulaşma
lot of
Ne
efforts
güzelmiş.
in
platformu
this
Sağ olun,
oluşturmak
congress
eksik
because
istedik.
olmayın.
we
Çok
wanted to
faydalı bir
create a
iş yapıyorsunuz.
platform
O
that
yüzden
would be
buradan da
accessible for all
ulaştırmış olalım. O
the public.
tarihlerde
Yes,
herkes
that is
Türk
a
Toraks
very nice
Derneği'ne
initiative. So on
incelemede
26th and
kalsınlar.
27th of February, everyone should be looking at the YouTube page of Turkish Thoracic Society.
Bütün
Turkish Thoracic
vatandaşlara
Society
ücretsiz olarak açık cumartesi ve pazar günleri
is organizing
da
this
katılmayı
public
ihmal etmeyin
event
sağlığınızı
on
koruyun derken.
the Saturday and Sunday
Yine
of
Türk
this
camiasında
week. Please
önemli bir
keep an eye on their
dernek, önemli bir
page.
kuruluş.
Turkish
Türk
Thoracic
Toraks
Society is an
Derneği.
important organization
Yani göğüs
for the
hastalıkları
country. So
uzmanlarının
the
çatı derneği,
specialists
Türk
of
Toraks
thoracic
Derneği.
diseases, in fact, are
Bu
brought
dernek
together
bu ay
under this
bir
umbrella
kongre
organization.
düzenliyor.
And this month they are organizing this
Bilgilendirme
congress.
konferansı düzenliyor.
This is
İki
an
gün sürecek bu
information
konferans.
congress. It's going
26 ve 27
take
Şubat
2 days. It is
tarihlerinde
going to be held on the
bütün
26th and
topluma açık.
27th of February. It is
Herkes
open to everyone,
Türk
all the
Toraks
public,
Derneği'nin sosyal medya
kind of
hesapları
invited
üzerinde
to visit the social media
ücretsiz olarak
account
bu
of
konferansa
Turkish Thoracic
katılabilir.
Society.
Oradaki
Everyone
sunumları
can access the
dinleyebilir ve bu sunumların
Congress
esas
page
ekseninde
free of
akciğer
charge
hastalıkları
and
ve
listen to different sessions regarding the pulmonary diseases, and specifically COVID-19 disease will be the topic of the information sessions and presentations to be held and delivered during these couple of days. In fact, we are proud by this national and also international congress of this Turkish Thoracic Society, and thank you for inviting me here today to inform you about our congress. And also, I would be glad to answer your questions about COVID-19 as well. Thank you, Professor. You have been giving more warnings about coronavirus, and also I know that on the 26th and 27th of February, Turkish Thoracic Society is going to meet the public with this topic. I know that last year you also had a similar event. How many people were watching you last year, and what is your expected number of viewers this year? On the 29th of October last year, 150,000 people watched us on all the virtual platforms. And this week, on Saturday and Sunday, we are going to be discussing many other interesting topics as well. Coughing, smoking, electronic cigarettes, heated tobacco products, nodules in the lung, COPD, TB, many topics will be discussed by the prominent experts of the country. There will be some nice interaction, and they will be able to answer some incoming questions as well. The European and the US thoracic societies, pulmonary societies, all the patient societies, they have all been in communication with us. We are going to be feeding our streaming to all of these societies. I would like to give some information about health, because nowadays we are going through this COVID, and we have been mostly discussing our lungs. And Turkish Thoracic Society has this event now. Their congress is starting with the topic of pulmonary diseases and COVID-19 congress for the public. And this year, they're organizing the congress in February, this Saturday and Sunday. It's going to take 2 days on the 26th and 27th of February. Last year, they had a similar event on Instagram, Twitter, and other social platforms. You will be able to watch the streaming. About 25 different topics. The experts will come together to discuss different topics for public health, and there will be simultaneous interpretation in English as well. So, who are suffering from chronic pulmonary diseases, COPD, may want to have a look, pneumonia, TB, air leakages from the lung, and hemorrhage in the lungs, and many other diseases will be discussed here. A secondary effect of the pandemic was to increase the burden of pulmonary diseases. And please be aware that the Congress is going to take place on the 26th and 27th of February, and you may find answers to many questions. For example, should I get a checkup for my lungs? Should I worry because there are nodules in my lungs? And I am obsessed with cleaning. Should I panic? So as of 12 o'clock on Saturday, the Congress starts, and it's going to be broadcast on all social media accounts of the Turkish Thoracic Society, and over a weekend, because they want the Congress to be accessible for all the public. Hello, today I would like to talk about a Congress. I would like to inform you about a Congress. This is a Congress that is being organized by the Turkish Thoracic Society. It is going to take place this weekend, and Professor, the dear professor and the chairperson of the Congress is with us. We're having this Congress because we'd like to inform all the public about pulmonary diseases and COVID-19. So it is taking place this weekend on the 26th and 27th of February. We start at noon, at 12, and the sessions will continue until 6:30 p.m. And you can watch us on the social media accounts of Turkish Thoracic Society, YouTube, Instagram, Facebook, Twitter, will be the platforms that you can use for watching us. As you have mentioned, Mr. Ömer Madra, we are organizing this Congress about pulmonary diseases and COVID-19 for the public on the 26th and 27th of February. We are going to get questions from the public as well. We would like to provide proper and accurate information to the public about these diseases. Well, I know that this will be a very comprehensive Congress to be organized by the Turkish Thoracic Society over the weekend. And you will talk about why the pandemic is not coming to an end. Is it our destiny? Will be the question that you will be asking. So there are many reasons as well. There are many discussions on the table at the same time. The air pollution, the climate change, and also I guess you will be discussing the prognosis of the disease in the children, and many other questions will be answered, I guess, during this Congress. Hello, everyone. I'm Dr. Füsun Topçu from the Turkish Thoracic Society. Our society is organizing this second Pulmonary Diseases and COVID-19 Congress for the public. Welcome to our Congress. And we would like to start with some social media coverage about our Congress. I would like to introduce our Congress team to you. To start with our secretary, Dr. Pınar Bursa, and all members of the Congress team, thank you very much for all your precious efforts. For 1 month, on the social media accounts of our society, we had very nice messages from the Mayor of Istanbul Metropolitan Municipality, Ekrem İmamoğlu, and Tunç Soyer, Mayor of Izmir Metropolitan Municipality, and many other important anchor people were there to speak to you and give messages for inviting you to our Congress, and all these messages and invitations were broadcast on our social media accounts. We are supported by many other international health organizations this year, and many international societies, in fact, have been supporting us. And this year we are broadcasting abroad as well. And please let me also introduce you to the executive board of the Turkish Thoracic Society. I'd like to thank each of the members of the EP for their great support throughout this process. And Professor Dr. Oya İtil is the president of the society. Dear Professor, thank you for being here, and would like to thank you for the kind support to this Congress. But would you please kindly introduce your society briefly? Yes, thank you very much, dear Professor Füsun. I wish you success. I would like to thank in advance for all the efforts. Turkish Thoracic Society is there in order to protect and promote a national pulmonary health. It is a society of specialists. We attach great value and give respect efforts, patients, accountability, being scientific, working evidence-based. These are some of the principles that follow. We have about 6,800 members, and more than 50% of the membership is female. We are working with many branch offices and 8 working groups. We are working to influence the public health and also the health policies. Thank you. Well, thank you, dear Professor. So how did you decide and come up with this idea to have a Congress for the public? Well, this Pulmonary Diseases and COVID-19 Congress for the Public, in fact, is being organized for the second time this year, as you very well know. But why do we need such a congress? Because there's information flowing from many sources. And that may easily confuse the public opinion, but we wanted to provide accurate information to the public. So we have invited specialists of the field so that they would properly inform the public. So anything that you are curious about, some popular questions that all the patients ask to the physicians in daily routine will be discussed. Unfortunately, pulmonary diseases are seen very frequently in recent years. Over the pandemic, we tried to inform the public properly. I hope over these couple of days, we will be able to eliminate all the question marks on the minds of the public. I would like to thank all the Congress team and also the owner of the very first idea was the idea of Professor Benan Müsellim in the first Congress. Thank you very much. I extend you my best regards. Well, thank you. As you heard from Professor Oya Itil, this project was initially designed by and also organized on the 29th of October 2021 for the first time by Professor Dr. Benan Müsellim. He's also here with us right now. So how did you come up with this idea and how did you design this Congress? Would you please talk about this? Well, of course, thank you. I'd like to thank all the viewers who are here, who made their time to watch us, and very soon a very nice session is going to speak about the vaccines. You know, this is a very popular topic for everyone. So paying attention to the time limits, I would like to speak about how we came up with this idea. You know, at the onset of the pandemic, everyone was very confused. Everyone was buying the packages of pasta from the supermarkets, and then we were washing it on the running water for minutes, and then we would let it dry in the balcony. We were waiting for the vaccines, but we wouldn't know if they would be effective or not. And there were many gossips on the media, and the public was fluctuating. Public opinion was fluctuating. This is the age of communication, and it's not very difficult to offer accurate information to the public. As you heard from the representative of the society, we are responsible for generating and offering scientific information to the public, and that is the path as the Turkish Thoracic Society we have been following. And on the 29th of October 2020, we organized the first Congress as the Turkish Thoracic Society, but we didn't want it to be lecturing. We wanted to be able to answer questions coming from the public live, and we actually did it during our Congress in 2020. We received many questions, and instantly the specialists and most important experts of the field answered all these questions coming from the public. Well, I think we are one of the kind as regards such an operation. I think it has been over 700 days since COVID-19 first occurred in Turkey on the 11th of March 2020. We have been trying to inform everyone since then, and for the first time we organized such a public congress, and we received the highest number of participants in a congress, 150,000. Well, I think we were able to contribute to the progress regarding public health. Well, thank you very much, Mr. Müsellim. Well, how was the reaction or feedback that you get after the Congress? Well, the people around me, in fact, watched the Congress, and I got very positive feedback from them. And as I said before, we got a very significant number of viewers, 150,000, reaching such a high number and informing the people, all these people properly, was really something. At that time, there were rumors everywhere and statements and misstatements were all around. I think we attained our goal. And it was providing correct information to the public. We're still in the midst of the pandemic. There are still many unanswered questions. Should we get the vaccine? Are we going to continue having these vaccines during our lifetime? How long are we going to wear the mask? There are still many pending questions. I think it is the right time to have the second Congress. Yes, I agree. Well, thank you. And, there was no such Congress in the world before, and we wanted to offer the scientific information and data from Turkey to the rest of the world. In the first Congress, we didn't do it, and this is the second Congress, and now we are doing it. We are also addressing the other nations as well. I hope we will not have to organize a third Congress about this topic, and here I end my remarks. Well, thank you. In 2 or 3 minutes, the first session is going to start. And during the first 15 minutes, there will be a conversation. And after 15 minutes, we're going to get your questions from the social media. And after the first 15 minutes, we're going to answer your questions in a period of 10 minutes. Please join our Congress and send away your questions. Please stay tuned. Today is Saturday. Tomorrow we will be saying hello to you from Istanbul, and please stay tuned. Welcome again to our Congress.
konusunu enine boyuna sizlerle tartışmak istiyoruz. COVID-19'daki aşı türleri, aşı etkinliği, aşıların güvenliği, yan etkileriyle ilgili güncel bilgileri sizlerle paylaşacağız. Evet, COVID-19 son 2 yıldır gündemimizi fazlasıyla doldurmakta. Ancak zatürre, grip gibi önemli akciğer enfeksiyonları, özellikle kırılgan hastalık grupları dediğimiz kronik hastalığı olan kişilerde önemini hala korumakta. Zatürre ve grip aşıları özellikle hangi gruplara yapılmalı, etkinliği nedir, güvenli midir? Bu konuları da sizlerle enine boyuna tartışmak istiyoruz. COVID-19 aşıları ve diğer erişkin aşılamasında geçerli olan zatürre ve grip aşıları ile ilgili güncel bilgileri aktarmak, sizlerden gelecek soruları da yanıtlamaya çalışmakta olacağız. Kongremiz Türk Thoracic Derneği sosyal medya hesaplarından, YouTube, Facebook, Twitter, Instagram hesaplarından canlı olarak yayınlanacaktır. 26-27 Şubat tarihlerinde hepinizi COVID-19 ve akciğer hastalıkları kongremize bekliyoruz. Merhaba, ben Profesör Doktor Füsun Öner Eyüboğlu, Türk Thoracic Derneği Solunum Sistemi Enfeksiyonları Çalışma Grubu Başkanıyım. Türk Thoracic Derneği 26-27 Şubat tarihlerinde halk için akciğer hastalıkları ve COVID-19 kongresi düzenliyor. Solunum sistemi enfeksiyonları çalışma grubu olarak COVID-19 pandemisini bitirebilmenin en etkin yolu olan aşılama konusunu enine boyuna sizlerle tartışmak istiyoruz. COVID-19'daki aşı türleri, aşı etkinliği, aşıların güvenliği, yan etkileriyle ilgili güncel bilgileri sizlerle paylaşacağız. Evet, COVID-19 son 2 yıldır gündemimizi fazlasıyla doldurmakta. Ancak zatürre, grip gibi önemli akciğer enfeksiyonları, özellikle kırılgan hastalık grupları dediğimiz kronik hastalığı olan kişilerde önemini hala korumakta. Zatürre ve grip aşıları özellikle hangi gruplara yapılmalı, etkinliği nedir, güvenli midir? Bu konuları da sizlerle enine boyuna tartışmak istiyoruz. COVID-19 aşıları ve diğer erişkin aşılamasında geçerli olan zatürre ve grip aşıları ile ilgili güncel bilgileri aktarmak, sizlerden gelecek soruları da yanıtlamaya çalışmakta olacağız. Kongremiz Türk Thoracic Derneği sosyal medya hesaplarından, YouTube, Facebook, Twitter, Instagram hesaplarından canlı olarak yayınlanacaktır. 26-27 Şubat tarihlerinde hepinizi COVID-19 ve akciğer hastalıkları kongremize bekliyoruz.
Distinguished audience, I'd like to welcome you all to this public congress. We are very excited as well as you are. And in this first session today, we have organized as the Respiratory System Infections Working Group, and we discussed the most important topics. So we decided on vaccination of the adults, including primarily the COVID-19 vaccine. My name is Dr. Füsun Öner Eyüboğlu. I'm the head of the Respiratory System Infections Working Group of the Turkish Thoracic Society, and we have a guest speakers. Our Professor Sayner will be with us. Our distinguished guest, Abdullah Sayner, will be with us from Ege University Medical Faculty, Chest Diseases Department. Welcome, Professor Sayner. If you like, let's discuss the problematic COVID-19 and the related vaccines and vaccination. Could you please provide the overall information and overview of this situation? Yes, it will be my pleasure. Thank you very much. I'd like to share my screen right away. I hope you can see my screen. As you highlighted, I'm now going to talk about the protection against the adult infections and infectious diseases, and we're going to talk about the vaccines, which is an important method of protection against these infectious diseases. First, we will discuss the COVID-19 vaccines, especially regarding vaccine, those people who are hesitant or who are against vaccines, who are anti-vaxxers, claim that and ask the question if these vaccines are effective or not. So these are two important graphs that I'm sharing with you now. Since the beginning of the pandemic, on the upper chart, you can see the newly confirmed cases in the United Kingdom or Turkey. The data of the United Kingdom is more reliable. That's why I wanted to add that graph as well. At the bottom chart, you can see the new deaths associated with COVID-19 infection in the same period. Why I'm showing this graph? Because you can see the number of the cases starting from the beginning of the COVID, and based on the highest peak of the wave, where there were more deaths, it covers the periods. I mean, this wave covers the periods of the last autumn last year. So 1 out of 1,000 people was infected, and 20 of them died. So this is the death curves. But as you may remember, vaccines were introduced and applied starting from the early 2021, and you can see the increased number of cases with Omicron. This is the daily new confirmed cases. But looking at the deaths, it is 3 or 4 in 1 million. So roughly, the mortality level or fatality of this virus decreased to 5 per 1,000 from 2%. So right after the vaccines were introduced, we didn't see any marked increase in deaths after the waves. So why we are discussing the booster doses? Because we had 2 doses, why do we need another dose, they ask. So you can see the level of antibodies after the vaccines in the blood. After the vaccination, roughly on day 10, the antibody levels reached the peak, maximum peak. But after that, as a natural course of immune system, in time, the antibody levels decrease. And depending on the age groups, there are variations in elderly cases, in older cases, immune system is weaker. For that reason, they reach lower peaks. Antibody levels reach lower peaks, and also there is a more significant decline in time in the antibody levels. So this is roughly month 3. After the month 3, the infection risk increases because antibody levels decrease markedly, according to the available data. This is one of the data available. This is from Israel. So in July and August, the number of the newly confirmed cases, and they checked when they were vaccinated. So in those who were vaccinated 3 months earlier, the infection risk is around 15 to 20 per 10,000. But if they were vaccinated in January, February, or March, which is 4, 5, and 6 months earlier, the infection risk was much higher, twice, almost 2 times higher risk persisted for them. So for that reason, as the time elapses after the vaccination, more than 3 months, the immunity created by vaccination decreases and infection risk increases. So this is another study. I'm sorry it's in English, but there are 2 important numbers here. You can see here those numbers. They compared non-booster group and booster group, and in fact there is an 11 times higher difference in terms of the infection risk. So the infection risk is 11 times lower in those booster group patients, and they have 20 times lower risk of getting severe illness if they have a booster dose. So we need booster dose. As I said, in Turkey, we have RNA and also BioNTech vaccines. So what about the other vaccines, such as CoronaVac or Inovac, which are the inactive vaccines that we use in daily life? What is the efficacy of these vaccines? I'm so sorry to say that, unfortunately, the ministry did not analyze the country data. For that reason, we have only limited data and information about the efficacy of this vaccine, but we have an important source of data from Malaysia. In the unvaccinated people, 47.5% of mortality was reported. But if they were vaccinated by BioNTech with mRNA, it is 43.2 times lower. But those who were vaccinated with CoronaVac or Sinovac, it is lower by 12.5 times. Actually, it decreases the risk of death, but compared to RNA vaccines, BioNTech, it has lower efficacy. Professor Abdullah, so in this case, after inactive vaccines, people were vaccinated by mRNA vaccines. We had 4 doses of vaccines. So antibody levels, as you say, decrease. Maybe the 5th dose, it is the time for 5th dose. So we need to get the 5th dose when the time comes. What do you say? Yes, that's right. Unfortunately, in time, the protective effect of the vaccine decreases gradually, as I highlighted before, starting from month 3, there is a significant reduction in the efficacy. So there are 2 sides of this point. The first one is it will be better for us to get another dose after month 3. But according to other studies, it has been revealed that as the time between the doses increases, the effect of the booster dose is stronger. For that reason, the the longer interval between the doses, the better effect the booster dose will have. So we are now under two different effects. So it seems it will be beneficial if we get the booster immediately after month 3, but as the time also, on the other hand, is delayed until the next dose, the effect of the booster is much higher. So if people are vulnerable, if they are older, and if they have multiple chronic diseases or immune suppression or immune compromise, that interval should be shortened. Maybe it will be more accurate to get that booster dose after month 3. But if mothers, fathers, grandmothers, grandfathers live together in the same household, they should be vaccinated by booster doses in shorter intervals. But apart from that, if they are at lower risk, if they have limited social relations, if their vulnerability is lower, then they can delay the next dose. They can wait until month 5 or 6, I think. So another question is, vaccines in the last 1 year, after the start of the pandemic, the vaccines were produced, and in early 2021, they were introduced across the whole world. So in short periods of time, they were prepared. There were different speculations stating that the vaccines will cause more harm than the benefit, according to some people's opinions. And are vaccines more dangerous or COVID-19 more dangerous? What do you say? Yeah, that's quite right question, as it is confusing for many people indeed. I'm sorry. Regarding this matter across the world, we have enough experience. And as you can see here, this is from Israel, from the database of Israel. What do we see here? The blue bars show compared to unvaccinated people, the increased risk of diseases or clinical conditions in unvaccinated people. So the orange bars show the increased risk in the people who were infected compared to those who were not infected. So look at the blue bars. The vaccinated people, in vaccinated people, 2 diseases were more incident consistently after the vaccination. So, for example, the enlargement of the lymph nodes. So, lymph nodes were enlarged after the vaccination in 78 people out of 1,000 people. According to the observations, it does not have any specifications. So it is just a reaction. Mainly in the armpit, lymph nodes are enlarged in just one or 2 weeks after the vaccination. So it does not cause any disease. So in 7 and 10 days on average, they disappear automatically or spontaneously. So there is nothing to fear about that. And we don't see any disease associated with the lymph nodes enlargement. So since December 2020, these vaccines have been applied, and almost 15 months have passed. In the long run, we did not observe any additional problems associated with these vaccines. And the other one is herpes zoster. In 16 out of 100,000 people, herpes zoster developed, and this is important. This has to be taken into consideration because associated with the vaccine, the protective cells of the immune system against herpes zoster become activated against COVID. Then they find a vacuum for themselves, and they can develop easily because due to another virus, this disease develops. But that's it. We don't see any significantly increased risk. But on the other hand, in association with the COVID-19 infection, if you look at the increased risks of the clinical conditions and diseases, for example, acute kidney injury, it was seen in 125 people out of 100,000. So arrhythmia in 166 people out of 100,000, and deep vein thrombosis in 43 out of 100,000 people, and also pulmonary embolism, 62 out of 100,000 people. None of them did not increase the risk after a vaccination, but the infection risk is much higher. The risk associated with infection is much higher. So embolism, AstraZeneca and Oxford's vaccine, which was not used in Turkey because another technology was used, and increased embolism risk was observed but it was perceived as if that was related with all the vaccines. You can see the cardiovascular diseases risk that develop after the infection. I'm not going over it one by one. So this is the odds ratio. So you can see the risk ratio here is it is 2 times or 4 times higher risk. It is defined for stroke risk, rhythm disorders, and arrhythmia, and also myocardial infarction, coronary vessel disease, and other vascular diseases, and pulmonary embolism. So you can see roughly 2.5 times higher risk after infection, not after the vaccine. So these risks are much higher after the infection compared to vaccination. So this is a little bit critical, but this shows that you can see the same disease risks after the COVID infection period, post-COVID infection period. The green ones are the ones who had mild COVID-19. Even in those mild cases, there is a slightly increased risk. It's like 10, 15, 20% higher risk, but the main risk is shown with the red ones. These are the ones that need to be hospitalized. So moderate infection cases. The purple ones are showing the cases, the most severe cases, most critical cases of COVID-19 infection. So there is around 5 to 10 times higher risk. So we can also refer to the importance of vaccines again. Vaccines, despite the vaccines, we may be infected, but against severe infection, they are still protective by around 85 to 90%. But if you have mild infection, the risk of cardiovascular diseases is quite limited, but in those severe cases of infection, these risks are much higher. So pregnancy is always an important concern, should they get vaccinated or not. But in pregnancy, any kind of pills and also medicines or vaccines may be dangerous. So in the first trimester, pregnant are not supposed to be using or taking any pills. So you can see lower risk. So miscarriage risk was analyzed in the United States. 105,000 pregnant women were included, and 13,000 miscarriages were analyzed. Compared to those unvaccinated and vaccinated, there isn't any significant risk between those groups in terms of miscarriage risk. So in early delivery and also low birth weight in baby, and also congenital anomalies, and also neonatal mortality risks did not increase in pregnant. So even in the first 3 months, in the first trimester, there is no problem in getting the vaccine. But of course, pregnancy is a risk factor for more severe form of the infection. For that reason, pregnants can also get vaccinated safely. Thank you very much, Abdullah Bey. In order to get rid of the pandemic, one of the most important ways is to do the vaccination regularly against COVID-19 across the world, equally under equal circumstances, and also other measures should be taken, should not be forgotten, as you highlighted in our presentation. Shall we talk about another vaccine, which is the influenza vaccine, flu vaccine? It is also used very frequently. What are the factors of the flu, and also what are the causes of the flu? Should we get flu vaccines, or who should get flu vaccines? As we all know, before COVID-19 came, flu was a problem for us. We used to get flu or flu-like upper respiratory tract infection at least once a year, and this also affected our daily lives, and we could not even fulfill our ordinary daily functions. That's why it's important. So in Turkey, we have national data, which is not so robust, but for influenza, we have very good surveillance data. This is data from Turkey. You can see the age groups of the people infected with influenza. But in school age, children, young people, and also actively working people who have more intense social lives, who have more human relations. As expected, it is more prevalent, but most likely school-age children are contracted with influenza. In the severe infection, as regards to age groups, we have a different curve. In the first 4 years of life, it is most incident, and then after the age of 50, it is more prevalent. So these groups are more vulnerable groups, and the disease is more severe in these age groups. For that reason, after the 6 months of age, children younger than 6 years of age, and also in advanced ages, the limit may be or highlighted as 65, but as you can see, the risk starts increasing starting from the age of 50. For that reason, those people in these age groups should be vaccinated, because they are they are getting more severe form of the disease. Another risk group is people with comorbidities or chronic diseases. People who do not have any other morbidities. Due to influenza, the mortality risk is considered as 1, assumed to be 1, we determined as 1. Chronic liver disease and the mortality risk associated with flu is 48 times higher. And also those who have chronic neurological diseases with a history of stroke in the past, or Parkinsonism or other neurological diseases, chronic kidney failure have 20 times higher risk of mortality, and chronic cardiac disease patients have a 10 times higher risk of mortality, and also chronic pulmonary diseases have a higher risk of 7 times of mortality. Those immune compromised or immune suppressed or vulnerable patients should be vaccinated against influenza. You know, the flu season starts in November and extends up to April, covering including March as well. So can we get the flu vaccine any time of the year, or is it much better just before the disease season? This is quite important. This is data from the Ministry of Health, Turkish Ministry of Health. This pertains to this year. The flu activity started on week 46, roughly in mid-November. It was not observed in the previous period because the influenza season starts by the end of November. Then the activity increases very rapidly, and most likely it increased in mid-January. It is still monitored, and this is the available data so far. For that reason, if possible, right before or 15 days or 20 days before the influenza season, it is ideal to get the influenza vaccine. It may be in October or early November. It will be ideal, because starting from the end of November, we expect the activity of influenza infection to start. It may be in December, mid-December or late December, but roughly it is applicable to most of the years. But the influenza season extends till the mid and sometimes end of April. So if they are not vaccinated in October for any reason, especially those who are at higher risk, whenever they have the opportunity, it may be December, January, or February, it is recommended for them to get vaccinated against influenza. After the vaccine is applied, antibody is developed roughly in 15 days. So it's not a problem to get vaccinated in February, because that influenza season extends at least till mid-April. So, you know, influenza or flu manifests with the symptoms of upper respiratory tract system. There's fever, and also dry cough, headache, and also myalgia or throat pain. Rhinovirus, RSV, and other viruses may also lead to these, or respiratory viruses may lead to very similar clinical pictures. For that reason, it's not always, it may not always be possible or accurate to diagnose people with influenza. So it is called as influenza-like diseases. In order to make a differential diagnosis, we need to get a nose swab. And this is data from Turkish Ministry of Health again. Starting from the second half of November, you can see different colors, especially other seasonal coronaviruses, rhinovirus, RSV, also are in circulation. It means that when a respiratory system infection develops, it may be related to coronavirus and COVID-19. It may also be associated with influenza, flu, or other seasonal viruses. So it is unfortunately not that possible to differentiate between the two with the clinical picture. To what extent the influenza vaccines are effective? Maybe we should ask another question. So this year I got my influenza vaccine. I got infected with influenza, people may claim, because the only cause is not the influenza virus. There are other viruses, as I highlighted before. For that reason, at least we should get the vaccination which we have at our hands against influenza, but against other viruses, we do not have any other vaccine. We have a vaccine against COVID-19, but for the other viruses, we don't have a vaccine. To what extent the influenza vaccines are effective? There are 116 studies, including more than 70,000 individuals. So this is a summary of that study on article. In the unvaccinated individuals, the incidence of influenza-like disease is 15 and 16%. But in the vaccinated ones, that incidence is 9.9%. So it's half by half. So or around 30% of reduction of infections if you get vaccinated, because influenza-like diseases include other viruses for which we do not have any vaccines. And to what extent these vaccines are effective? Can the pregnant women be vaccinated because influenza may be more severe in pregnant women? There are several studies. Each row refers to a different study. You can see the number of individuals in each study in this column, and vaccinated and unvaccinated people were compared. So they have a very high scientific level. In the first trimester, if the pregnant women are vaccinated, there is no increase in the risk of miscarriage, and in the babies of these pregnant women, there isn't any increased risk of congenital anomalies if they are vaccinated in the first trimester, or in the first trimester, or in any trimester of their pregnancies. Women can get vaccinated safely. And thank you very much, Abdullah Bey, for pulmonary health. Can you please talk about the pneumococcus vaccines very briefly, because they are very important and we have limited time. Pneumococcus vaccines are known as pneumonia vaccines in the public, so they are not protecting against all the pneumonias. Pneumococcus is the bacterium that leads to pneumonia most frequently. So this is only prevented by this vaccine. So in elderly and also people with chronic diseases, pneumococcus infections are more prevalent. Immune suppressed individuals and people with hematological problems, they have higher risks of pneumococcus infections. So those patients are recommended to be vaccinated against pneumococcus. Pneumococcus, depending on the pneumococcus, pneumonia can be prevented by 46%. But if there is severe pneumonia, when the microbe is circulating in the blood, the risk of pneumonia can be declined by 45%, and the efficacy for the severe cases is 75%. Thank you very much, Professor. Very quickly, if you like, I just would like to talk about two pneumococcus vaccines. The first one is effective against 13 types, and it is protective for lifelong, and the other one is protective against 23 species, and it is effective for 5 years. And the Ministry of Health provides this pneumococcus vaccine, which is protective for lifelong, free of charge at the family medicine centers. For that reason, not only for that, but this is effective for lifelong. First, this is recommended, and if possible, if the other vaccines can be bought from the pharmacist, maybe in 6 or 12 months, the other vaccine is recommended to be taken as a complementary vaccine. We are so lucky that we have COVID-19, influenza, and pneumococcus pneumonia vaccines, which are provided free of charge by the Ministry of Health. It can be applied to people who may need them. Thank you very much for the information you share with us. We don't have any questions, so I'll adjourn with this session now. Thank you very much for your attendance. Thanks a lot. Have healthy days.
Herkese merhaba, ben Doktor Yasemin Gökdemir, Türk Toraks Derneği Çocuk Göğüs Hastalıkları Çalışma Grubu Başkanıyım. Bu yıl Türk Toraks Derneği 26-27 Şubat tarihlerinde halk için akciğer hastalıkları ve COVID-19 kongresi düzenledi. Biz de çalışma grubu olarak çocuklarda COVID-19 seyrini anlatacağız. Yeni varyant omikron çocuklarda nasıl seyrediyor ve çocuklarımızı COVID-19'dan nasıl koruruz ayrıntılı tartışacağız. Sizleri de bekleriz. Herkese merhaba, ben Doktor Yasemin Gökdemir, Türk Toraks Derneği Çocuk Göğüs Hastalıkları Çalışma Grubu Başkanıyım. Bu yıl Türk Toraks Derneği 26-27 Şubat tarihlerinde halk için akciğer hastalıkları ve COVID-19 kongresi düzenledi. Biz de çalışma grubu olarak çocuklarda COVID-19 seyrini anlatacağız. Yeni varyant omikron çocuklarda nasıl seyrediyor ve çocuklarımızı COVID-19'dan nasıl koruruz ayrıntılı tartışacağız. Sizleri de bekleriz.
Hello, I am Dr. Yasemin Gökdemir from Marmara University Pediatric Chest Diseases Department. I'm a lecturer in that department. I am also a member of the Turkish Thoracic Society and head of the Pediatric Chest Diseases Working Group. Since the early days of the COVID-19 pandemic, we have seen many pediatric patients, whether inpatient or outpatient, and we still many of these patients. During last 1 month, the pediatric COVID-19 patients increased in number significantly. Today, I have a guest, Associate Professor Nagihan Emir Adeoğlu. Now, we will try to inform you about the prognosis of COVID-19 in children. She is a member of Hacettepe University Medical School, and we are working together with her in the Pediatric Chest Diseases Working Group of our society. Now, dear Nagihan, I'd like to ask you kindly to inform us about the prognosis of COVID-19 in the pediatric patients, and is there any change? Thank you. The available data so far, in fact, shows that children of any age, including infants, can be infected, can spread the virus, and the children can even get infected heavily and can have a very heavy course of the disease. Recently, the Omicron variant is the dominating one, and with this new development, we have seen an increase in the Omicron cases in pediatric patients, and there are more hospitalized patients with the Omicron. In fact, in the past for a while, the transmission capability of the virus was less, but now with the Omicron variant being the dominant one in the pediatric patients and adults, we see this increased hospitalization rate for the pediatric patients as well. So the hospitalization in general, but hospitalization in the ICUs, in fact, these are different, especially for the children less than 10 years of age are hospitalized more, not changing the ICU hospitalization rate. Maybe these impacts come with the vaccination. How can we distinguish the symptoms? You know, in some seasons, the symptoms can be easily mistaken for streptococci or COVID-19 and many other viruses. How can we distinguish them? Yes, you're right. In these months, and especially in spring, there's an increase in other viruses as well. The COVID-19 have certain symptoms in pediatric patients: high fever, coughing, sore throat, running nose, blocked nose, headache, myalgia, arthralgia, and rarely vomiting and diarrhea. These these come with the COVID-19 alone, or there may be some accompanying viruses as well. So these children should be given both the COVID-19 test, and if necessary, the children should also be checked for other viruses. It doesn't mean that test every child for all the viruses, no. But if these are the symptoms that you can see in a child, then please prioritize all these options. 1 month after COVID, there is the multi-system inflammatory syndrome, and that is quite scary. Would you please also inform us about the course of that, and is the incidence changed with the Omicron variant? Would you please inform us about that too? At the onset of the pandemic in May 2020, we would see some prolonged and persistent fever in children, and something just like Kawasaki syndrome would also appear in children. And we understood that the clinical picture was heavier than, because after COVID-19, in 2 or 6 weeks, the children would be suffering from some persistent fever longer than 72 hours, rashes, and also involvement of different organs, including particularly the heart, respiratory system, gastrointestinal system, kidneys. So some findings related to these organs would also be included in the clinical picture, and some blood parameters would also change and be added to the picture, and some of the findings very heavy, and then it was called multi-inflammatory response syndrome. It is very specific because first there should be the history of COVID-19 infection, or at least there should be the contact, and even if we don't know the history, at least in the blood, the antibodies, associated antibodies have to be identified. Once the diagnosis is made, it would be necessary to respond very quickly to treat the case. In fact, that is the most scary or the heaviest impact of the virus. It would be very important to diagnose this very early. So for children younger than 3, if you see such symptoms, please, physicians, be careful. But in Marmara University, maybe in also your university, we have not seen in the number of these syndrome cases. Probably it is because that there is not much inflammatory response in the Okay, would you also talk about the home treatment and also what do we do at the hospitals? Yes, the course of COVID-19 varies from one child to another. We know 40% of children, in fact, go without any findings, but in some children you can see some mild symptoms. Sometimes the symptoms just look like an upper respiratory syndrome. Please be careful with isolation at home, and we just offer support and supplement treatments, vitamins, a lot of liquid, self-isolation. These are the recommendations. However, there's also a group of patients in whom the prognosis of the disease is quite severe. In children, this is a smaller group. In some children, there will be a need for oxygen support and respiratory support. For children, in fact, at least for children, there is no recommended antiviral treatment for this virus. Sometimes, depending on the physician's judgment, an antiviral can be suggested, but you know that will be very specific. Yes, it's about the risk groups also. Would you also inform us about the risk groups in children? Yes, that's a very important question. Thank you. In the adults, the group with the underlying conditions will get infected more heavily. in children, especially in babies younger than 1 year of age, the prognosis can be very severe. If there is also any underlying condition, just like obesity, any metabolic diseases, chronic pulmonary diseases, cardiac diseases, or any type of other cardiac diseases, some genetic syndromes, any immune system deficiency, in oncology and pathology patients, we have seen that the symptoms would be felt more. 60% of the ICU patients, in fact, have an underlying chronic condition. That is an important piece of information for us. If you have an underlying condition, you should be very careful with the protective measures and vaccination. Well, thank you very much. In Marmara University, we also have our own experience. Children with any underlying condition will go through this disease more severely, and even if there is no underlying disease, obesity will still be an important risk factor according to our findings. Yes, we love and caress and always try to favor children, but please be careful with obesity in this regard. Then, next question, how should we protect our children? Yes, I guess that is the most important aspect, protecting the children. And in many platforms, we have this discussion. First, we suggest and recommend vaccination in order to protect children. And I know the recommendation of the Turkish Thoracic Society is aligned with mine. According to the ministry's directions, we offer routine practice for children about the age of 12. In the US and many other countries, they started giving the vaccination to the age group from 5 to 11. And at young ages, they have seen that the side effects are even lighter. It is also important to wear the mask. Both the mouth and the nose need to be closed with an appropriately constructed mask for the face structure. It's also important to isolate the sick children. If you see any mild symptoms in children, for example, any symptom that can be easily associated with the upper respiratory tract syndromes, please do not send your children to school in that case on that day. Be careful with the crowded activities. They're not suggested nowadays. And these are the commonly recommended protection measures. Also, please take into consideration the distancing measures. At schools, everyone should be careful about distancing. And also, the children should be careful with the hand hygiene. Thank you. Vaccination in protection. And people are always concerned about giving the vaccine to their children because they are very afraid of getting the appointment for the children. What can you say about the vaccination of kids? Well, thank you. Yes, at the beginning, we were worried about giving the vaccine to the children. However, according to the studies, of course, they just have very short-term results right now. But currently, we vaccinate. We recommend vaccination of children over the age of 12. Maybe this practice will change and the age limit can be reduced down to 5. We don't know. Currently, the age threshold starts from 12 years. In the adults, 1 to 3 years after, 1 to 3 days after the vaccination, fever, myalgia can be seen in adults, but these are temporary side effects. And after 5 minutes from the vaccination, you should watch the kid for any allergic reaction that may happen both in adults and in children. Have a prognosis multi-inflammatory reaction syndrome is prevented by the vaccine. The transmission risk to other children is reduced by the vaccine, and also it contributes to protection of other family members in the same household. That is why we recommend that children should be vaccinated. They should get their vaccines. And there are certain changes in the implementation of vaccines. We know currently we're giving the vaccine to children over the age of 12 with an time interval of 3 weeks. And the booster doses are also recommended to children over the age of 12 in 3 months. In our country, we don't give the vaccination to children aged 5 to 11, but do they give the same doses? Is it the same vaccine? Is it the same way of administration? Do you have any information? In the group of children from 5 to 11, there will be more studies. The results of the studies have also started to come. And some nice efficacy is being reported, something like 97%. And in fact, for this age group, there is no booster dose. The other doses are the same, but abroad, there are some countries that recommend the booster dose for the children, but the dose is reduced compared to the dose that is given to the adults. After COVID-19, we know that there are some persistent symptoms in adults, lethargy, and some others. But do we see those prolonged symptoms in children? In children, the incidence of COVID-19 increased. So in children, we also see this increase, and the symptoms are ongoing, especially in the first couple of months: coughing, lethargy, sleeplessness, pain in the joints and the muscles, sometimes shortness of breath. It can be seen in a major part of children. These symptoms continue for 2 months. In a smaller group, we see those symptoms continue up to 6 months. So these symptoms can continue up to 6 months, just like in the adults. For the first 2 months, the symptoms can be heavier, but later they will be lighter. Of course, the parents feel worried. They can go and see their physicians, and necessary examinations can be made. There may be certain other effects after the COVID-19, but just like in the case of adults, these symptoms may be prolonged up to 6 months. But then we see how important vaccination is, because when there's vaccination, the children happen to become asymptomatic, or they encounter the symptoms very lightly. And that's all. Thank you.
Herkese merhaba. Ben Doktor Banu Salepçi, Türk Toraks Derneği Tütün Kontrol Çalışma Grubu Başkanıyım. 26-27 Şubat 2022 tarihinde Türk Toraks Derneği'nin Halk için Akciğer Hastalıkları ve COVID-19 isimli bir kongresi olacaktır. Bu kongrede tütün kontrol grubuna ait 2 tane oturum planlanmıştır. Birinci oturumda sigarayı bırakamıyorum, iradesiz miyim başlığı altında nikotin bağımlılığının tedavisi, sigara bırakma yöntemleri konuşulacak. İkinci oturumumuz ise elektronik sigara başlığı altında elektronik sigaranın zararları ve elektronik sigaranın aslında tütün endüstrisinin bambaşka bir yüzü olduğunun tartışılacağı bir oturum olacaktır. Sizleri oturumlarımıza davet eder, aramızda görmekten çok mutlu olacağımızı bildiririm. Teşekkür ederim.
Bırakmayı çok istiyorum ama
bunu bırakalı 12 yıl oldu. Bırakmak istediğim dönemde
Kendime bir takım sorular sordum. Son yıllarda özellikle çok fazla sağlık problemleri yaşamaya başlamıştım çünkü. Niye bırakamıyorsun veya niye erteliyorsun bırakmayı diye.
Nikotin bağımlılığı nasıl bir bağımlılıktır? Nikotin bağımlılığı biyolojik, psikolojik, sosyal yönleri olan çok güçlü bir bağımlılık şeklidir.
Arkadaş sohbetlerinde, dostlarla yemekte, çay içerken, kahve içerken, sevincimde, üzüntümde, hep beynimde sanki eşleştirmişim sigara içmeyi bu aktiviteleri yaparken veya bunları yaşarken. Oysa ki benim bedenimi, sağlığımı, ruhumu, cebimdeki parayı eline alan bir ahtapot gibi bir düşmanla beraber yaşamışım. Ve bir de sonunda şunu öğrendim ki ben hasta olunca nasıl olsa bunu bırakacağım, hiç olmazsa sağlığımda bırakayım dedim. Benim buradaki tek kazancım yeni bir sayfa açmışım. Yürüyorum, koşuyorum, her türlü aktiviteyi yapıyorum, tatile gidebiliyorum. Cebimde para var. Bunlar çok önemli şeyler. Şimdiki aklım olsaydı eğer, hiç içmezdim. İçmeye başladıysam da keşke çok daha önce bıraksaydım diyebilirdim. Son pişmanlığım budur. Şu anda harika hissediyorum kendimi.
Nikotin bağımlılığından kurtulmak ister misiniz?
Merhaba, 29 yıl içmişim. Ekonomik olarak da çok büyük kayıp. Sosyal hayatımdan da kaybettim ve ben istedim. Hasta olmadan bıraktım, ben başardım. Şimdi 11 yıl oldu. 11 yılda ekonomiyi yeniden kazandım. Çok mutluyum ve sonsuz güven taşıyorum kendime. Motosiklet aldım. Sigara parasıyla motosiklet aldım. Benzin koyuyorum içerisine ve biz geziyoruz. Biz daha özgür yaşıyoruz. Çok mutluyum.
Sigara bırakma yardımı alan ve bu bağımlılıktan kurtuldukları için çok mutlu olan eski nikotin bağımlısı bir çifti izlediniz. Onlar başardılar. Siz de başarabilirsiniz. Bağımlılığınızı tanımak ve yardım almak başarı şansınızı arttıracaktır. Gelin, Türk Toraks Derneği'nin sizler için hazırladığı halk kongresinde nikotin bağımlılığını masaya yatıralım, sigarayı bırakabilmeniz için bir yol haritası oluşturalım. Ne dersiniz? 26 Şubat 2022 saat 13.30'da Türk Toraks Derneği'nin tüm sosyal medya hesaplarında buluşalım. Siz sorun, biz cevaplayalım. Bekliyoruz. Sağlığınız için.
Herkese merhaba. Ben Doktor Banu Salepçi, Türk Toraks Derneği Tütün Kontrol Çalışma Grubu Başkanıyım. 26-27 Şubat 2022 tarihinde Türk Toraks Derneği'nin Halk için Akciğer Hastalıkları ve COVID-19 isimli bir kongresi olacaktır. Bu kongrede tütün kontrol grubuna ait 2 tane oturum planlanmıştır. Birinci oturumda sigarayı bırakamıyorum, iradesiz miyim başlığı altında nikotin bağımlılığının tedavisi, sigara bırakma yöntemleri konuşulacak. İkinci oturumumuz ise elektronik sigara başlığı altında elektronik sigaranın zararları ve elektronik sigaranın aslında tütün endüstrisinin bambaşka bir yüzü olduğunun tartışılacağı bir oturum olacaktır. Sizleri oturumlarımıza davet eder, aramızda görmekten çok mutlu olacağımızı bildiririm. Teşekkür ederim.
Bırakmayı çok istiyorum ama başaramıyorum. İradesiz miyim acaba? Hayır, iradesiz değil. Sadece bağımlısınız.
Ben emekli öğretmenim. 30 yıl bir fil sigara içtim. Ama bunu bırakalı 12 yıl oldu. Bırakmak istediğim dönemde kendime bir takım sorular sordum. Son yıllarda özellikle çok fazla sağlık problemleri yaşamaya başlamıştım çünkü. Niye bırakamıyorsun veya niye erteliyorsun bırakmayı diye.
Nikotin bağımlılığı nasıl bir bağımlılıktır? Nikotin bağımlılığı biyolojik, psikolojik, sosyal yönleri olan çok güçlü bir bağımlılık şeklidir.
Arkadaş sohbetlerinde, dostlarla yemekte, çay içerken, kahve içerken, sevincimde, üzüntümde, hep beynimde sanki eşleştirmişim sigara içmeyi bu aktiviteleri yaparken veya bunları yaşarken. Oysa ki benim bedenimi, sağlığımı, ruhumu, cebimdeki parayı
eline alan bir ahtapot gibi bir düşmanla beraber yaşamışım. Ve bir de sonunda şunu öğrendim ki ben hasta olunca nasıl olsa bunu bırakacağım. Hiç olmazsa sağlığımda bırakayım dedim. Benim buradaki tek kazancım yeni bir sayfa açmışım. Yürüyorum, koşuyorum. Her türlü aktiviteyi yapıyorum. Tatile gidebiliyorum. Cebimde para var. Bunlar çok önemli şeyler. Şimdiki aklım olsaydı eğer hiç içmezdim. İçmeye başladıysam da keşke çok daha önce bıraksaydım diyebilirdim. Son pişmanlığım budur. Şu anda harika hissediyorum kendimi.
Nikotin bağımlılığından kurtulmak ister misiniz?
Merhaba, 29 yıl içmişim. Ekonomik olarak da çok büyük kayıp. Sosyal hayatımdan da kaybettim ve ben istedim. Hasta olmadan bıraktım, ben başardım. Şimdi 11 yıl oldu. 11 yılda ekonomiyi yeniden kazandım. Çok mutluyum ve sonsuz güven taşıyorum kendime. Motosiklet aldım. Sigara parasıyla motosiklet aldım. Benzin koyuyorum içerisine ve biz geziyoruz. Biz daha özgür yaşıyoruz. Çok mutluyum.
Sigara bırakma yardımı alan ve bu bağımlılıktan kurtuldukları için çok mutlu olan eski nikotin bağımlısı bir çifti izlediniz. Onlar başardılar. Siz de başarabilirsiniz. Bağımlılığınızı tanımak ve yardım almak başarı şansınızı arttıracaktır. Gelin, Türk Toraks Derneği'nin sizler için hazırladığı halk kongresinde nikotin bağımlılığını masaya yatıralım, sigarayı bırakabilmeniz için bir yol haritası oluşturalım. Ne dersiniz? 26 Şubat 2022 saat 13.30'da Türk Toraks Derneği'nin tüm sosyal medya hesaplarında buluşalım. Siz sorun, biz cevaplayalım. Bekliyoruz. Sağlığınız için.
Herkese merhaba. Ben Doktor Banu Salepçi, Türk Toraks Derneği Tütün Kontrol Çalışma Grubu Başkanıyım. 26-27 Şubat 2022 tarihinde Türk Toraks Derneği'nin Halk için Akciğer Hastalıkları ve COVID-19 isimli bir kongresi olacaktır. Bu kongrede tütün kontrol grubuna ait 2 tane oturum planlanmıştır. Birinci oturumda sigarayı bırakamıyorum, iradesiz miyim başlığı altında nikotin bağımlılığının tedavisi, sigara bırakma yöntemleri konuşulacak. İkinci oturumumuz ise elektronik sigara başlığı altında elektronik sigaranın zararları ve elektronik sigaranın aslında tütün endüstrisinin bambaşka bir yüzü olduğunun tartışılacağı bir oturum olacaktır. Sizleri oturumlarımıza davet eder, aramızda görmekten çok mutlu olacağımızı bildiririm. Teşekkür ederim.
Bırakmayı çok istiyorum ama başaramıyorum. İradesiz miyim acaba? Hayır, iradesiz değil. Sadece bağımlısınız.
Ben emekli öğretmenim. 30 yıl bir fil sigara içtim. Ama bunu bırakalı 12 yıl oldu. Bırakmak istediğim dönemde kendime bir takım sorular sordum. Son yıllarda özellikle çok fazla sağlık problemleri yaşamaya başlamıştım çünkü. Niye bırakamıyorsun veya niye erteliyorsun bırakmayı diye.
Nikotin bağımlılığı nasıl bir bağımlılıktır? Nikotin bağımlılığı biyolojik, psikolojik, sosyal yönleri olan çok güçlü bir bağımlılık şeklidir.
Arkadaş sohbetlerinde, dostlarla yemekte, çay içerken, kahve içerken, sevincimde, üzüntümde, hep beynimde sanki eşleştirmişim sigara içmeyi bu aktiviteleri yaparken veya bunları yaşarken. Oysa ki benim bedenimi, sağlığımı, ruhumu, cebimdeki parayı eline alan bir ahtapot gibi bir düşmanla beraber yaşamışım. Ve bir de sonunda şunu öğrendim ki ben hasta olunca nasıl olsa bunu bırakacağım. Hiç olmazsa sağlığımda bırakayım dedim. Benim buradaki tek kazancım yeni bir sayfa açmışım. Yürüyorum, koşuyorum. Her türlü aktiviteyi yapıyorum. Tatile gidebiliyorum. Cebimde para var. Bunlar çok önemli şeyler. Şimdiki aklım olsaydı eğer hiç içmezdim. İçmeye başladıysam da keşke çok daha önce bıraksaydım diyebilirdim. Son pişmanlığım budur. Şu anda harika hissediyorum kendimi.
Nikotin bağımlılığından kurtulmak ister misiniz?
Merhaba, 29 yıl içmişim. Ekonomik olarak da çok büyük kayıp. Sosyal hayatımdan da kaybettim ve ben istedim. Hasta olmadan bıraktım, ben başardım. Şimdi 11 yıl oldu. 11 yılda ekonomiyi yeniden kazandım. Çok mutluyum ve sonsuz güven taşıyorum kendime. Motosiklet aldım. Sigara parasıyla motosiklet aldım. Benzin koyuyorum içerisine ve biz geziyoruz. Biz daha özgür yaşıyoruz. Çok mutluyum.
Sigara bırakma yardımı alan ve bu bağımlılıktan kurtuldukları için çok mutlu olan eski nikotin bağımlısı bir çifti izlediniz. Onlar başardılar. Siz de başarabilirsiniz. Bağımlılığınızı tanımak ve yardım almak başarı şansınızı arttıracaktır. Gelin, Türk Toraks Derneği'nin sizler için hazırladığı halk kongresinde nikotin bağımlılığını masaya yatıralım, sigarayı bırakabilmeniz için bir yol haritası oluşturalım. Ne dersiniz? 26 Şubat 2022 saat 13.30'da Türk Toraks Derneği'nin tüm sosyal medya hesaplarında buluşalım. Siz sorun, biz cevaplayalım. Bekliyoruz. Sağlığınız için. Saygıdeğer ve sevgili izleyicilerimiz, sigarayı bırakamıyorum, iradesizim konulu
Participants, dear viewers, welcome to our session titled I'm Unable to Quit Smoking. Am I frail? And in this session, I, as Seren Arpas, MD, I'm going to host Professor Dr. Oğuz Kılınç. In fact, Mr. Oğuz Kılınç is a professor in the chest diseases department. He's also in charge of the smoking quitting outpatient clinic. Every year, 8.5 million people die because of smoking. We also know that one of every two smokers, in fact, will lose their lives because of a reason, a cause that is associated with smoking. And there are still more than 70 million active smokers in our country as well. This is a very common public health problem. Today we're going to talk about this problem. What kind of addiction is tobacco addiction? What can we do in order to get rid of this addiction? What are the challenges to be coped with in this process? How we can deal with these challenges? What kind of assistance can we get? And who are the authorities providing this assistance? These will be the questions that we will be answering today. In the second part of this session, we're going to get and try to answer your questions. Please send away your questions. So, Professor Oğuz Kılınç, I'd like to start with a question. So when a smoker hears a lot of upsetting sentences from the people in his or her vicinity, what can we say about these and what are the examples? Yes, thank you. These are the sentences that the smoker is fed up with hearing. They say, okay, you know the damages and the harms. Why do you continue smoking? So just finish it in your brain and throw away the package. So some people can quit, and why can you not? Don't you appreciate your life? Are you frail? You have succeeded a lot of things, and why can you not succeed this? All these sentences are very commonly told to a smoker, but in fact, these sentences do not work, although they are coming from mouths with goodwill. In fact, this is pushing the smokers to smoke more. Then how can you define smoking? Smoking is no more a social behavior. It's not something that you can quit whenever you want. This is not a simple behavior. It is a disease. It is treatable. Just like in the case of other disease, you may get some treatment from a medical physician, just like in the case of tuberculosis, asthma, COPD, hypertension, and diabetes. You can easily get assistance from a physician if you would like to treat this disease. As you said, there are 17 million people who got this disease, I mean the smoking disease. In fact, addiction It's like a triangle. It has three pillars. So there is a mechanism in the brain that is in action. It has a psychological aspect, neurochemical aspect, and a behavioral aspect. So when we are treating these patients, we try to control all three aspects. This is how we handcuff smoking habit, and this is how we can help a patient stop smoking. I said there's a popular sentence, just finish it in your brain, but why does it not work and help the smokers? Because there are some obstacles in the brain, because people smoke while knowing that there are damages associated with smoking, but they think that their way of smoking is not going to harm them. For example, they say that I'm not going to smoke when I am hungry. It's just my lips that are smoking. I use filters. I use some light cigarettes. And also they say that I can do sports. I know some people who get cancers without smoking, but we now know that it is not possible that you use a tobacco product and you go without any harm. So any dose that you get into your body is going to damage your body. And also, people try to get rid of this disease, but they really get some strong reactions from the body. And then they get annoyed, they lose their concentration, they crave for smoking, their life turns upside down, and then they think, okay, I'll smoke one more, and then everything turns back to the beginning. And sometimes they cannot cope with the physical symptoms, sores in the mouth, etc., and constipation, overweight, and then they fail. And when they fail, they get the fear of being stigmatized. So they think they're not going to a battle that they are going to lose. For all these reasons, they cannot finish this business in their brain. With all these taken into consideration, isn't it unfair to tell the smokers that they should finish it in brains? Think about a diabetes patient or a blood pressure or hypertensive patient. Can they really use their brain in order to reduce their sugar level or the blood pressure level? No. You see, this is the brain, and this is the primitive brain zone. It works with goodwill. It works without the conscious will. It is aiming at protecting the body. For example, when your body is hungry, it warns the body. It tells you, okay, you're hungry, go and eat something. If you are thirsty, because you will lose your kidneys due to lack of water, it gives you a signal to go and drink some water. If you are sleepless, it is going to warn you to go to bed to sleep. And when you satisfy this need, you are awarded by the center of the brain. For example, when you eat something, when you drink some water, when you sleep, then you will be pleased. This is a mechanism, and nicotine enters into and introduced into this mechanism. It misleads. It's just like a virus. Eating, drinking water, and sleeping gives you pleasure, and nicotine does the same thing. And heroin, cocaine, in fact, are doing the same effect on this mechanism. So the nicotine is a product, but it's a legally sold drug, as we deem it, because it misleads your brain. It thinks that all these signals, in fact, are sincere and candid bodily symptoms. When you are deprived of nicotine, you encounter certain symptoms, just like you feel dizzy, you lose your sleep, you get weaker concentration. And in 9 out of 10 smokers, these symptoms are at a controllable severity. You know, we use medication in order to treat many diseases, just like the blood pressure, diabetes, etc. And in fact, there are some medications that we can use and we should use in order to treat the smoking habit in 9 out of can smokers? I have a question. A smoker may easily say that, okay, you are going to medicate me, but it can also do some harm to me. Well, in the first session, there was a presentation delivered by Mr. Abdullah Sayner, and he talked about vaccines, and he told that there are certain rumors regarding the potential side effects of the vaccines, but so far we have not seen any killing effects or disabling effects. In that case, no Ministry of Health would allow or permit the use of vaccines. That was the case for the vaccines and the COVID-19. Now we can make the same analogy here. Smoking, in fact, is 1,000 times more dangerous compared to these medications, but these are not killing you. These are not going to disable you. Okay, controlling the brain mechanism itself and alone, would it be enough? I always make this analogy. Just give the diabetic medications to a diabetes patient and then set him or her free, and that person will be free to continue his life in the way sure he wants. Would we be successful? No. No, we wouldn't, because think about a diabetic patient or a hypertensive patient. If a hypertensive patient continues eating and getting salt, or a diabetic patient that continues getting sugar, will never be successful, will never be able to continue his life, because at one point you have to distinguish your friends and your foes, your enemies. So a foe, an animal, is a killer that is waiting for the right time to kill you. Any person who smokes just one cigarette a day, in fact, is accepted as a smoker. In the male gender, a smoker, even at such level, may have a different long age. 28 years in the male and plus 23 years in the female. So if you are 30 years old, if you smoke one cigarette a day, and if you are male, then your lung age, your pulmonary age will be 58. So please distinguish your friends and foes. They know this, maybe they know this, but they continue smoking because smoking gives them pleasure and satisfaction. And when they are not smoking, they encounter some negative emotions. And they believe that when they are challenged, smoking helps them. So they disregard the damages and they continue smoking. Think about your friends and think that you are separated from your friend. You are separated from a very beloved friend just because your doctor or your family member says that you should be separated. That will not be very helpful. But if you think that entity is an enemy, then you will have different feelings. You will be happy, you will be relieved, you will have peaceful mind, and you will try to avoid some repetitive cases which may push you to smoking. Just like a student that is relieved after passing an exam, or just like an adult who feels relieved after paying a huge debt. This is how you should treat smoking. When you think in this way, if you're a smoker, then the rest will be helped with by your physician. Just like you are getting divorced and your lawyer will be your MD. There's also the behavior aspect. So if you would like to control a brain mechanism, then the medication should be continued for at least 3 months. Sometimes during the first 15 days, people feel very good and then they think they have done it, but no. The brain mechanism can easily be restored. You should continue for 3 months. And also you should take away the related objects from your environment. The lighters and the cigarettes should not be around you. And brushing the teeth right after eating, and drinking water. That will be helpful to you, because if you brush your teeth, if you drink some water, if you keep the mouth clean, then the nicotine will not be traveling easily to the brain. And you can take some measures in order to control your hand-to-mouth habits. And also, you shouldn't be into the environments where you are habituated to smoking, and you should keep away from high-calorie food. Then you can easily get rid of this disease. Well, in fact, we're always talking about cigarettes, but that name covers all the tobacco products. Would you also give some remarks about this? Yes, a cigarette is just like a brand name, but here are some visuals that are related to different tobacco products. This is always the same killer in a different outfit. Electronic cigarettes, and also the new toy of the tobacco industry, the new killer in a modern outfit, the heated tobacco products. None of them is different. Some of them are strangling you, some of them is pushing you from height, some of them is throwing you into water, some of them are smiling at you, but stabbing you in the back. These are all killers, and no one of them can make less damage than the others. There will be some other sessions tomorrow. You will hear more details of these different products in that session. Okay, I understand that all these tobacco products are very dangerous, and these are freely sold, but who are manufacturing them, who are selling them, or who are helping the spread of this habit? There are international tobacco cartels. In fact, they earn $50 billion annually thanks to the smokers. And unfortunately, all these sales are legal, and the governments enact the legislation to legitimize this drug. But this shouldn't be legal, because there is no other commercial commodity that can kill the user, even if it is used in line with the recommendations of the manufacturer. No other substance is allowed to be used and consumed in this way. You see, indirectly, the states, the governments are also helping this industry. Ours is a battle, but we never favor the idea of a battle. A battle is always against public health. Because of the Ukraine-Russian crisis, we say no to war, but our battle and war against the tobacco industry will be endless. Okay, very briefly, would you please summarize what we should do? Okay, what should we do? Smoking and the tobacco products, in fact, can make you sick. This should be deemed as drugs. First, you should acknowledge this, and then you should have a regulated therapy, and you should get professional help. So nicotine stops, acupuncture, bioresonance, and other methods should be avoided. Please seek scientific therapy. And you can easily have to take a break, or you can easily get deviated. Please don't be afraid. Continue on the same way. And we should ask the decision makers to put a ban on all tobacco products. If the tobacco producers will be categorized in the same group as opium producers or heroin producers, then we will provide some better protection for our children and youth. Thank you. Thank you for enlightening all of us and also our patients. Now, in the Q&A session, I would like to ask this first question. There are some common questions coming from the patients. I also worked as a person in charge of smoking quitting outpatient clinic. I know the questions. The first question is normally as follows. They say, okay, I decide I should quit, but where should I go? What way should I take? Would you please enlighten us about this question as well? Yes, we have a hotline, 171. If you dial this number, then you will be referred to the closest clinic to your address. These clinics are all registered with the Ministry of Health. You can easily access them. You can easily get an appointment from the quitting centers. These centers are staffed by physicians who are very familiar with this topic and who are well equipped with the necessary knowledge and means. You will get help from those centers. Okay, one more question. Sometimes the patients say that I have been smoking for 30 or 40 years. Now I got this infamous disease. What's the use of quitting now? What would you say? It doesn't matter when. Even if an individual is diagnosed with lung cancer while he is still smoking, the survival time will differ if they continue smoking or not. For example, once you stop smoking in 20 minutes, the risks will drop. You see, I said 20 minutes. Start quitting. In 20 minutes, you will see the changes. And after 1 year, the risk of cardiac arrest will be reduced by half. At the end of 10 years, the links with the cancer will be reduced. The cancer risk will be reduced because 1 in every 50 cigarettes, there's 50% chance that you create some mutation in the cells and that may cause cancer. And this is more dangerous than playing Russian roulette. If you get rid of this killer as quickly as possible, then you will have a greater chance of restoring your body. You don't need any excuses. Please get an appointment from the authorized quitting centers and start your therapy as soon as possible. That is to your benefit. And most of patients fear of failing, have this fear of failing. They would like to do it, but they think that if they fail in this attempt, then they will get some negative criticism from the people around. Then should we emphasize the following? If an individual starts the quitting process, that individual will require some help from the people around. And what kind of assistance? This is not about success or failure. Do we do the same thing in the case of other diseases? So I know that you have treated tuberculosis for many years and you offered many significant TB treatment methods to our country. Thank you. So think about a TB patient. If something goes wrong, should the TB patient blame itself? Not every smoker is the same. Each individual has a certain genetic structure, has a certain smoking habit, and that person should be considered unique. There is no one to set an example to others. So if that person can really not quit, then probably something is missing in the process. You cannot blame the individual. If you go to a physician, if you complete the missing part, if you get a therapy from a physician, then you can easily sort out this problem. Any problem is solvable, but please let the physician to cope with all three aspects of this disease, and please follow the recommendations and instructions of your physician in your private life. Then you will have a very high chance of success of therapy. But you are never the one to be blamed because your brain is kidnapped. Your mechanism is working without your will, and your body is addicted to the substance, just like cocaine and opium. Thank you. That was very explanatory and very helpful. Thank you. Many of our viewers will have already quit smoking. So what can they do in order not to restart or resume this habit? You can think about this as a communicable disease. Once you recover from the nicotine disease, if you do not get another dose, then you will not get sick again. But the mechanism in your brain that is already triggered can not be restored forever. So if you get nicotine from any channel once again afterwards, then that mechanism will be re-triggered. Just think about a virus infecting your body. In fact, once you recover from this disease, please do not forget one thing. Never get another puff. Even if you just slightly open the door, the smoking habit will just kick the door and let itself in. Please do not let it in. Thank you. That's a very important mindset. Keep away from smoking if you would like to remain healthy all your life. Yes, please never forget that this is a killer in a nice outfit. It may look nice and tidy, but it is still a killer, and it always has the same character of a killer. Thank you. Tomorrow we will have another session about this with Professor Elif, and we will hear more from her. Thank you very much. Thanks for coming here. Thank you. Have a nice day. Bye-bye. Remain healthy.
Merhaba, ben Türk Thoracic Derneği Sağlık Politikaları Çalışma Grubu Başkanı Doktor Yavuz Sağlıcı. Akciğerinizin kaç yaşında olduğunu merak etmeyin. Çünkü akciğerinizin yaşı yoktur. Hastalıklar konusunda kısıtlı bilgiye değil de hatta fazla malumata sahip olduğunuz hiç aklınıza geldi mi? Sosyal medyada her gördüğünüze inanıp dakikalarca nefesinizi falan tutmaya çalışmayın. Sizler deney faresi değilsiniz. Sağlıklı kalmak istiyorsanız check-up'lardan uzak durun. Anneanneniz check-up'sız bir yaşam sürdü. Bunu hatırlayın. Kanser oldum mu diye sürekli film çektirmeyin. Sizler aktör veya aktris değilsiniz. Peki ne mi yapacağız? Bunun için Türk Thoracic Derneği'nin 26-27 Şubat tarihleri arasında düzenlediği Halk için Akciğer Hastalıkları ve COVID-19 Kongresi'ne sizlerin katılımını bekliyoruz. Merhaba, ben Türk Thoracic Derneği Sağlık Politikaları Çalışma Grubu Başkanı Doktor Yavuz Sağlıcı. Akciğerinizin kaç yaşında olduğunu merak etmeyin. Çünkü akciğerinizin yaşı yoktur. Hastalıklar konusunda kısıtlı bilgiye değil de hatta fazla malumata sahip olduğunuz hiç aklınıza geldi mi? Sosyal medyada her gördüğünüze inanıp dakikalarca nefesinizi falan tutmaya çalışmayın. Sizler deney faresi değilsiniz. Sağlıklı kalmak istiyorsanız check-up'lardan uzak durun. Anneanneniz check-up'sız bir yaşam sürdü. Bunu hatırlayın. Kanser oldum mu diye sürekli film çektirmeyin. Sizler aktör veya aktris değilsiniz. Peki ne mi yapacağız? Bunun için Türk Thoracic Derneği'nin 26-27 Şubat tarihleri arasında düzenlediği Halk için Akciğer Hastalıkları ve COVID-19 Kongresi'ne sizlerin katılımını bekliyoruz. Merhaba, ben Türk Thoracic Derneği Sağlık Politikaları Çalışma Grubu Başkanı Doktor Yavuz Sağlıcı. Akciğerinizin kaç yaşında olduğunu merak etmeyin. Çünkü akciğerinizin yaşı yoktur. Hastalıklar konusunda kısıtlı bilgiye değil de hatta fazla malumata sahip olduğunuz hiç aklınıza geldi mi? Sosyal medyada her gördüğünüze inanıp dakikalarca nefesinizi falan tutmaya çalışmayın. Sizler deney faresi değilsiniz. Sağlıklı kalmak istiyorsanız check-up'lardan uzak durun. Anneanneniz check-up'sız bir yaşam sürdü. Bunu hatırlayın. Kanser oldum mu diye sürekli film çektirmeyin. Sizler aktör veya aktris değilsiniz. Peki ne mi yapacağız? Bunun için Türk Thoracic Derneği'nin 26-27 Şubat tarihleri arasında düzenlediği Halk için Akciğer Hastalıkları ve COVID-19 Kongresi'ne sizlerin katılımını bekliyoruz.
Have a good afternoon. My name is Yavuz Havluca from Turkish Thoracic Society Healthcare Policies Working Group Chair. Today we are going to talk about should we have a checkup for lung diseases. Dr. Osman Elbek is going to be the speaker in this session. He has been working at different levels of the Turkish Thoracic Society as a valuable and distinguished scientist, and also for the accurate information to be provided to the public. He always tried to do his best. Oh, welcome, my dear friends. Thank you. No, actually, this topic is a quite popular topic. Why should we have lung checkups? And nearly all hospitals opened up their checkup units. But before that, we need to define what health means, or according to World Health Organization, what is the full well-being, and why is checkup units so popular nowadays, and why it is the rising value in healthcare. You are right, Yavuz. It's better to talk about the definition first, because the background and the basis of everything is quite important. And we have internet access, and we're now on the internet, so it is advantageous to share the information over the internet to the people, but also friend robbery and also other dependencies on internet are the disadvantages. Everything has a dark face. And in this session, I'd like to talk about the dark face of health. Some of the audience members may question what's these dark and bad aspects of health. So if we start thinking about when health doctrine started, we can have a roadmap. As a full well-being as a definition under the World Health Organization for health. As you may remember, there was an economic crisis by the end of 1930s, and then there was a fascism because of Hitler and Mussolini in Europe. Then this was followed by the World War II. People died, all the places were demolished, and they needed to stand up again. So they started planning our welfare and a prosperous and a good state, and every state had to define their health care, and this was the process how the health notion of health was shaped. And people may say that this was done for humanity. Actually, in the factories for the workers that will work, and also to protect their borders, they needed soldiers. For that reason, they needed healthy human force, or especially male human force. Actually, health was shaped and structured with this background. Actually, it was not shaped for humanity, but good or bad, everyone had education and also social security, food security, and welfare security. And it was this case till 1970s, and then people in Turkey started saying that that was a dogma that the bread was in the mouth of the lion, but now it's in the stomach of the lion. So we're at a certain point now, jobs are harder and the wages are lower, and our parents, for example, worked for a job for 30 or 40 years and they used to retire from the same job, but now we can see rotations very quickly and there is no job security, and There is no guarantee if you will be in the same job position next year, for example. And there is an interesting sentence that we use in our lives in private companies. For example, there is such a software. Now they started calling human beings as human resources. Are they gold? Are they metals? Why are we referring humans as human resources? Our perspective has changed. Instead of that prosperous state of that day, you have to be flexible, you have to have certain qualifications, and you have to work hard day and night. The only capital you have is your body and your health. You have to take good care of your health, they started saying. So then we started talking about risks. That risk, this risk, and everything is risk. So the biggest risk is to be born. Actually, being born is the greatest risk, because if you are not born, there is no death, no disease. For that reason, whole our life is considered from the perspective of risks. So by investing in our health and body, by getting away from the risks, we are trying to find jobs and employment. Of course, they are checking the physical appearance of the job candidates. Now, health is an object of investment in our body. So it's a kind of our income source. And also in the COVID pandemic, we had such an experience. There were inhumane sentences saying that people who died were not vaccinated, as if it was just their guilt. So they are fault. So they consider them as irresponsible. They're not taking good care of their health. They're not taking good care of our society. Health is perceived to be the responsibility of individuals. Individuals have to take care of their health for the health of themselves and also for the society. So state is perceived as the one that does not have any responsibility. So health has to be defined as a human right at this point, but miracles, or instead of miracles and miraculous methods, the social determinants of health have to be discussed, because that is the point where the health starts and ends, comes to an end. Rather than checkup, I think first of all, social determinants should be highlighted first and foremost. Yeah, we go to hospital, for example, when you have to check up, you have a film and there is just image and also numbers on it. But as I said, there are social determinants, what you do and how you live, and this is not known. What you do is not known, and the effects of these determinants are not taken into consideration. So what are the determinants of health? Only the laboratory tests or radiological image you have, or are there social determinants for health? Yeah, this is a critical question. Social determinants, and WHO has been putting it on the agenda very recently. Actually, I'm against the notion of awareness. I'm against awareness. So be aware of what? Risk or disease? No, this is a huge trap. We need to discuss this. You need to know. What should we know? The social determinants of health we should know. So the first condition for healthy life, especially nowadays, the world is progressing towards war, is peace. At home, outside, at all corners of the world. If there is no peace, there won't be any health and life. So if you want to be healthy, both at home and in the world, we need to defend and advocate for peace, because this is the only point where we can get away from that the most. And the most important factor affecting health is inequality. There may be two types of inequality. Class inequalities, for example, between the blue-colored and also white-colored people. For example, in a company, a public servant working at desk are different from the cleaning ladies and people in the same company. They are not subject to the same health risk. And there are also invisible part, unemployed people. So this is class hierarchy. We saw that in the COVID-19 pandemic, there is only one factor that started pandemic, blue-collar, because they did not have the chance or luxury to work at home. Or according to the deep poverty network, they showed one fact, and the garbage collectors on the streets, they were trying to earn only coins and pennies in a day. So we can't talk about health for them, as all the research studies reveal that identity is an important factor for inequality because of your language, race, faith, ethnical origin, if you're subject to marginalization, it may be in Turkey, it may be in Germany, it doesn't matter, then it is unhealthy life for you. So the way to be healthy is to eliminate inequalities based on classes. I did not talk about demographies or other things because they are not related to health, they are related to diseases. Another factor is the system itself. Factories pollute our air, and tobacco companies sell more cigarettes and produce more cigarettes across the world. So how can we be healthy under these circumstances? For that reason, this capitalist system does not think about anything but profit. So we need to balance their enthusiasm for profit, and we need to stop their enthusiasm for profit. And we need to change our perspective, Yavuz, I believe. In the prehistoric period, in the skulls, there were holes. They were created holes because when they get ill, so they thought something gets inside in their bodies. For that to get out of their bodies, they just drilled holes in their skulls. The body was healthy as long as nothing infiltrated into it. They did not get ill. So we have good cholesterol, bad cholesterol, good genes and bad genes. Our body is not healthy either, and we need to heal our bodies. So our perspective has changed significantly or radically. So everyone is not carrying painkillers in our bags. Every day we receive lots of news about air conditioners and also spinal herniation, or also the threat on our hair follicles. So we need to get away from being aware. So these are not news about health. This is this is designed in order to increase the consumption side of health. This is not information. Actually, this tells people and inflicts the feeling of being insecure. From the pulmonary health perspective, there are some determinants that deteriorate health: tobacco and also air pollution. And the reason for that is companies and tobacco companies and also other factories that pollute air. Another factor is obesity or overweight. Overweight is not an individual problem. If you just let McDonald's everywhere, if you let fast food restaurants everywhere, instead of public transport, if you encourage the consumption of individual automobiles and cars, instead of increasing pedestrian ways or bicycle ways, if you just put lots of cars inside the urban areas, there will be overweight and obesity. Food industry try to feed children with high-calorie foods, and also exposure to occupational substances is another factor. Chemical substances are an important factor for exposure in the industry, and so when a product is produced, health effect is not evaluated first. And finally, just like COVID-19, there may be other pandemics which is directly related with the ecologic destruction. So we need to improve the protection perspective in another way. So in primary, secondary, and tertiary protection should be further improved. Could you please elaborate on that? But in today's world, is it enough, or do we need a new way of protection? There are important number of studies that claim that another way of protection should be added. We should not lose them. I mean, we need primary protection for pulmonary health, for example. We need to decrease tobacco consumption, air pollution, and also internal ambient pollution. Just in another way, the aggressive nature of tobacco companies, industrialization, or poverty should be prevented through the sets of policies. And also, we need to encourage people for exercise and physical activity. We need to construct bicycle paths and bicycle roads. We need a social mobility, and also we need to be protected against sugars due to the food industry. So adult vaccination is needed, and we need to prevent and eliminate discrimination and poverty. This is primary prevention before you get disease. And secondary protection is very important for the lungs. We need to be aware, we need to know and recognize the disease in early periods, and the medical industry is focusing on this. They just want to perform the respiratory test and lung X-ray. Are you aware of this threat? They say. But I can be honest. In Turkey, if you're not working in a critical sector like mining or asbestos work, you don't need X-rays, tomography, respiratory test, any scanning test. For that reason, we need to be very careful about the secondary protection. Forget about the CRPs. For lung, we don't have any checkup in today's world in Turkey. And we need to change tertiary protection and prevention. After the disease is diagnosed, only 2 pills or medicines will not be enough for treatment. Rehabilitation is needed. Can they use and take those pills at home? Is the environment or the atmosphere at home suitable? We need to look holistically. We need to add another, the fourth dimension of prevention and protection. So excessive medical practices, excessive tests, excessive treatment should be avoided. The person is solid and healthy, but they receive lots of information from TVs, Twitter, Instagram, or Facebook. They just go for lung X-ray, for CRP or folate, thyroid hormones. So we need to protect the society from this, against this. Actually, this is the basic logic behind this presentation, because they may be in delusion because of this. They get tomographies, respiratory tests, and X-ray. Don't run after these tests. Actually, running itself turns into a disease. Especially in the checkup programs, Turkish Thoracic Society also made a statement: don't get lung X-ray because it is unnecessary radiation and it does not have any contribution for diagnosis. For that reason, if you don't say that you can get checkup or lung X-ray once a year to get away from disease. So you should be avoiding these unnecessary tests. These are very important because there are some questions that were received. I just would like to ask this. And about diseases, maybe we have excessive information. We are overly informed about the diseases. This is one of the questions I received from the audience. But this is what the physicians do. They give excessive information, confuse us, and they just guide us towards this direction. What do you think? I think that person is really right. In COVID pandemic, we also observed that, for example, in a TV program, when I saw COVID-related information about the genetic level, the hormones and everything. So we are sharing the information that is in my scientific knowledge with the public. That is not necessary, actually. As you increase the information, you increase the fear. So you say just there may be a mutation in the interferon gene. This is just increasing the fear among the public, not the information. So we are 70 million people in Turkey, so this is quite rare. So why do you speak about this with 70 million people in the country as if that is the only problem? But it means we don't talk about unemployment or the money, decreasing money in our pocket, or just the increase in the oil, which is 1.6 to Turkish lira now. If you don't talk about and discuss poverty, you can talk about health. And if you don't talk about discrimination, you can't talk about health. There are two reasons, I think. Physicians do not get the medical education. There is cytokine, there is interferon. They are just providing medical information. For that reason, they are just explaining this for good intentions. But some of the physicians, to be honest, they are not physicians. They just hold the diplomas of medical schools. They are just merchants and commercial people. They just do it in order to sell their own products. That's why they inflict fear into the public. For that reason, specialization societies and pharmaceuticals and other merchants should not be delivering such information, and we should be protecting the public against these attempts. And it should be highlighted that it doesn't necessarily mean that we should use alternative medicine. I don't say these medicines or drugs are too bad and we should use leaks or other alternative medical therapies, or we should not prescribe based on other things. We need to keep certain distance against science. We need to be critical. We need to think critically. And our path is not to the alternative medicine. We should be in science. We need to criticize science in our path. For that reason, medical education has to be transformed and changed. I read something recently. They just studied 5 words that is causing fear among people, and one was cancer. So lung cancer is really frightening for people. And treatment is very difficult, almost impossible for that reason. For the treatment of lung cancer, low-dose tomography and other treatments are used for the treatment of lung cancer. What do you think about that? So we need to look from a holistic perspective to a system. You know that lung X-ray and sputum tests do not have any effect for the early diagnosis and treatment of lung cancer. But in low-dose tomography imaging, there is a rule. We need to have effective smoking cessation clinics. You need to quit smoking, and after the tomography, you should not feel so relaxed and continue smoking. In the last decade, we have a very bad and poor tobacco control practice, and the policies are not proper, and smoking cessation polyclinics are not popular anymore. So as this is the case, and also there are acupuncture practices that took hold of these tobacco cessation practices. You can't be so effective under these circumstances, and tomography system has not been standardized in Turkey. They have different doses across different hospitals, and these hospitals do not see their results most of the time. For that reason, if you smoke more than 30 packs of years, and if you're older than 55 years and smoking cessation units are effective, low-dose tomography may be important in order to decrease the lung cancer-related deaths. But under the circumstances in Turkey, this is not applicable. So if we can have a very strict tobacco control in Turkey, then we can discuss that. 2 days ago, the data was explained. Compared to 1 year ago, we smoked more in Turkey. So this leads to the feeling that I'm smoking, I have my tomography result, it's normal, so I may continue smoking. This is the idea and feeling of the people. But so it is abused also, exploited. Because as a physician, I saw that an individual's 16 systems were analyzed separately, one by one. So we need to look from a holistic perspective, I say. And there are other questions. If there is a history of lung cancer in family members, should we also do we also need such tests and checkups? So if there is a limited genetic interaction, if there is a similar history of cancer, one of the reasons, most important reasons, is that the addiction is transmitted to other generations. If father is smoking, then children are smoking. So the reason why there is more cancer is because of the similar profiles of addiction. This is distributed between the members of the family. But at syndrome level, if there are minor disorders, genetic disorders and diseases which may not be exfoliated to the whole population, this can be considered. But the most important reason for lung cancer is tobacco and addiction. It's not genetic factor. If you can eliminate tobacco, and if you just prevent the use of and consumption of tobacco, then you can protect the health of people and also extend their lives. I have another question. As you mentioned in the first part of the presentation about awareness. The several societies, just like Turkish Thoracic Society, have awareness-raising activities and events about certain diseases. For example, if you have this disease, you cough this much, and this may be this disease. If you have fatigue, this may be the disease. So we have so many posters on the social media and across everywhere. So the ministry may do that, and societies may do that. What do you think about this? Do you think that this is a good way? So it's a problem. We need to set the boundaries very well. In Brazil, in southern parts of Brazil, for example, there is poverty and hunger. This leads to fatigue. You may not move, and you are unhappy when you're hungry. So the pharmaceutical industry make advertisements on the billboards. If you do not take pleasure in life, you do not want to go to work, maybe it's depression, they say. So the sale of the depression pills increases rapidly, but the main problem is hunger. So we need to do something for the awareness raising. If you're coughing, if you have sputum, there may be someone around you who smokes, or maybe you are smoking. So tobacco companies, tobacco industry, factories should be targeted. I mean, rather than individual measures, we need to consider what we can do collectively. COVID showed this very well. Maybe this is also the case with you. Patients said they do everything they did. They wore masks, they did not go out of the home at all, so they did not use public transport. How could they get COVID? So if that COVID is disseminated in society extensively, no matter what you do individually, this cannot be prevented. If there are tobacco advertisements all around society, and if there are air pollution causing factories all around, regardless of how good care you take of yourself, regardless of how frequently you just follow your CRP, you can't avoid that disease. We need to see the whole picture. So just last sentence. Could you please share just last sentence with us? In the science, in medicine, we need to have a critical thinking, and we need to stand by each other. Thank you very much. Thank you very much for your contributions and for your presentation. On behalf of the audience, thank you very much, and I'd like to thank the audience as well. Have a good day. Thank you.
Değerli halkımız ve sevgili hastalarımız, sizlere güzel bir haber vermek istiyorum. 26-27 Şubat 2022 tarihinde ücretsiz olarak Instagram, YouTube, Facebook gibi bütün sanal adreslerden, sanal ortamlardan akciğer hastalıkları ve COVID konusunda geçen sene ilkini yaptığımız Halk Kongresi'nin ikincisini düzenleyeceğiz. Ulaşım adresleri bilahare sizlere bildirilecek. İstediğiniz soruları orada soracak ve ücretsiz olarak uzmanları izleyeceksiniz. Halk Kongremizde görüşmek üzere.
Kronik öksürükle ilgili merak ettiğiniz tüm soruların cevabını kongremizdeki ilgili oturumda bulabileceksiniz. Eğer uzun süredir öksürüyorsanız, bir soluk algınlığı veya solunum yolu enfeksiyonu sonrasında uzamış öksürüğünüz varsa, yıllardır çözemediğiniz, zaman zaman sizi rahatsız eden bir problemse geçmeyen öksürük yakınmanız, bizim oturumumuzda bu sorularınızın cevaplarını bulabileceksiniz. Kendi sorularınızı sorabilmek, bu konudaki deneyimli uzmanları dinleyebilmek için Halk Kongremize sizleri davet ediyoruz.
Değerli halkımız ve sevgili hastalarımız, sizlere güzel bir haber vermek istiyorum. 26-27 Şubat 2022 tarihinde ücretsiz olarak Instagram, YouTube, Facebook gibi bütün sanal adreslerden, sanal ortamlardan akciğer hastalıkları ve COVID konusunda geçen sene ilkini yaptığımız Halk Kongresi'nin ikincisini düzenleyeceğiz. Ulaşım adresleri bilahare sizlere bildirilecek. İstediğiniz soruları orada soracak ve ücretsiz olarak uzmanları izleyeceksiniz. Halk Kongremizde görüşmek üzere.
Kronik öksürükle ilgili merak ettiğiniz tüm soruların cevabını kongremizdeki ilgili oturumda bulabileceksiniz. Eğer uzun süredir öksürüyorsanız, bir soluk algınlığı veya solunum yolu enfeksiyonu sonrasında uzamış öksürüğünüz varsa, yıllardır çözemediğiniz, zaman zaman sizi rahatsız eden bir problemse geçmeyen öksürük yakınmanız, bizim oturumumuzda bu sorularınızın cevaplarını bulabileceksiniz. Kendi sorularınızı sorabilmek, bu konudaki deneyimli uzmanları dinleyebilmek için Halk Kongremize sizleri davet ediyoruz.
Distinguished audience, welcome to another session of our pulmonary diseases for the public congress. I am Professor Dr. Elif Shen from Ankara University. We have a valuable guest here from Hacettepe University, Professor Dr. Fuat Kalyoncu. Today, we're going to talk about a very interesting topic, which may also be a great challenge to the patients. The title of the session is, Why Am I Coughing So Long? For so long? And let me ask you the same question. Why are we coughing for so long? Well, for many reasons. To the limits of our time, I would like to go through all the causes. Well, coughing is an important phenomenon. And this is the number one cause that takes people to a doctor's office in the world. And during winter, it is 1 in every 3 people, and in summer, it's 1 in every 10 people that are coughing. So, family practitioner, pediatrician, chest physician, all the doctors are visited mostly for this reason. Now, as you can see on my slides, we need to ask certain questions. Is every cough important, and does every cough matter? Yes, it does. Yeah, yes, it is. What is coughing? It is an important defense mechanism. It's an important defensive response and reflex, because in our lungs, in our throat, in our airways, there can be any clogging, for example, some phlegm, sputum. In order to get rid of this and throw it away, we cough. So any organisms that can cough can live long, and otherwise they cannot. That was the case with the COVID-19 as well. For example, if you have an optimal weight, and if you can strongly cough, if you have this capability, then you can survive. You could survive in COVID-19. And also, some people cannot really warm their bodies because of weight problems or other issues. And sneezing and coughing are important methods of warming up. For example, in an environment with different temperature, we see people start coughing because they would like to quickly warm up their body. In many sides of our body, ears, outer ears, eyes, and in all the trunks, that is the part of the body about the diaphragm, there are certain receptive points that can make us cough. Some of them can be triggered by change of heat and many other factors. Very recently, in the US, they spent about $7 billion for treating cough. It's an important phenomenon. If you can distinguish between two types of coughing, that will be helpful. For example, sudden onset coughing can come with infections and catching cold and flu. For example, COVID-19, a flu that can cause mortality. Reflux, indigestion. And in fact, that is also associated with weight. Sometimes when you lose weight, it helps you with better coughing. And also air pollution, smoking damages the body, and air pollution damages the urban population. So any air population caused by the vehicle engines and the chimneys can harm you. Any gases, odors, cold water that can irritate the respiratory tract can make you cough, and also any foreign body in your air tract can make you cough. Another type of coughing is chronic and long-term and persistent. Sometimes if you have any renal discharge, if it is very thick and viscous, then it can be very disturbing. If you're a smoker, if you have a chronic sinus disease, for example, sinusitis, these people will be disturbed a lot. If you have irritation in your esophagus, then you can cough, and that can be chronic. And the smokers, they are very used to coughing, but when the type of coughing changes, when the modality of coughing changes, you should be very careful. And chronic bronchitis, other lung diseases, asthma can be other causes of coughing. Which cough matters more? In fact, all of them matter. I can give you some hints and tips. Any coughing that does not get better in a few days should make you suspicious. If it wakes you up at night, if it prevents you from going to sleep, if it makes you vomit, if it prevents you from breathing, then you should be careful. For example, women, sometimes they're coughing, they also leak some urine. If your ribs get broken, if your social ties are affected by coughing, then it's a great deal. Fever, phlegm, pain, and shortness of breath. If these accompany coughing, then please visit a thoracic diseases specialist. Allergies. Now, it's almost spring. If you are allergic to pollens, then you will start sneezing. You will have some discharges from the eyes and the nose, and that allergy can also make you cough. And during the pandemic, we were mostly staying indoors, and in the indoor spaces in the hospitals and malls and schools, we have been using cleaning agents more than ever. And sometimes household cleaning is exaggerated by mothers, and we consume more disinfectants and cologne. All of them may affect us. Okay, since you're talking about allergies now, we should also talk about the masks, because with the COVID-19 now, we also are supposed to wear masks. But what can you say about the relation between the allergens and the use of masks? Well, if you're allergic, then mask will also help you, not only with COVID-19, but also with allergies. It can help you during the, for example, pollen spreading season. If you wear the mask when you're outdoors, that will help you. If you're allergic to other animals, dust or mold, you can also be protected slightly by the masks when you wear it indoors. It cannot protect your eyes and the skin, but anyway, the masks that we are typically using every day, in fact, are not produced specifically for allergies, but still they may help you. Because of your pet animals, you can have allergies, and they happen to be an important cause of allergy gradually. Coughing due to smoking is an important phenomenon, but if the way of coughing changes, you should be careful. Normal healthy person is not going to cough every day. A smoker may, but if the way you are coughing changes, then please go and visit your doctor. In 1980s, in fact, up to that time, it was possible to smoke indoors, and then it was banned. And until 2012, in fact, we had tendencies that you can see in the screen, but after 2012, we see an increase in the use of tobacco products, and it means that the government stopped struggling with or fighting against the tobacco habits. You see those water pipe cafes everywhere. So we lost the acceleration. So that report of the Turkish Thoracic Society can tell you a lot. Now, we should also talk about electronic cigarettes. They are forbidden in Turkey since 2013. They are not sold, however, they are sold everywhere. You can buy it from any shop in Ankara, Istanbul, but the government needs to take some deterrent measures against them. Sometimes they're talking about it, but they're not taking the measures. Another type of product is heated tobacco product. So when people use it, they will be directly impacted, and the people around them will be impacted. And all the tobacco and associated products, all the tobacco industry, in fact, are trying to get the money out of your pocket. They are using different methods. Please do not be misled. And they're also now trying to have a new factory in Turkey. I hope they are not going to take this way. Lung cancer. Our people smoke a lot. Lung cancer is the top cancer in men, and the second top one in female after breast cancer. It's a very sorrowful disease. In the early stages, it is treatable. However, it comes with a certain cost for the country, for the health system. I wish no one is going to get this disease, but it is very common, and it is associated with smoking and tobacco. For many years, we have been saying the TB is declining. That is right. As of 1970s, we were very similar to Europe, but during the last decade, after the arrival of migrants particularly, we can see that the tuberculosis started to move up, and I can give some figures from Istanbul. I know that the foreigners with TB increased by 10 times. And the registered migrants, another problem because they can easily get the treatment, but unregistered migrants avoid the treatment because they think they will be caught and sent away, but they are posing a threat, and that threat is the TB and spreading. Sometimes coughing may be used as an instrument psychologically when you are nervous or something else. Now, I would like to shortly talk about asthma and COVID-19. In both of these cases, you see coughing and shortness of breath, dyspnea. But, people who know both asthma and COVID say that the dyspnea and coughing are different in two cases. With coughing, you get rid of some phlegm and then you are relieved. And when you have COPD with the discharge of some phlegm, you feel relieved, but not in COVID. And in hospitals, we see a lot of phlegm in high volumes. This is something we're trying to deal with in the hospitals. So some people, refrain from going to hospitals because they think even if they don't have COVID right now, they may catch COVID when they're in the hospital. In the past, we thought that in case of asthma, we thought that it would be a risk factor, but now we notice that it is not really a risk factor. Sometimes the prognosis of the other diseases less severe in patient with asthma. And in fact, we have a nice triage of patients in the hospitals or depending on the severity of the cases. About the alternative therapies, what can we say? Herbal teas, money, etc. Apart from medication, there is no treatment. So honey or some black sesame, not meaningful at all. But something you eat will not treat your cough. Well, sometimes coughing will get better on its own. Some therapies, I don't know, including alcohol, yes, it may warm you up, or some spices can warm you up, but it doesn't treat the disease. The disease will continue and remain there. That was my short introduction about coughing. Now, if you have any questions received, Elif, maybe we can talk about the questions. Well, sure, Professor Fuat, thank you very much for this very informative introduction. Now we have a better understanding of the reasons for coughing. There's a question here. It's about heated tobacco products. What could be the potential harms of these products? Because these are relatively new products and they were developed just for sales purposes. This is just a new method invented for better sales figures. But what kind of potential damage do they have? Can they make? Why should we avoid them? In typical cigarettes, you burn the tobacco and then you smoke. It is still the burning in other methods. In the heated tobacco meetings, you just heat it up, and then there are still the hazardous substances that are activated with this process, and also they spread and diffuse into the air. In cigarettes, there are more than 4,000 substances. In electronic cigarettes, there are more than 2,000 substances. But anyway, your lungs, your vessels, and your body health will be impacted. I cannot say that something is more hazardous than others. This discussion itself is very dangerous. Does it make a difference if you jump over from the 5th floor or the 25th floor? In any case, you will die. But additionally, in this kind of tobacco products, they put the tobacco in a pan-shaped article. So you can also put some narcotics into this pen-shaped item. you no, you can also do the same thing with the water pipe. And people say that they add some narcotics to the ingredients when they're enjoying the water pipes. This is a new sector. You see a lot of these hookah or water pipe cafes. They're everywhere, but we should say this is harmful because normally you shouldn't see so much freedom to use hookah. There should be some law about this. Well, tomorrow there will be another session about tobacco products, and we will make more reference to the heated tobacco products then. So that may be an early announcement to the viewers. I have one more question for you, Professor. When should we go and see the doctor? I understand clearly that coughing is a defensive reflex, but when should we get alarmed and when should we go and see the doctor? Check your cough. If in a few days it is not lessened, if it is disturbing you, if it is in fact impacting your social relations, if you vomit, if you leak some urine, if it is damaging you, I don't know, if you cannot function, if you have fever, if you have dyspnea, please go and see a doctor. There's no need to resist. This is COVID-19 era still. Still, we cannot see the end of this pandemic. A viewer says that he recovered from COVID-19, had some cough. All the patients, in fact, know that there could be the involvement of the lungs, and now he asked, should he go and see a doctor for involvement of the lungs? Yes, when you get COVID-19, you can also have lung involvement. When you go to an outpatient clinic, your physician will listen to your symptoms, and then probably your lungs will be x-rayed, and we will understand if there's an involvement. Mostly in the first week or in the first 10 days, we will see the involvement of the lung. Even if there was the involvement, later on, we are going to see some recovery. We have the necessary treatments. Of course, these treatments can be implemented in a wide percentage of the population, but in a smaller percentage, there may be need for ICU stays. So, however, we also have the vaccination. After vaccination, the need for ICU stay will be applicable for a specific group. For example, if there's a high suppression of the immunity system, then there will be a need for the ICU stays. In 90% of the vaccinated people, it will not be necessary. But there is a phenomenon. This is called post-COVID coughing. There are still some fake phlegm clots. The body would like to get rid of them. It is something like forced cleansing. It may be disturbing, but the body would like to do this cleansing. We have some drugs, some medications that can be used in order to help your body get rid of the phlegm. In some cases, we see the coughing maybe extended up to months. Thank you. I know that this is a common complaint in many viewers. Thank you for these hints to them. One more question. It's about chronic coughing. A viewer says that she's been coughing for months, and since now we have COVID, people around me warn me because I need to go and get tested because of my coughing. I get tested many times, but my cough has nothing to do with COVID-19. I got some medication. I didn't see any benefit, and my cough is waking me up at night. What should I do? Okay, I understand it. It is waking up the patient, and it is existing. It has been existing for months. It may be related to asthma, or there can be also reflux together with asthma, or that can be some renal discharge because of allergies, please go and see a doctor. Please see a chest diseases specialist. This is treatable. Very rarely it may be difficult to control or put under control the coughing, but that is just true for a very small group of patients. Most cases are treatable. And what are the options for the challenging cases then? Apart from the alternative methods, you said that honey doesn't work, but what else? It depends on what drugs we have. We always have the medication to use in order to stop coughing. But, we would like to eliminate the root causes. We'd like to treat the patient. Stopping the coughing is not nice. 100 years ago, they used heroin in order to treat coughing. And also, later on, they noticed that the coughing was associated with TB. They couldn't treat TB, but they just treated coughing, and they used heroin for this purpose. And when they understood the harms of heroin, they just stopped using it. They discontinued using heroin for this purpose. This is just the same. Yes, I understand. All these medications should be administered under the control of the physician. Please go and see a physician. Please do not try to treat yourself. Go and see a specialist. So, Professor, would you please elaborate on cancer? Because you already made a reference to this. I would like to ask a question in this regard. When the nature of coughing changes, then we may get suspicious of cancer, as I understand you. So, in which patients should we be worried? So, for example, if you are using any tobacco products, if you are a smoker, if you smoke cigarettes, or if you smoke hookah, then you can be suspicious. Especially in women, we know that the woman is not an active smoker, but has always been a passive smoker, first because of the father and then because of the wife. Or you may be exposed to smoke in your workplace. So then you may be more inclined to cancer. Normally, you shouldn't have any disturbing coughs, but you can have, just a few coughs a day while you are still healthy. But if it is persistent, if it wakes you up at night, then please go and see a doctor, because one reason can be cancer. And if you have these other factors in your life, it could be cancer. Maybe it is not cancer, but at least you will be checked and you will be sure. It's just like taking your car to the maintenance shop just to be sure that your car is in good condition. Yes, we shouldn't ignore our own well-being. Thank you for providing us with all this valuable information about coughing. Thank you to all the audience, and we will look forward to listening to the other sessions and other specialists of the field. Thank you.
Merhaba. Astımlı hasta COVID aşısı olabilir mi? Aşılar alerjik midir? Astım, COVID için risk faktörü müdür? Alerjik astım hastasıyım, aşı olabilir miyim? Aşılar alerjilerimi tetikler mi? COVID-19 pandemisi esnasında kullanılan dezenfektanların astım üzerine etkileri. COVID-19 sırasında astımlı hastaların solunum yolu ile kullanmakta oldukları kortizonlu ilaçlar risklidir. Eğer sizler de bu soruların cevaplarını merak ediyorsanız, Türk Toraks Derneği'nin 26-27 Şubat tarihlerinde düzenleyeceği Halk için Akciğer Hastalıkları ve COVID-19 Kongresi'nde buluşalım.
Herkese merhaba. Ben Doktor Rana Işık, Türk Toraks Derneği Astım ve Alerji Çalışma Grubu Başkanıyım. Bu yıl Türk Toraks Derneği 26-27 Şubat tarihlerinde halk için akciğer hastalıkları ve COVID konulu bir kongre düzenlemiştir. Bu kongrede çalışma grubumuzun da bir oturumu bulunmaktadır. Bu oturumda astım ve alerjisi olanlarda COVID her yönüyle tartışılacaktır. Sizleri kongremizde ve oturumumuzda görmekten memnuniyet duyacağız. Teşekkür ederim.
Have a good afternoon. In this session, we're going to talk about COVID-19 in all aspects of asthma and allergy sufferers. From Gazi University Chest Diseases Department, Professor Kıvılcım Oğuzülgen will be our speaker. Welcome, thank you. For the last 2 years, you know that we have had enough of COVID-19 infection. Hospitals are fully occupied, intensive care units are fully occupied. Ministry of Health gives positive news, but this is not our life. No, not at all, actually. Really, pandemic is not slowing down, and deaths associated with pandemic are not lowering. Actually, it is continuing with full speed, and those with full dose vaccination do not get infected. Although they get infected, they have milder forms, but there are still a substantial number of people who have not been vaccinated yet. That's why hospitals are occupied. 1/3 of the population has not been vaccinated. In the Netherlands, the vaccination rate is 92%, and in the Netherlands, only 10 people die. But in Turkey, it's much higher. So countries that will be shown as examples to us should be similar to our country. Not all countries should be taken an example. So it's not easy to find an example across the world because every country finds its own way. People who have asthma and allergy are important because nearly 1/4 of the population has asthma or allergy. So in those asthma and allergy sufferers, how is the course of COVID? There are so many asthma cases and also allergy cases in the population. Of course, not all asthma patients have allergy, but there are also other diseases with allergy only. So what is the course of it in asthma patients? So it's been 2 years. We can clearly talk about that because I personally followed up COVID-19 hospitalized patients and also outpatients. I still follow up those outpatient COVID patients, and we see so many asthma cases also having COVID-19 based on my observations and also based on the publications of my colleagues across the world. Based on the data, I can say that in asthma sufferers, COVID-19 is no different from those who do not have any asthma. We can say that the presence of asthma is not a risk factor for the severe form of COVID. Some diseases can be clearly a risk factor, for example, diabetes, renal failure, or high blood pressure. But asthma patients, if they get infected with COVID-19 compared to non-asthma patients, do not have severe disease. Also in asthma patients, mortality is not different from the other non-asthma patients, normal individuals, I mean. So when they come to present to hospital, they have the fear of getting infected with COVID, although they have asthma allergy. But so for that reason, several asthma and allergy patients delayed and postponed their visits to hospitals because of this pandemic, although they used to come regularly to hospitals before that. When they get infected with COVID, do the medications prescribed have a negative or positive impact on asthma or allergy they have? This is a good question, because although they cannot visit us, we recommend our patients that they need to take their pills and medications on a regular basis. This is quite important. I just want to highlight it once again. And the patients should take their medications as prescribed by their physicians, although they cannot come up for the visits. So this will protect them against asthma attack and also unnecessary hospital admissions. The asthma medications that I take, most of them are taken through inhalation. They do not cause any predisposition or easy infection of COVID. So it is important that they take their medications on a regular basis. This is not a problem for COVID. It prevents the attacks of asthma. And on the other hand, COVID medications do not have any negative side effects for asthma patients, I can say clearly. So they can take their medications prescribed by doctors. Their asthma will not be exacerbated, not deteriorate. COVID-19 vaccines do not cause any harm. We should also say that some of the medications for asthma can also be used for the persistent cough after COVID. For that reason, they should take their medications regularly in this pandemic. I'm recommending this to all patients. So, in COVID and asthma, cortisone is the most important, most effective medication, because people may fear that there may be some cortisones in the sprays in asthma and COVID. Cortisones can be used very safely by patients. Very rarely, in severe asthma cases, they take tablets, tablet form of cortisones, not inhalation. So this is a limited number of patients, and these patients should protect themselves against COVID, especially because if they have severe disease, in most severe form of asthma, that they need to take cortisone orally, should protect themselves against COVID, because they may have severe form of COVID. And those patients who use oral forms of cortisone, the levels of the vaccines or efficacy of the vaccines may not be adequate. So inhalation is quite safe, but if they are taking cortisones orally on a regular basis, should be more careful. Maybe because of that, and patients tell us very frequently when they get COVID, maybe they want to use the tablets instead of the inhalations. No, it's not the case, you say. So it is specific to individual patients, you say, right? Masks. Do you think that they increase the respiratory distress in asthma patients? There are some who claim so, but masks do not increase shortness of breath, does not decrease oxygen. I can tell this clearly. There are some patients who do not want to wear masks because of the low level of oxygen. Just to the contrary, for the last 2 years, after asthma patients started wearing masks all around the world, asthma-related shortness of breath also decreased because of the dust and also smoke. And people against allergic things, they are also protected. Masks are not harmful. Maybe it is beneficial for the asthma patients, we can say. So it may be asthma or allergy sufferer. most of the asthma patients need to protect themselves against allergic agents. They think they are allergic to many substances, they say. I wonder if this COVID-19 causes allergy, because there are some patients who hesitate as they suspect that this will cause allergy in them. So which vaccine should they get? For the COVID-19, what kind of vaccines do you recommend? This is a very frequently asked question. More than 1 year we have been vaccinating the population. It starts in January, so this is the most frequently asked question among the asthma patients. The presence of asthma, it doesn't necessarily mean that they are also allergic. Allergy is something different. It may be allergic asthma or non-allergic asthma. Allergy is very common around the world. In the whole world population, maybe 1/3 of the world's population has allergy or asthma. Allergy to vaccine is something different. We don't see it in all vaccines. It is quite rare. Only in mRNA vaccine we see that. In active vaccine, COVID vaccine, we don't see such an allergy. It is very rare, I say. It is like in 1 million vaccinated people, only in 4 people this may be an allergy. And also, it is unrelated to the vaccination or not. So 4 out of 1 million people define themselves as allergic, but there is only one substance used as a protectant in these mRNA vaccines. There may be some severe reactions. Polyethylene glycol it is. So in mRNA we find it, in shampoos, detergents also. This is just a chemical substance used. It is very rare, I can say. Maybe it will be more understandable. For example, like penicillin allergy or painkiller allergy. So they can get any vaccine they want. If there is any bee sting allergy or food allergy or cat or dog or home dust or also fungal allergy in allergic cold patients, this is quite common. So they can safely get any vaccines they want. Their existing allergy does not mean allergy to vaccine. If they have an allergy to eggs, you know that the people who will get vaccinated ask if they have any egg allergy, but if they have egg allergy, they can get any COVID-19 vaccine safely. As I said before, in the shampoos, in the detergents, in the cosmetics or chemicals, if you have severe allergic symptoms, they may not prefer mRNA vaccines, or they need to maybe get tested through the allergy specialist if they are really allergic to these substances. If they have allergy to several drugs, multiple drugs, and if they have severe symptoms after taking those medications, before taking those vaccinations, they may consult the allergy immunology specialist. And also, rush patients can get any vaccines they want. Vaccines are quite important. This is the only resort for the end of the pandemic. There is vaccine suitable for everyone. In inactive vaccines, there is no allergy, because in mRNA vaccines, the allergy is quite rare. So I can safely recommend all patients to get vaccinated, because on the other hand, we have death because of COVID. And also there are certain patients, for example, they get vaccinated and they get allergic. So they need to get the 3rd dose. So I advise them to get vaccinated in a big hospital where they have emergency department, emergency room, where everything is available there. So what they describe as allergy is important to know, because some people get vaccinated with great anxiety. This happened at our hospitals. So they feel like fainting after vaccination. This is not allergy. This is because they were excited. This is because of the nervous stimuli. This should not be confused with allergy. For that reason, if patients have such complaints, they should get vaccinated at well-equipped hospitals after also consulting allergy specialists. They can safely get their 2nd dose. If asthma patients have allergy to painkillers, 15 and 20% of these patients have a history of allergy to antibiotics. What do you recommend for those patients? If they are allergic to only painkillers, it is not a barrier for that vaccine alone. As I said before, the most common antibiotic allergy is penicillin allergy. It is not a barrier before the vaccination of COVID-19, but if they have allergy to antibiotic and also painkillers and they have suffered from severe symptoms, they should consult allergy and immunology specialists and then choose the relevant vaccine. In the treatment of asthma and allergy, we use tablets. In addition to those medications that we conventionally use, in the last decade, biologics were introduced. For example, every 15 days or every month, they come and get those biologics. These are not vaccines because they have to be injected every 15 days or 30 days. This is biologic therapy. There are patients receiving those biological therapies. What do you think about them? Of course, what these medications that you describe are known as asthma vaccine in the public. So asthma patients are severe asthma patients. As long as they take these medications in accurately selected patients, their asthma can be controlled well. And these patients have severe forms, so they need to protect themselves a little bit more against the infections. But this vaccine treatment does not cause any predisposition to COVID. And also, it is not any problem for the other vaccines as well. So those patients who receive biologics or asthma vaccines as referred to by the public, they can get any COVID-19 vaccine as they may wish safely. The efficacy of the vaccine does not decrease and there is no negative impact of the vaccine on these asthma patients. So spring is imminent. There may be pollen allergy or also hay fever and other things. Sometimes COVID and hay fever may be confused. Thank you very much for telling this because spring is coming. There may be pollen allergy or spring allergy or also hay fever, and we will see those patients at our clinic. So we need to make a distinction between the two. The last variant is Omicron variant. Everyone knows that. In Omicron, we can see kind of cold, sore throat. This may be confused with allergy, really, but there are certain symptoms which can be seen in cold, but not in common cold, but not seen in COVID-19. For example, there may be itching on the eyes. There may be itching or sneezing symptoms in the nose. But in COVID, we don't see any itching or sneezing in the nose or in the eyes. And COVID-19 have pain and sore throat. So if they have such symptoms in addition to the runny nose, if there's sore throat and if they have suspected contact, this may be considered as COVID. But itching in the nose, if there is sneezing, and if the running nose starts in spring, this can be considered as spring fever, and also or spring allergy. If they have a history of spring allergy, they should take their nasal sprays and allergy medications, probably prescribed by their physicians. So this year, if they feel that their symptoms will start, they should take their medications regularly, I think, which I think is very important. There are some questions that we received just looking at this. Some people lose their loss of smell. Not all patients. In some patients, we see loss of smell, and this is not related to allergy. Some allergic patients may be anosmotic, may not be anosmotic, and also the nerves may be involved that leads to loss of smell. In some patients, it may be very early. In some patients, it may be very late. So, but if you ask which patients will develop loss of smell, we do not have any indications or marker for that or any symptom. We can't say this is going to be more marked in these patients and they lose their smell, lose their taste. We don't have such a data to make such a distinction, but allergic patients should not fear. It doesn't necessarily mean that they're going to lose their smell, but in some of the patients, if you allow me, I just would like to make an additional point. They also lose their taste in addition to anosmia. Not in all patients, maybe, but in some patients. In hospitalized COVID-19 patients, in 10 or 15 days, they lose 5 and 6 kg. So one of the reasons for that loss of weight is related to the loss of smell and taste. So when they lose weight, they start coughing better. I think this is a kind of evolutionary protective mechanism. You lose weight, taste and smell, and you lose weight, and it's a kind of protective mechanism. So there is another question. Being an asthma patient, is it an indication for a severe COVID-19 infection? In asthma patients, do you think that COVID-19 is more severe? You mentioned about that. Being asthma doesn't mean that you will have severe COVID-19 infection. And in asthma patients, the virus gets into the cell and then the symptoms are manifested. According to the scientific data, for asthma patients, the structures for the infiltration of the virus into the cells are lacking. For that reason, asthma patients are infected less, according to some data, scientific data. So it is not longer either in these asthma patients if they get infected with COVID-19. They are not different from those who do not have asthma. So do you think that you should be aware of the value of disease? No, we never thought that this would be an advantage, especially in allergic asthma patients. But of course, we should not rely on that. We need to protect ourselves against COVID. Virus is evolving, changing, mutating, and we do not know what the new variants will bring. So I hope no one gets infected with that. In Turkey, I think the first case was announced on the 11th of March 2020 when the pandemic in Turkey was declared. So actually, starting from November 2019, we knew that there would be or might be this disease or pandemic, but our administration accepted that only on the 11th of March. At the initial phase, as physicians, we were worrying about our patients who had COPD, asthma, and allergy. Yes, we gave administrative leaves for those healthcare professionals who had this disease to protect them. So asthma patients, just like you said, it was understood that they were not at higher risk group. That's why those leaves were suspended. So I'll come back to another point, which is also wondered by people a lot. There are references and sources which are studies and research conducted in the world, in other countries. Don't we have any studies in Turkey? Yeah, Turkish Thoracic Society has very comprehensive study on this topic. And in that study, you can see the risk patients and factors, mortality factors. For that reason, we are grateful to the Turkish Thoracic Society for that study. Can you talk about that study further? And because Ministry of Health set a barrier for performing studies, because there is a condition in order to conduct a study to get a permission from the Ministry of Health, and this is not nice. So despite those circumstances, the society could conduct that study. Yes, we obtained all permits. Several centers in Turkey participated, and we have a very large patient population. And I think this is the first study that shared the data of the country for the first time. And based on that database, there are certain studies that are ongoing now. And in asthma patients in Turkey, in terms of mortality, we also showed and demonstrated that they are not at risk group. So I'm getting back to the questions of the audience. One of the participants say he's an asthma patient. So after COVID, Should we continue taking the medications? Do you think that there is still virus? Should I take another medication, a box of medication? Do you think that medication has been infected? For the virus to live and proliferate, they need live tissue. On plastic surfaces, on clothes, viruses cannot survive longer. So that inhaler is just one person. Those inhalers are not used by multiple people. For that reason, if it's not possible for that person to be infected again, because there is certain protection after COVID infection with different durations, because although some patients are infected with COVID, they may be infected in the future again, but they are not infected through their own inhalers. But if you feel unrelaxed with that, you can wipe that mouth piece with wipers or containing alcohol, but that should not be inhaled, because you should not inhale it right after you clean it with that alcohol-soaked wipe. And those inhalers are not used after 2 a.m. So you do not get infected because of your own device. You can continue taking your medications. Then we should clarify one point. This disease is airborne. So if I'm sick, when I sneeze, when I speak, when I shout, when I cough, if I just push myself and expel the viruses and shred the viruses through the droplets, I can infect other people. But on the knobs, on the tables, although it is theoretically possible that you may get infected, but I think 98% of the people who are infected because of the short distance in the indoors area. It is difficult to be infected through contact, but if you just touch something which has virus and touch it on your mouth, then you can be infected. It is airborne and it is transmitted through droplets. So we should not exaggerate a lot. When you just come outside, there are some people who make their children and husbands to take off their clothes at the entrance, but there is no need for that. Thank you very much, Kıvılcım Hanım. Thank you indeed, Fuat. Thank you, and see you, distinguished participants. See you.
Distinguished participants, welcome to the second Public Congress of Turkish Thoracic Society. This year's topic is pulmonary diseases and COVID-19. We are honored by your interest. So within the time period that is dedicated to us, we're going to talk about the risk of blood clots. And I have a very successful friend from thromboemboli, and he is also a member of the working group in our society. Associate Professor Serhat Erol, my dear friend, is here. I will be moderating this session. I'm going to voice your questions to his attention. I also I'm working in the Ankara University as a lecturer. Probably we will have a very a nice and sincere communication between us. So we wanted to hold this session together, and that will be a very interactive session with your help and interest, I hope. So dear Professor Serhat Erol, I have a specific question for you. So we're talking about clots and thromboemboli, and what does the pulmonary emboli mean? In fact, this is the clotting of the vessels in the lung. So in certain veins of the body, the clots occur, and then they get accumulated and get deposited in the arteries of the lung, and then the pulmonary emboli occur. Okay, do you see in every people, or does it come in association with certain reasons? Pulmonary emboli, in fact, can be idiopathic at a percentage of 50. However, there are certain diseases that may add to the risk of clotting. For example, if the patient has an active cancer, that is a risk factor. We mean that if the patient is still being treated for cancer through radiotherapy or other means, then that it can create some inclination to clotting, or there can be some genetic inclination. For example, some orthopedic surgeries, abdominal surgeries may add to the clotting risk as well. Many other risks are increased, so as clotting. And what about COVID? Is there any facilitating effect of COVID-19 in clotting? Well, in case of COVID, you see some widespread inflammation in the body. It is generalized inflammation, and there is a very strong war that is fought by body against COVID, and the lungs are affected highly. And in the vessels of the lung, the war is going on. The first cause is this inflammation, the inflammatory process. The second reason is related to severe prognosis of the disease. You know, the activities are lessened, and there may be need for a certain stay in the ICU, and the daily activities are reduced, and the propensity to embolus is increased by lack of activity. Well, I understand the lack of physical activity and hospital stays and long duration of treatment can add to the facilitated clotting risk. Yes. Okay, we know that in the lungs, we know that there is a very high amount of vascularization. Then do we see the clotting and emboli very frequently in all these vessels in COVID-19 patients, or are they propose a rare phenomenon? Well, in fact, we can categorize the COVID-19 patients into three groups. We can name the first group as mild patients. Their prognosis is just like an upper respiratory tract infection. The second group is the group of hospitalized patients, but they're in normal, regular wards, and the third group requires intubation. And in that group, the ratio increases up to 50%. In the hospitalized patients, you can see different ratios. It is about 20% in the second category, but in the first category, in the mild COVID-19 patients, the ratio of clotting can be up to 1% or maximum 3%, according to certain articles. The most risky group is the group of patients in the ICU. Okay, one more question. I understand that it doesn't occur in everyone. It has a very small incidence. If it is just upper respiratory tract infection, or if it is just some silent COVID-19 infection, when should we suspicious of clotting in the lung vessels? There are two things to highlight here. One is related to healthy individuals. If you are a healthy individual, if you went through COVID, if there was no clotting before, if there was no ongoing cancer treatment, if you don't have any genetic propensity, then if you don't have this history of pulmonary emboli, then you have a very small risk. But if you have all these risk factors, please get suspicious. If you're a cancer patient, please think about this risk, even if you are spending your COVID-19 sick leave at home. Sometimes, in certain surgeries, for example, hip surgery, we see the patient is also get infected by COVID-19, and that patient will be confined to bed for a certain period of time, but then please be careful about this risk of clotting. How can you understand if you have clotting or not? The patient may present with a few complaints. One is sudden dyspnea, shortness of breath. For example, a couple of days ago, you were perfect, but suddenly you are short of breath. If you have a very increased heart rate, or if you are breathing on the right-hand side or left-hand side, if you have any stinging pain, if the patient just faints for no reason, then please think about clotting. And very rarely these patients can spit blood. If you see blood coming from the mouth of the patient, then the people should think about this possibility, the pulmonary emboli. These complaints are very significant, very severe ones like this, and probably you will not see those in everyone. No, you won't. But then I think when it occurs, it's a dangerous case. You refer to cancers, for example, pulmonary cancer, lung cancer, breast cancer. We know that they create more mortality than traffic accidents, for example, in Europe. So any patient who recovered from COVID-19, should that patient take any measures to protect against clotting? What are the protective measures? I recommend all the patients that they should continue with their daily activities. If they have to stay home, if they cannot get out, then they should do some exercise at home. They need to be careful with hydration. They need to be careful with their water intake. Not only COVID-19 medication, but also other drugs that they are supposed to be getting should be continued very carefully. And also the severe COVID-19 patients who are staying in ICU. When they are being discharged, a certain group of patients may need to receive anticoagulant injections. Just a group of patients, they need to get these anticoagulants. At the time of discharge, they will be checked. They will be given these injections. And if you are ordered these, please take them. Okay. Now we have more information about COVID-19. We still don't know a lot of things, but now we know that there can be some propensity towards clotting, and people now try to get anticoagulants. And everyone is taking them, and people who really need those anticoagulants, in fact, have difficulty in finding these drugs. Then I guess there is something wrong, because if you are using anticoagulants more than you need or without any need being there, then it can be dangerous. If you are not prescribed these anticoagulants, then should you really use these drugs? Because and the patients who had mild COVID-19 who were hospitalized but without the need of ventilation, should they continue getting these anticoagulants? Well, there can be rare cases, exceptional cases. For example, a patient is hospitalized, didn't get any anticoagulants, but if the patient had a history of clotting, or if the patient has active cancer, or if the patient is confined to bed, then these are exceptions and they can get anticoagulants. Apart from them, we don't give or administer anticoagulants to every patient. So an anticoagulant is not a simple injection. It comes with a risk of hemorrhage, even if it's a small risk, a slim chance. Well, also, I'd like to talk about D-dimer, because I hear this a lot from the patients. D-dimer is a test for blood destruction. Well, in severe COVID-19 patients, you will see a high ratio. In cancer, you will also see a high score. We also carry out this D-dimer test. But if you have a high D-dimer score, it doesn't necessarily mean that you should get an anticoagulant. And you should be very careful as a patient. Please consult with your physician first, and please do not take any drugs just due to hearsay. Yes, because we know that D-dimer will be increased with the infection itself. Don't you agree? So yes, I agree. Well, you should know the reason for increased D-dimer. Is it because of infection? Is it because of clotting? You will never know. Now, I'd like to ask you a question coming from the audience. In fact, I also had two patients this week got treated in the past for pulmonary emboli, got anticoagulants, and then this treatment was discontinued. And now the patient gets COVID-19 and being treated as an outpatient. And should we give anticoagulants? No, not necessary. If the patients can still sustain their daily activities, if the case is not so severe, then you shouldn't give anticoagulants to every patient. So we need to highlight one thing. People are using so much anticoagulant because of the footage they saw from China at the onset of this pandemic. Probably at that time, everything was very heavy and severe. We didn't have much information then, but now we have some knowledge. There are many publications now. So if you are a mild COVID-19 patient, that you have a very small risk of coagulation. In order to protect against emboli, would the vaccines help? Yes, of course. We know the facts from the healthcare professionals, because last year, the same days, in fact, we would lose many citizens due to COVID-19. And now we see the protective effect of the vaccines, and also they help protecting against emboli. And people are talking about the potential increased risk of clotting after vaccination. No vaccine that is being administered in Turkey right now has a very obvious risk of pulmonary emboli and clotting. We don't have any such reporting except from some exceptional cases. In the US, what they use, AstraZeneca. I can mention the name because it is also mentioned in many publications. They have the AstraZeneca vaccination has a high risk in size 1%, but it is not in use in Turkey. So apart from in very rare cases in Turkey, we don't have any such reporting of clotting after vaccination. So we get this question a lot from the patients. Maybe it was a coincidence if you say that you got clotting after vaccination, but that is not a commonly seen symptom. Hundreds of thousands of healthcare professionals were vaccinated. Then we would have to see some increased incidence of clotting. Yes, the vaccine you are talking about is a vector vaccine. It is not being used in Turkey, especially in the UK. That vaccine is in use, and for the group of people who got this vaccination, we can see there may be an increased risk. Now, I have a question to you related to daily practice, and this question is also being repeated by Gonca Akaç. So, for mild COVID-19 cases who spend their time at home, these patients would like to get some aspirin. If before COVID-19, these patients were not taking any aspirin, after being infected by COVID-19, should they take any aspirins as a protective measure against clotting? No, because this is a mild case. If it is a mild case, you don't need an extra medication against clotting. For example, no pills, no injections for anticoagulation is recommended. Please keep your routine. Whatever it was before the COVID-19 infection should be continued. If because of pulmonary emboli you were getting some treatment, then if you get infected by COVID-19, again, do not change your treatment regime. Please continue your treatment as you were doing before COVID-19 infection. Of course, if the picture gets heavier or it deteriorates, that's something else. Well, thank you very much for all this useful information. About a cardiac patient, he's on aspirin, and then he's infected by COVID-19. After COVID-19, should the patient not increase the dosage of aspirin? Yes, please do not. No, don't increase the dosage and keep your routine treatment regime. What about the need for checkup? Should the patient go and have a checkup to see if there's any clotting in the vessels? If it was a mild case and if the recovery just came at home, if there was too much coughing, if you feel increased shortness of breath in case of AFib, if you feel some pressure or pain in chest, then I don't know, after 1 month or 2 months, you can go to hospital for a checkup. But if you just get an upper respiratory tract infection, or if you got just diagnosed by chance, then no need for such a check. But if you, stayed in hospital, maybe 15 days after the discharge, you should come to the hospital for a follow-up check, especially if the patient was on a ventilator. Those patients will need a certain follow-up period, because you cannot say that, okay, there's recovery and then it is done. No, a follow-up visit will be necessary in every 3 months or 6 months, and the follow-up procedures need to be decided. Okay, thank you. One more question. One patient without any clotting in the lungs in former years, but there was clotting in the legs in former years. After COVID-19 infection, would clotting recur? Should there be any treatment as a measure? And would aspirin be suggested for clotting in the legs? This is deep vein thrombosis that you are describing as clotting in the legs. In fact, it's also important to understand the cause of the thrombosis in the legs. For example, if the patient fell and then got the clotting, then it is temporary. This is not a lifelong risk. The patient doesn't have to be on medication for his lifetime. But apart from these, it's the same as pulmonary clotting. If it was a mild case, then you don't need to take anything extra. But if you were hospitalized, then yes, you should need a check. But not in every hospitalized COVID-19 patient it is necessarily there will necessarily be a clotting. Sometimes you should be careful with any swelling or rashes in the legs. If you see such a thing, go and see the doctor. Okay, we discriminate between clotting in the lungs and the legs. If there's clotting in the pulmonary vessels in COVID-19, is it limited? Is it widespread? Or does it change the progresses of COVID-19? Pulmonary emboli, if it is massive, then it's a risk. This is a risky group. The incidence can be 2 to 3%, but anyway, this is risky. I don't know, maybe 3 or 10 vessels in the leg will be clotted, and regardless of the disease, it can be severe. But this is all applicable for the ICU patients. Apart from this, the risks are similar in everyone. If a patient faints, if the emboli is so heavy that makes the patient faint, then this is a risky patient. They need follow-up. Thank you. Thank you for the information. Thank you for all the questions we received. Thank you for the nice attention we got from the audience. 2 years ago, we got introduced to COVID-19. We started without much information. We still continue without much information. Firstly, we thought that the pulmonary emboli could be the main cause of mortality. But now we have vaccination and protection. Even children are getting this vaccination. In order to avoid clotting in your pulmonary vessels, please keep your daily activities, get your daily dosage of routine medication. Please do not act by hearsay and let your doctors decide if you need any anticoagulants. Our doors are always open to you if you would like to visit us as your physicians. In the morning, Professor Benan, the creator of this public congress, said whether we're going to have a public congress next year about this topic. And Professor Benan said, we hope not to have another congress with the same topic next year. I hope we will not. One last minute question about the pregnant women. So if a pregnant woman got COVID-19, should such a woman get anticoagulants? Are pregnancy a different group? No, not a different group. For pregnancy, there are certain risk groups. I'm not going to talk about this because I don't want to distract the audience. But if it was a mild case for the pregnant women, then their risk will also be very small. They will not need any extra treatment. But if they have those symptoms and complaints that I have listed, then they need to go to a hospital. So I understand that you do not separate the pregnant women from the overall population. So their vaccination, their hydration, and their healthy nutrition and their daily activities, I guess, will be important. So just keep your routine. Just because you are infected by COVID-19, you are not suggested or recommended to get aspirins or anticoagulants. This is what you say. Yes, it is. That was a last minute question. I understand that there was a huge interest from the audience. Thank you. That was a short but very satisfying session. The next session will be even more delightful. And thank you for all your patience, all your efforts, and all your attention. Thank you.
Tüberküloz Çalışma Grubu Yönetim Kurulu üyesi Profesör Doktor Aylin Babalık. Halk arasında ince hastalık olarak bilinen verem yani tüberküloz nedir? Sıklığı nedir? Nasıl bulaşır? Belirtileri nelerdir? Nasıl tedavi edebiliriz? Merak ettiğiniz tüm soruların yanıtlarını sizlere canlı olarak vermek istiyoruz. 26-27 Şubat Türk Toraks Derneği'nin düzenlediği Halk için Akciğer Hastalıkları ve COVID-19 Kongresi'ne sizleri bekliyoruz. Türk Toraks Derneği'nin sosyal medya hesaplarından bu kongremize katılabilirsiniz. Verem ile ilgili oturumumuz 26 Şubat Cumartesi saat 16'da Şeref Özkara hocamız ile birlikte olacaktır. Sizlerin katılımını bekliyoruz. Teşekkürler.
Good afternoon, distinguished audience. I'd like to welcome you all to this public conference organized by the Turkish Thoracic Society. And we are now in this session going to talk about tuberculosis, TB in short. You know, TB is an important disease that led to the highest rate of mortality in history of humanity. It is a communicable disease which caused the greatest harm to people. COVID may be more prominent in the last 2 years, but TB is always a problem and persists as a problem. What is TB and what is the diagnosis and preventive treatment? And also we will talk about TB in the world because this disease is still around. So we would like to see the picture all together. My name is Şeref Özkara from Ankara Sanatorium Hospital, Chest Diseases Department. Our speaker is Aylin Babalık from Istanbul Süreyya Paşa Hospital, Chest Diseases Department. For many years, we have been working at TB outpatient and inpatient clinics and hospitals. We are contributing to the training and guidelines developed in Turkey about TB. Aylin Babalık is going to give us overall information about TB. Over to you. Good afternoon. First of all, I'd like to wish you a fruitful congress. This disease is referred to as tuberculosis, which is TB. Is it still around? Sure, tuberculosis is a medical name for that. It is one of the most common diseases in the world. Every year, the World Health Organization receives TB statistics, collects TB statistics from the countries around the world, and it is one of the most fatal diseases. It is number 13 in all-cause deaths. And also before COVID-19, it is the infectious diseases that led to the highest number of mortalities. But in the last 2 years after COVID-19 deaths, it is the second highest mortality causing disease. How is it communicated? The microbe of TB is contracted through inhalation. The microbe's name is Mycobacterium tuberculosis. And there must be a TB patient for the contamination with the TB microbe. From the patient to the healthy individuals, it is contracted through airway. So when patients cough, speak, and sneeze, lots of droplets go out of the mouth, and these droplets dry, get small shrink in the air, and they turn into droplet cores, and every core contains 1 to 3 microbes and germs, and they move in the air in environments that is not ventilated and not sunny. They persist for a long time. And what is the highest communication? If people have TB in their lung or pharynx or in the sputum microscopic examination, there's who are found to have the TB germ, and also cavity in the lung, and people who have frequent coughs communicate the disease at higher rates. What are the environmental transmission factors? Lack of ventilation, lack of sunlight, and also staying in the same environment for long times. This TB microbe can be suspended in the air. And also colleagues or the members of the households sharing the same space for a long time with the patient may lead to higher transmission risk. And this TB microbe is important. 1/4 of the global population has this microbe in our bodies. So 90% of them do not cause any disease. They are silent infection in our bodies, and 10% of these people may develop TB. After contracting with the microbe, there is a likelihood of 10% that TB may develop. In which organs we can see tuberculosis? It involves lungs by 60 and 70%. It is the most frequently and most commonly involved organs. For example, membrane of the lung, lymph glands, and also visceral organs, peritoneum, brain, membrane, bone, joints, kidneys, and also urinary tracts, and also myocardium may be involved by around 30 to 40%. 1/4 of the world population contains this microbe of TB in their bodies, and 10% of the cases may develop TB. In the first 1 or 2 years, if people who contact the TB microbe, the likelihood of or the risk of getting the disease is higher. If patients have diseases that lower the immunity, they may develop TB. For example, AIDS, uncontrolled diabetes, renal failure, and also gastrointestinal surgery history, and lymph gland or hematological cancers may increase the predisposition to TB. Also, therapies suppressing immunity, such as anti-TNF drugs, cortisone, and also drugs taken by organ transplant patients may lead to increased predisposition. Excessive weight loss and smoking, such as alcohol, tobacco, and substance addiction may lead to predisposition to TB. Children under 5 are at risk, and people at prisons, elderly houses, migrants, and healthcare professionals, and homeless people have higher predisposition or higher risk. What are the symptoms and signs of TB? If cough persists more than 2 weeks, and they have sweats at night, nocturnal sweats, fatigue, myalgia, and lack of appetite, and weight loss. They have a fever of 37.5 degrees, sputum, and also back pain, and also chest pain may be comorbid. A cough is the most important one for us. If the cough persists more than 2 weeks, if there is myalgia or fatigue at night, and excessive weight loss. When we suspect TB, we take lung X-ray. If there are lesions consistent with TB, then we collect sputum from the patient, or phlegm. So especially in the morning, the first phlegm is the most important phlegm for the diagnosis. The first phlegm out of 3 phlegm samples should be from morning time, and they are analyzed under microscope. They are stained, and then under microscope they are analyzed to see the microbe, TB microbe. But for the definitive diagnosis, the microbe is proliferated in media. So appropriate media are found, and then the microbe is proliferated there for the definitive diagnosis. What about the treatment of TB cases? So this is a treatment because it is 100% treatable disease, and drugs and medications are free of charge. So the Minister of Health provides the medication to the TB clinics and centers, free of charge. And the shortest treatment is 6 months. This is the standard treatment duration for drug refractory patients. And if the treatment medications are absent, or if there are organ involvement such as bone, brain, and meningitis, the treatment duration may be longer. So the basic principle of treatment is to provide treatment under direct observation. All throughout the whole treatment process, every dose of the medications should be given to the patient under the supervision of a well-educated and trained professional. The purpose is that the patient takes the dose, every dose, on a regular basis, and this should be done under supervision to make sure. And very recently, based on the recommendations of the Ministry of Health and WHO, video-assisted or video-supervised treatment is applied. A healthcare professional connects or the patients may record while they are taking the drugs and medications. So this is direct supervision, which is more practical and easier for patients if the video is used. It is very useful during the pandemic time, and we can see many advantages of that. We can watch and follow that the patient is taking every dose of the medication. Should we treat at outpatient or inpatient clinics? The sanatorium treatment in the past was available in the past, but not available now. In mortality and the course of the disease, no difference was found in terms of mortality or the prevalence around the patient. But if people have bleeding and also general state disorders, uncontrolled diabetes, chronic renal failure, or hepatic failure, or there may be a side effect of the drugs, and social status, economic constraints, financial constraints, homeless patients may be hospitalized for treatment. TB patients that are resistant to medications should be hospitalized for the treatment, and then they are discharged and treated through ambulatory services. This is the first sanatorium, which is Heybeliada Sanatorium. So what are the points that we need to take into consideration? Tuberculosis control centers should have the control, and the medications, this is the most important point, medications should be used for the adequate duration and on a regular basis. If the treatment is not maintained for the adequate time of period, and on a regular basis, we can't achieve treatment, and also the problems and side effects of medications should be followed up. This is done very well at the tuberculosis treatment centers, and the patients should be followed up for 2 years after treatment. So what is the drug-resistant TB disease? What is drug resistance? If there is drug resistance, the microbe of the TB is not killed. So if they do not take their pills on a regular basis for the adequate time, if the disease is repeated or recurrent, if they are contacting a drug-resistant patient, so this is referred to as drug-resistant TB. The TB drugs should be used on a regular basis under direct supervision so that drug resistance can be prevented. When a drug-resistant TB develops, the treatment duration is much longer, cost is much higher, and the number of the pills taken is higher, and side effects of the drugs are much higher. So it is more difficult to control and treat the disease. You can see the drugs used by a non-drug-resistant patient, and also pills taken by the drug-resistant patients. You can see more drugs are needed and longer treatment duration is needed. So when the TB patients start their social life, when they can start going to school or work, so when they can get back to their former life. So in the microscopic examination of the sputum, we should not see any TB microbe. So you can do this. I mean, communicability disappears earliest and 3 weeks after treatment starts. The number of the microbes in the body decreases swiftly, and then communication or transmittability decreases minimum in 3 weeks after treatment. The basic principle is early diagnosis, detection, and early treatment, early effective treatment, regular uptake of the medications. So TB patients are in different wards at healthcare facilities. We open the windows, we have negative pressure ventilation rooms. So in ICUs, in the negative pressure rooms, we follow up these patients. And also in the corridors and in the patients' rooms, ultraviolet lamps are installed. When there is transmission, patients wear surgical masks and the healthcare professionals use respiratory masks. So what should the relatives or family members of the TB patients do? If there is a history of cough more than 2 weeks, everyone should present to the closest healthcare facility. Examination is free of charge at the TB control centers for the relatives of the TB patients. And if they have TB, they are treated. If they are at risk of developing TB, protective or prophylactic medications are prescribed. During the scanning or screening test, TDT and blood tests are performed. If they are positive for TB, it means they are contracted with the microbe of TB. It doesn't necessarily mean that they are diseased. It means that they had a contact with a TB microbe. So, is there any vaccine for TB? There is a BCG vaccine for TB, which was discovered in 1921, which is 100 years ago. We are still using the same vaccine. So it prevents the severe course of the disease in children. After birth, at month 2, babies are vaccinated with this vaccine. And also there is no protection by this vaccine at age 7. The vaccine studies are still ongoing, but despite that, we are still using the vaccine that was invented in 1921. Thank you very much. Aylin, thank you very much for sharing this detailed presentation about TB, tuberculosis, and for this informative talk. Regarding TB, I just would like to present some figures across the world. By the way, we collect questions. One of the questions is, or a few of the questions are related to what has already been presented by Aylin. And one question asks about the effect and impact of COVID on TB. Could you please answer this question? What was the effect of COVID on TB? Yeah, COVID had a negative impact on TB. In terms of disease, I mean, for the risk of developing TB. Patients' access to diagnosis and treatment was delayed because as this was delayed, more common and severe cases were detected and mortalities are higher. But we should also say that TB is not so more prevalent among COVID patients. WHO publishes TB reports every year, and this has been done since 1997. The recent one was published in 2021. Every year, 10 million new TB cases develop, and this number persisted for many years. So it is not like it appears and disappears at certain periods, and this is a huge pandemic. So I'll share the figures of the last 2 years. We had 10 million patients, and 72% of them were diagnosed in 2019, which decreased to 59% in 2020. So because of the COVID, patients' access to healthcare facilities and healthcare system was restricted, and as healthcare systems had to deal with COVID, there were some shortcomings relating to tuberculosis. Only 59% of the patients could be diagnosed and recorded. If you look at mortalities due to tuberculosis in the COVID pandemic, the mortality has increased, and in the last 15 years, this is the first time that we see such an increased mortality. This seems to be the effect of COVID. As you can see here, you can see we have still have patients, but the recorded and registered patients decrease. So in Africa and Asia, we see the most prevalent, the highest prevalence. In Europe, they had great pandemics in 1600s and 1700s, and they developed resistance. That's why we see less prevalence in this in these continents. And in the past, we also had pandemics, but we have the highest number of patients in India now, followed by Indonesia, China, Nigeria. So Africa and Asia are the hubs for tuberculosis. Africa has another trouble because the prevalence of HIV/AIDS is too high, and HIV strengthens tuberculosis and vice versa. And one of the points in COVID time was that we had a problem in registering the patients. There was a reduction of 42% in the number of the patients in India, followed by Indonesia and Philippines. So COVID pandemic, the period of the COVID, we had great troubles in diagnosing the patients. So in conclusion, there is a reduction of 20% in the number of the registered patients and increased mortalities. And activities also decreased. For example, treatment of the refractory TB and also prophylactic treatments. And the budget also decreased because it is allocated for COVID, and the budget allocated for tuberculosis decreased. And you can see the number of the registered patients decreased from 7 million to 5 million very rapidly. And this also continued in 2021. It's not perfectly improved yet. So Aylin said that it is number 13 disease causing mortality. Actually, we are talking about the topic of the Congress is the lung, but we have the lung diseases, pulmonary diseases, but in the communicable diseases, tuberculosis is one of the leading mortality cause, and only in 20% of the countries treatment can be started. There is a strategy across the world which has important problems. There is a tuberculosis pandemic across the world, and this pandemic cannot be controlled adequately. 60% of the patients are recorded. There are treatment problems. Prophylactic treatment is not adequate, and this, it seems that will continue for many years. Since 2007 in Turkey, Ministry of Health has been publishing great reports about the status of TB in Turkey, confined individual patient information. For example, this number of patients in this city, and these are the resistance and also sputum test and analysis results that help us a lot in our programming. So in 2005, we created this map in 2005 that you are used to it now with the COVID. Now in Marmara, in the Black Sea, we have a high number of patients, and in Turkey, you see, we have 20,000 patients, and in 2020, we have 9,000. So from 100,000, 10 in 100,000 is the rate, incidence rate. So this is a good program. So there is a reduction of 5% in the number of the patients on a yearly basis. So 60% of the patients are male, 65% of the patients have lung TB. As I said before, it is the highest incidence is observed in the Marmara region, followed by the Black Sea region. It has a characteristics in Turkey. So because we have some migrants in Turkey, in which the disease prevalence increased from 2% to 16% in 2020. Of course, this affects our tuberculosis control efforts. But increased started in Afghanistan. We have patients from Somalia, Pakistan, Azerbaijan, Bulgaria, Uzbekistan. So this is the close vicinity of Turkey, and we have patients from the Turkic republics. We have some patients from Indonesia, for example, or different countries of Africa, for example, South America. The world is really small. As regards the incidence, it is 15% in Turkey. These are the figures of 2020 of the World Health Organization. So you can see the incidence is around 20-25 around Turkey. It's 70% in Georgia, 58 in Azerbaijan, and 47 in Turkmenistan. The main problem is in Afghanistan, Pakistan, and Somalia. It's like 200-250%. So you can see tuberculosis is more prevalent and incident in these patients coming from those countries to Turkey. We treat patients, but also we examine all their relatives. For example, 9.5 people were examined. These are the people who are the relatives to the patients. So it's like for every patient, we prescribe prophylactic treatment for 2.2 people. COVID had a negative impact because the number of the registered TB patients decreased by 21%, which is a swift and radical decrease, because every year we have a reduction, but this year it was quite swift, and prophylactic treatments also decreased, and also the number of the contact persons examinations and also radiological examinations and microscopic examinations also decreased. COVID had a negative impact on the prophylactic and preventive practices. Turkey has been implementing a successful and great program. We are successful for diagnosis, treatment, and prophylactic and preventive treatments. Number of patients decreasing. We have some patients who were born out in other countries. This creates problem because we have some communication problems and follow-up problems, and COVID-19 had an impact, negative impact. You can see at the dispensary, these are the daily bags of medications, and we have the TB control dispensary centers. Everything is free of charge. These are very important and self-sacrificing people work there. So for the follow-up of the TB patients, registration, prophylactic treatment, and also preventive examinations are performed with great care. Turkey is very lucky. So if you have questions now, you can contact the Tuberculosis Control Center, which is the closest one to you. Thank you very much. Now, I'd like to check the questions that the audience submitted to us. What is the most important reason for the reoccurrence of TB? Did it reoccur? Yeah, it exists actually. It never decreased. 30% of them are undetected. I mean, this is still a persisting problem. So when we started our career, there was TB, and today it is still around. We have unlimited arrangements for that. And what is the most important reason for that? Poverty, hunger, starvation, and other social problems are the most important factors or causes for this disease. As long as these problems are overcome across the world, it doesn't seem that it can be controlled. So AIDS, which developed recently, is an important problem. Migration problems. We need to look globally, actually. It is silent, isn't it? It's a kind of silent burden. There are around 2 billion silent infections around the world, and always you can find new diseases. You cannot eradicate it. So it's a kind of, it is settled and deep-rooted in human community. It will take many years to fight against it, to eradicate it. We are behind. I mean, the World Health Organization's reports reveal that we are behind the standards and objectives. During the COVID period, the number of the tuberculosis patients increased because of the X-rays taken performed. I do not agree. Tuberculosis decreased. In some of the recurrent TB cases many years ago, these people may have lung involvement due to FMF. FMF is really less prevalent in Turkey, so this is not a huge problem. So we are about to finalize. So I'd like to hand over to Aylin for the final remarks. Thank you very much. It's a great pleasure for us to meet the public. As we said before, if you're a TB patient, you need to take your medications regularly to heal yourself, to protect community health and the community as a whole. You need to take adequate pills, accurate pills on a regular basis for an adequate time. Thank you very much. As you know, the medications and treatment for TB is free of charge. Please present to the closest hospital or the center. If you have coughed more than 2 weeks, please go to hospital. Thank you very much for your attention. Have healthy and good days. Thank you.
Evet, Eyüp Bey 55 yaşında koahlı hastamız. Yaklaşık 8 yıldır koah tanısıyla birçok ilaç kullanmakta. Son çare olarak acaba koahta farklı tedaviler uygulanabilir mi diye bize gelmişti. Ve kendisine yaptığımız değerlendirmeler sonrasında bazı bronkoskopik tedavi seçenekleri olduğunu düşündük. Ve hastamıza yaklaşık 1 ay önce koaha yönelik bir bronkoskopik tedavi uyguladık. Tabii ki tedaviyle beraber şikayetlerinde azalma olduğunu gördük. Ancak tabii bir de kendisine soralım. Eyüp Bey, koahta mucizevi tedavi var mıdır?
Hocam koahta mucizevi tedavi yoktur. Fakat ben bu bana yapılan şeyden sonra, operasyondan sonra daha rahatladığımı hissettim. Yani yürürken, otururken, kalkarken daha rahat nefes almaya başladım. Yaşam kaliteli yükseldi.
Evet, bu şikayetlerin azalması bizim için sevindirici. Ama tabii ki biliyoruz ki koah bir kere olduktan sonra artık tamamen ortadan kaldırmak mümkün değil. Fakat şikayet kontrolünü, semptomları biraz daha azaltmak mümkün. Eyüp Bey'de umarız önümüzdeki süreçte daha da iyi olur. Geçmiş olsun diyoruz.
Teşekkür ederim hocam, sağ olun.
Merhaba, ben Doktor Mehmet Polatlı, Türk Thoracic Derneği Koah Çalışma Grubu Başkanıyım. Sizlerle çok önemli bir haberi paylaşmak istiyorum. 26-27 Şubat 2022 tarihleri arasında Türk Thoracic Derneği'nin yapacağı halk için akciğer hastalıkları ve COVID-19 kongresine hepinizi bekliyoruz. Bu kongrede merak ettiğiniz akciğer hastalıkları ile ilgili sorulara yanıt vereceğiz. Koah'ta mucize tedavi var mı? Bu soruyu merak ediyorsanız mutlaka kongremize gelin. Doğru bilgiye ulaşmak için doğru adres Türk Thoracic Derneği. Görüşmek üzere.
Distinguished audience, please accept our greetings. Welcome to our Pulmonary Diseases and COVID-19 Congress for the Public that is organized by the Turkish Thoracic Society. I'm Sibel Naci from Mersin University, and I used to be a member of the executive board of Turkish Thoracic Society. I am also working in the working group of COPD. And we have a speaker from Gülhane Academy. Distinguished speaker is Professor Dr. Can Türktaşçı. We're going to discuss if there is any miracle cure for COPD. And we're going to have a discussion at the end of this session that will be based on your questions. COPD stands for chronic obstructive pulmonary disease. So this is an acronym. COPD patients can be identified as the highest priority risk group in the face of COVID-19. And the patients, in fact, avoided visiting hospitals because they were afraid of getting infected with COVID-19. All these patients need to continue a certain treatment regime, but rather than continuing with their regime under the supervision of a physician, they are sometimes going to the search for a miracle cure, a miracle method. And sometimes they follow their neighbor's advice. But anyway, now I think we should discuss, is there really a miracle cure for COPD? That will be the topic of our discussion today. But before I give him the floor, Mr. Can Türktaşçı, first let me ask, is COPD treatable? Well, thank you, Professor Sibel Naci, and I would like to thank the Society for this kind invitation. That's a good opportunity to inform the public about what is not known, what is not fully known. That's an important mission that I would like to achieve in the best way possible. Yes, you can treat COPD. However, in a COPD patient, it is not possible to eliminate the whole disease, but we can take certain measures in order to put COPD under control. We can suppress the symptoms, and we can relieve and facilitate the daily life of the patients. Of course, in this framework, it is important to have a good relation between the patient and the physician. It's important to be able to control and manage the disease within such a framework. Now, I can start with my presentation. I have some slides here. When I was preparing my slides, I benefited from the data that was generated by the COPD working group of the Turkish Thoracic Society, and I will try to be understandable for the public. First, we need to think about the tobacco products. If there is some significant exposure to tobacco products, there is some permanent disorder and deterioration that is created in our airways, and then our life quality is compensated. And it is more important to prevent the COPD because it's a preventable disease. It is also treatable, but it's important that we prevent it. We also have some global data. About 65 million people are affected by this disease, and annual mortality is about 3.5 million. And this is the fourth most frequent reason of mortality that is associated with a disease. And probably this ranking will go higher, and it will be the third on the list. And, such a patient should go and see doctor as early as possible. And we use certain instrumentation in order to take measurements. Sometimes the doctors may be challenged in accessing this instrumentation and interpreting the measurements, the readings. And sometimes the patients are delayed in visiting the doctors. I can say that from among all patients, only 1/3 to 1/10 can be diagnosed with COPD. Sometimes these patients think that, okay, I'm a smoker and it's normal that I get these symptoms. Of course, the risk factors are not limited to tobacco products and smoking. For example, air pollution in the house, and also use of biomass. For example, use of dried animal manure for heating and cooking purposes. Some of these products, when they're burned, and if there is extended exposure to those substances, then that can be a reason for COPD. If there is a childhood asthma, then it can also pave the way to COPD in future. Of course, there are some other risk factors. That can be added to this list, but environmental factors are always more significant than the genetic ones. It's not always about the genetics. What happens in our system, the structure of our respiratory system, and in fact, we have the bronchi and the alveoli. This system is quite branched. These are small airways as wide as 2 millimeters only, and here some inflammatory picture is created here first, and then this is not something acute. This is not an acute exposure. By years, you see fibrosis, and then there will be increased resistance in the airways, and the air sacs, the alveoli, will have a distorted structure, and then the symptoms will start to appear, and the patients will suffer from attacks. And there may be episodes of coughing, increased frequency of breathing. In some patients, there will be a phlegm, but the form of the phlegm will be changed. For example, the color, the viscosity of the phlegm will change with all these episodes. Of course, each of these steps will contribute to the progress of the disease, and with reduced oxygen level, the picture can get heavier and end up with death. What are the symptoms? Chronic coughing, and the coughing will continue day and night, and in certain patients you will also see phlegm together with the coughing. You will also see dyspnea and shortness of breath. If all these symptoms continue for an extended period of time, in fact, it will be necessary for those patients to go and see a doctor, because it is necessary to verify their diagnosis with the necessary tools and means. Spirometry is the method of measurement that we use for diagnosing COPD. We have certain respiratory parameters. The physicians check those parameters in order to diagnose COPD. Mr. Can Türktaşçı, I interrupt you for a question that we have just received. During the pandemic, is it necessary to give this respiratory test? What do you think? Yeah, the respiratory function test can be more challenging during the pandemic. The respiratory functionality test should be conducted in a laboratory. And in the laboratory, probably there will be a patient who will have taken the test before you, and there should be a time interval between the two patients so that the necessary cleaning and sterilization can be done, and also PCR tests may be requested. But if there is a very intensive demand for the testing, then it may take months for a patient to get the appointment. So that is why first we check the symptoms and we look at the overall picture. We give the necessary recommendations, we give the necessary medication, and then we postpone the appointment for the respiratory function test at a later date when everything is easier. Maybe it's also useful to question the risk factors, and looking at the risk factors may give a clue about the COPD possibility. You already listed the risk factors, but what are the most associated ones? In fact, I have already listed them. I can say we have the tobacco products at the top of this list. Because if you would like to prevent COPD, then that is the best means that you have. If you're a smoker and if you also are suffering from COPD symptoms, then it is obvious that you have to quit smoking. Because once you get COPD, then everything will start to deteriorate. And of course, it is important to avoid the risks, but please be aware. Please know and anticipate that your condition may get worse. In fact, the physicians will recommend you in all your visits that you should quit smoking. As you have just mentioned, the smoking habit and all tobacco products, the cigars, hookah, electronic cigarettes, passive smoking, all these risk factors go at the top of the list. What about the quality of the air that we breathe in? Is there any association with that? Because recently we know that the air quality is compromised. Sorry. Yes. The air quality in the indoor environments and outdoor environments, they are both important. We hope to be able to breathe in cleaner environments, because in future with exposure to all these polluting particles, we may see the emergence of COPD. What about the growth of lungs? Think about our childhood or the prenatal period, or the times before you were born. All disparities, social inequalities, all the risk factors that you were exposed as a child, frequent respiratory infections that you suffered from when you were a child. I think all these should be questioned when we are seeing a patient. Yes, I agree. Thank you. Thank you for all these nice contributions. Now let me continue. People sometimes find it difficult to differentiate between asthma and COPD. People try to self-diagnose, and then they think they have asthma while they have COPD. It's important to differentiate between the two. Some drugs may be common for the two conditions, but the basic approaches differ significantly. So the preventive measures and the medication will differ based on the condition. Asthma will start at earlier ages, and we know that the disorder is parametrically speaking, it is persistent in COPD, but it is not the case in asthma. And phlegm will be different in the two cases. There can be a more dominant history of allergies, and with spirometry, the medication may be more helpful in one of these conditions. So this is how you can differentiate between the two cases. Once the patient is diagnosed with COPD, then we need to take one important measure. It is to quit smoking and also getting away from tobacco products. It will help with both morbidity and mortality. We have this combined assessment diagram for COPD. This is quite familiar to the physicians. And in this chart, in this diagram, you see different groups of patients. The exacerbations of the symptoms, changes in the respiratory parameters, the episodes, all of them are taken into consideration in order to categorize the patients. Smoking is critical. I keep emphasizing this because we call this disease a preventable one. Then we need to eliminate the risks, and also regular physical activity, vaccination will be part of the treatment approach. Regular influenza vaccination, also oxygen therapies, pulmonary rehabilitation, maybe different modalities of treatment. We know there are different drugs. Mostly we use inhalers. In some patients, there can be respiratory failure due to COPD, and those patients will actually need oxygen therapy. Well, we have very limited time, Professor John. There's a question about oxygen therapy devices because of electric cuts and power outages. These patients, in fact, suffer a lot, and they get victimized by these power outages because these patients have to be on long-term oxygen therapy. Very briefly, would you give a few remarks about this situation? Well, if the patient needs an oxygen concentrator, this patient will have gone through certain assessments. We collect blood from the arteries, and then we prescribe the oxygen concentrator. And this kind of prescription will require a minimum usage of 16 or 18 hours per day. And sometimes it may be necessary to get a portable oxygen cylinder because there may be power outages. Currently we are paying very high electricity bills. In this in this group of patients, I hope there will be some kind of subsidy coming from the government because there will be a high consumption of power in those households. Yes, not just with the oxygen devices, but also some patients who need the ventilators will need this kind of measures and subsidies, I guess. Yes, I believe because these people have to be on these devices because of a medical obligation. This is not just random usage. Well, sorry for interrupting you. This is our last 5 minutes. I would like to give you the questions that we have received so far. People are very eager to get your answers. We see a lot of different miracle solutions. For example, an agent that cleans the lungs, and eliminating COPD in 7.5 minutes with the help of a balloon. What do you think about all these? Is there any agent that can cleanse the lungs? What about balloon therapies? Or are there any alternatives to the drug therapies that you have mentioned? So what can really eradicate this disease? Yes, you're right. That was the title of the session. Is there any miracle cure to COPD? Well, as you know, Sibel, before we start looking for a miracle cure, we need to look for prevention. This is what we need to focus on. Early diagnosis, awareness raising, quick access to physicians, and prevention of the disease. There are some herbal plant or herbal solution shops, and people try to visit those shops in order to find a miracle cure. No, you don't have much chance in those shops. For example, some people try to consume, different products, just like oat, hay, or I don't know, locust. I know about this. And what about the balloon therapies? Because that therapy also received a lot of media coverage. They suggested this as a miracle cure. In severe COPD patients, only in a certain group of those patients, in fact, we're looking for certain ways, but there is no data for the balloon therapy yet. We look at the guidelines, and there are certain therapies that are specific to the very severe group. For example, plug therapies, or there are some smart therapies, and thermal vapor treatment. This is quite popular in the recent years. But are they prescribable to all the patients? No, not to all of the patients, because there are certain specific types of COPD patients. We get CTs of the patient. We also get respiratory function tests. Some of these tests are very detailed. So rather than conventional spirometry, we conduct very detailed tests. For example, a lung CT and some other scanning, all done and taken before we can prescribe these specific therapies. And in fact, before our session, people watched a video about my interview with a patient. I asked my patient, "Is your COPD over?" And the patient said, after so many therapies, that no, it was not over. He was still having some complaints, but with all the therapies that we suggested, we provided, now his respiratory capacity is improved. Now he can get engaged in more physical activity. The need for concentrated oxygen may be reduced in certain patients. We can offer more comfort to patients, but we can offer specific therapies only to selected patients. I see many patients who underwent balloon therapy, but there is no scientific background to such a therapy, not for the time being. That's why we cannot recommend such a therapy right now. Well, Professor Can Türktaşçı, thank you very much for all this enlightening information. Thank you for the nicely prepared presentation. And our audience was here with us with their questions. I would like to thank them for mediating our discussion. Let me repeat our main messages before we conclude this session. So COPD therapy is not takes away the COPD. We are mostly, in fact, talking about relieving of the symptoms. We're talking about improving the life quality for the patients. The pharmacologic therapies, in fact, help with eliminating the exacerbation of the symptoms. Apart from pharmacology, there may be some complementary therapies. So the pharmacologic methods and non-pharmacological methods can be complementary to each other. Some interventional bronchoscopic methods may be implemented, but beyond all these, it's more important to take the measures so that the disease will not get worse. Measures should be taken. Necessary vaccination should be administered. The influenza vaccines and completion of all the necessary vaccination during the pandemic. Healthy nutrition, not junk food, giving the nutrients that are needed by the body. And of course, some measures to be taken by the nations. This is out of our individual control. For example, elimination of air pollution, high quality air, and improvement of socioeconomic factors, elimination of disparities. This is a long list in all diseases. All these factors matter. And once we eliminate these factors, maybe we will get a spherical cure one day. Well, thank you very much for your kind participation and attention. We would like to thank the Turkish Thoracic Society and the organizers of this Congress. And Professor, thank you once again for your nice presentation. And that's the end of the session. Thank you.
I'd like to welcome and say good afternoon to all the audience. I'd like to thank the Turkish Thoracic Society and everyone who contributed to the organization of this excellent conference for the public. I'm from Hacettepe University Medical Faculty, Chest Diseases Department, Adult Immunology and Chronic Immunology Department. My name is Associate Professor Ebru Dahmadoğlu. Today we're going to talk about the medications used for asthma and COPD and inhaler medications. We are going to discuss why these inhaler medications are not working, and we will focus specifically on patient usage errors. Our speaker is Associate Professor Feride Taşkın Yılmaz. Is from the nursing faculty and also in the Turkish Thoracic Society. She's a secretary in a working group. Welcome, Feride. Thank you. Let's start this way. What are these inhaler medications? I'd like to say good afternoon to all the participants. Inhaler medications are used for various respiratory system infections to treat lungs, especially if people have some problems in using liquid forms or powder forms. It is also referred to as spray among the people compared to the oral and IV medications. They have advantages because for the healing of the lungs associated diseases, it has a positive impact compared to oral and IV medications. They have fewer side effects like nausea and dizziness. And also when you give IV medications, there may be pain infection, which is disturbing for patients, but inhalers do not cause such pains or disturbances. That's why these are alternative medications. You say when we inhale these medications, compared to the tablets, the low dose is taken. Compared to IV application, we get or take lower doses, but it directly goes to the lungs through inhalation. We can treat the disease with lower doses. In which diseases we can use these inhaler medications? As you mentioned before, especially in asthma and chronic bronchitis, they are used. Mainly inhaler medications are used for such diseases. In addition to that, in viral diseases, if the specialists find it appropriate for the lung diseases, for symptoms such as sputum or cough, they may heal certain symptoms. For that reason, inhaler medications are used for the treatment of such disorders. Are there any types of inhaler medications? Do they have any superiority? There are different inhaler medications. What are the features of these medications? Could you please summarize them? Today, for the treatment of lung diseases, there are 3 different inhaler medications. The first one is this one. It has a measured dose, and the other one is powder forms. And then the other one, we have dehumidifiers. Through the machine, you can use that medication. As regards the superiority of the drugs or medications, we can't say something. What is important is the disease itself and its symptoms. The physician decides on which type of inhaler medication can be used depending on the characteristics of the disease of each specific patient and its symptoms, to relieve the respiration of patients and to control the disease of the patients. They are used if there is any secretion, to prevent secretion, and also to control infection, to also facilitate the secretion of the sputum or phlegm. They may have an effect. And as I said before, depending, the physician will take the decision which type of the inhaler medications will be used. As we discuss now the types of inhaler medications, there is a question. It says vapor form and spray form of medications are available. What are the differences between them? Of course, symptoms are important at this point. If they have severe shortness of breath, vapor forms of medications can be recommended by the physician. And also in stable periods, when the symptoms are controlled, inhaler or spray forms of inhaler medications may be useful for patients. The variety of symptoms and characteristics of the symptoms should be evaluated by physicians who then will decide on the type of the medication. I should also highlight one point. When the vapor form of medications are given through a machine or a device, increase the risk of transmission of the disease during the COVID time. That's why it is not preferred in this time. But elderly patients or may have difficulty in coordinating that inhaler medications, pushing and also inhaling, they may not be successful in that. Also for younger children, a vapor form may be preferred, might be preferred. But we observed that the spray form of inhaler medications have a certain part, they can place a certain chamber or part, so it has the same effect like vapor forms. For that reason, by placing just an intermediary part, there won't be any difference in terms of efficacy compared to vapor form. Taking in vapor form, because droplets are spread, the risk of transmission of the infection may be increased in this period. Using an inhaler medication, will it cause addiction? Because there is such a hesitation in the public. When we use them, do we get addicted? Especially asthma patients take these medications, and that question, if this leads to addiction, is also popping up so frequently. Patients also fear that. If you look at the agents of the medications, we don't see any addictive substances. Because these medications have to be used for a long time, people perceive that it may lead to addiction. But as I said, these medications do not lead to addiction. In line with the advice, physician advice, it can be discontinued anytime. It doesn't lead to any withdrawal symptoms, so it doesn't cause addiction, in short. A patient asks a question: how can I make sure that I'm using the inhaler medications accurately? Do I inhale it adequately or not? How do we understand that as patient relatives or ourselves? Maybe we are using it ourselves. How can we make sure we are using it correctly? Depending on the respiratory diseases such as shortness of breath, cough, and sputum secretion, these are the main symptoms that we observe. To overcome these symptoms, we need these medications. But if the symptoms are not relieved despite those medications, it may mean that these medications are used erroneously, or there are some errors in the usage of these medications, or in recovery period, just to the contrary, when triggering factors are encountered, if these symptoms increase, it may mean that there are errors in using those medications. But in some diseases, again, there are different treatment modalities that may be used, but the physician should be consulted and informed about that. And within the knowledge of the physician, they may switch to another medication. There are two different forms. This one has a measured dose in it. So this is the most frequently used form of inhaler medication. Before using these medications, we need to check the expiry date. We need to hold it in a vertical way, upright position, and we need to shake it for a few times we use it. After opening the lid, we are going to place before we place it inside our mouth, we need to exhale, empty our lungs, and we need to fully place it in our mouth. While inhaling, simultaneously we need to push at the top. I'm showing it now. So as soon as you push, you inhale it. Yes, that's what I meant. You need to simultaneously push and inhale. We are just directly keeping the breath for 10 seconds in our lungs, and then we need to exhale it from the nostrils slowly. Most important error is that the drug is pushed into the mouth. Rather than we need to inhale in a way to take the drug medication into the lungs directly. And also we should not push it repeatedly. We need to wait 30 seconds or 60 seconds for the second round of inhalation. So there was a question about these inhalers. Do you have any striking example to errors in patient use? Could you please show it again? I think there was a lid in front. So before, so a patient, for example, used it without opening the lid. So he opened a hole on that lid with a nail and tried to get the medication from that hole, and it was not effective. I just want to give an example to that based on my clinical experience, especially in the street. We see such examples. They just put it in the mouth and do it like this. So inside the mouth, they just do 2 sprays, for example. The physician recommends 2 sprays, but then this is a wrong application. That medication does not go to the lungs and it does not treat. We need to inhale directly into the lungs in this dry powder form. Similarly, we have to open the lid, and in the direction of the arrow, we just pull it. There is a we need to place the capsule inside this. Then you have to close the lid, hear the click sound, and there are clicks on the sides, and actually you are just blowing that capsule with that clicks, and then you place it into mouth and you inhale quickly. You need to hear the sound of wheeze, and after inhaling it, we have to keep the medication in our lungs for 15 seconds and then exhale from the nostrils. If you have to do it for the second time, you have to wait for 30 seconds to 60 seconds. I want to show it again. We place the medication, close the lid, click it, and place it in the mouth. First, of course, we need to exhale before we inhale. In this way, if second round is needed, you may need to do it, repeat it. I just would like to make an additional remark here, because you showed it, but I'm going to sit laterally. It applies to all forms of inhalers. It may be fixed dose or other dry powder form in medication. We have to put it in this position before inhalation. When you inhale by bending, the whole medication will go to your palate in the soft tissue inside your mouth. For that reason, the side effects, intraoral side effects, occur more, and less medications reach the lungs. And maybe you can lift your chin upwards slightly so that you can inhale it better. So this is another error, for example. So let's move on. On the website of the society, is there any information or any video for the use of these medications? Yes, on our website, there is an information tab. Under that tab, you can click on the videos that you may find there. So for every device, there are videos of like 2 minutes or 1.5 minutes. You can watch those videos. So what about the pill form inhalers? before placing the pills, if we just swallow those pills, will it be effective? So in our society is one of the errors. It may be tablet, capsule, or pill. They are inhaler medications, therefore they should be definitely placed into this device. Because of the agent, it has to be inhaled, not taken orally. They should definitely not be taken orally because they are inhalers. You have to inhale them. As you know, it's not possible to orally take it with water. This is also another important error, usage error. There was a patient of mine. Somehow they did not remember that they have to place it into the device and blow it and inhale it, but they just took it orally. That medication would not be so effective because there is very low dose of medication. When you inhale it, it is effective in the lung. When you take it orally, it is in the blood circulation. As the dose is very low, you do not benefit from that dose when you take it orally. So how should I keep these inhalers? Should I put it in the refrigerator? Should I carry it with me? Inhalers, drugs should be in the ambient temperature, and also they should not be exposed to sunlight directly. And there must be a user manual according to which you can find relevant information about the storage of these medications. Mainly, they should be stored in ambient temperature, at ambient temperature or room temperature. So this is also a very common error because in the market, there is a fixed dose inhaler device, and they are placed and stored in refrigerators at the pharmacies. And the pharmacist give it to you by taking it out of the refrigerator. So it is in the room temperature. So for 5 months, they can be used in room temperature. You should not store it in the refrigerator because some of them are used as saver. So when you store them in the refrigerator, you inhale cold air. Inhaling cold air is not desired. For that reason, you should store them at room temperature below 25 degrees and not exposed to sunlight, direct sunlight. Other questions? I'm checking the questions. Because of cough, do you think that inhaler medications can be prescribed for coughs? I'll answer this question. Because of cough, sometimes low-dose cortisone-containing inhaler medications are prescribed. Some asthma patients with prominent cough, a marked cough, then inhaler medications are sometimes prescribed. So there is also another question. In the treatment, do you think that the cortisone in the treatment is harmful? Because these medications have cortisone. Do you think cortisone is harmful? And will it lead to involvement of the lung or a problem in the lung? There is a misconception about cortisone in society, and people fear using those medications. So in inhaler medications, the effect of cortisone is important for the suppression of secretion in the lung diseases. So it is at a level which may be beneficial for the disease. But medications given orally and IV may have more side effects, like osteoporosis, risk of infection, or growth retardation. When given as inhaler medications, these effects are not expected because they are not at very high level doses. For that reason, based on physicians' advice, they are used. It is beneficial for the breath, for respiration. And while using cortisone-containing inhaler, we need to be careful about some infections that may occur intraorally, while some small particles of the medications may settle in the throat, in the teeth, for example. So the thrush may, or after intraoral after may develop. So after inhaler use, we tell our patients to rinse their mouth. So rinsing mouth after using the medication will be enough to avoid such intraoral infections. There is a question from a patient: when symptoms are relieved, can I discontinue it? Or patients diagnosed with chronic COPD should continue using it, taking it for a lifelong. In some diseases like asthma and COPD, medications should be taken for a long time, but it doesn't mean lifelong. From time to time, they should go for the control to the hospital or to the physician. Then the physician will decide on discontinuation or suspending it for a while. So it can be decided based on each specific patient and by the physician. Instead of taking it for lifelong, they need to be taken according to the specific situation of each patient. I'd like to make a contribution here about cortisone first. In our lungs, there is an infection or inflammation, and the most effective drugs or medications are the ones that contain cortisone. When we do not treat that infection in the lung, it will lead to negative impact on our health status. That effect is more severe and more problematic than the minor effect that may be caused by the low dose cortisone in these medications. So these are micrograms of cortisones, and it does not lead to systemic side effects like osteoporosis, high blood pressure, or weight gain. This has not been demonstrated. So you need to take your medications regularly based on your doctor's recommendations and advice. Actually, chronic treatments are needed for COPD and asthma. Sometimes doctor may decrease the amount of medications you take, so when you are under good control, but very frequently they may need to be used for lifelong, but there may be a decrease from time to time as well. There is another question: when I take drugs, there was trembling and a palpitation. Is it a barrier before the use of those medications? I can answer this question. In some inhaler medications, trembling at hands, palpitation, and cramps in the muscles may be caused by a substance. It is not cortisone. It is other substances that enlarge airways. So you need to notify your doctor in such a case. Then the doctor may prescribe another inhaler medication that does not include or contain these substances or agents. And time is up. There is just final question: how can we use the plants? About this matter regarding plants, in any guideline, there isn't any evidence-based treatment about plants. We don't know which plant or plant combination will be effective or will have any interaction with the medications that you are using. Or we don't know if they lead to deprivation of medication. We do not know their efficacy or interactions. For that reason, in asthma or COPD, we do not recommend any plant-based treatment. We answered all these questions. Professor, can I also take the floor? Do patients have to carry their inhaler medications with them? At this point, in chronic diseases like asthma, because of certain triggers, when they encounter with triggers, symptoms of shortness of breath may increase. If physician advises that you need to carry it with you, then you need to keep it with yourself all the time, because, as I said, you may encounter the triggers anytime and you may be in shortness of breath. For that reason, it is better for those patients to carry those inhaler medications with them. Thank you very much. Thank you indeed. Thanks a lot.
Ben 2015 yılı Aralık ayında akciğer nakli oldum. Hem akciğer nakli olmadan önce hem de akciğer nakli olduktan sonra pulmoner rehabilitasyon eğitimi gördüm. Ve bu eğitim bana nakil esnasında kaslarımın güçlenmesine ve daha sağlıklı bir ameliyat geçirmeme sebep oldu.
Ben İbrahim Kurtuluş. İdiopatik pulmoner fibrosis hastasıydım. Ankara'da çift taraflı akciğer nakli oldum. Hastaların kasları ne kadar güçlü olursa bu hastalığı yenme oranı o kadar yükselmektedir.
Herkese merhabalar. Ben Mehmet Seyman. 52 yaşındayım. İleri derece koastası akciğer nakil adayıyım. Hasta hikayemde 32 gün yoğun bakım sürecim ventilatöre solunum cihazına bağlı kaldım 6 ay. Pulmoner rehabilitasyon sayesinde solunum cihazından ayrıldım. Hiçbir şekilde günlük aktivitemi gerçekleştiremiyordum. Pulmoner rehabilitasyon sayesinde günlük aktivitelerimi gerçekleştirebiliyorum. Solunum cihazıyla yürüyebiliyorum, gezebiliyorum. Tüm ihtiyaçlarımı karşılayabiliyorum. Spor ilk zamanlarda zor gelebilir, sizi yorabilir, nefes darlığı çekebilirsiniz. Ama bu gün geçtikçe, zaman geçtikçe iyi olacaktır. Yaşamınız düzelecek, moraliniz düzelecek, yaşama daha sıkı tutunacaksınız. Pandemi sürecinde maske, mesafe, spor diyorum.
Merhaba, 30 yaşında bir fizyoterapistim. Her şeyden önce aslında 1,5 aylıkken tanısı konmuş da bir kistik fibrozis hastasıyım. Demem o ki 30 senedir pulmoner rehabilitasyon uygulamalarının içindeyim. Pulmoner rehabilitasyonu düzenli olarak hayatımda uygulamaya çalıştım. 30 senedir pulmoner rehabilitasyonu her gün uygulamam sayesinde sağlık seviyemi, durumumu belli bir seviyede tutabildim. Hatta ötesine geçip daha yükseklere çekebildim. Pulmoner rehabilitasyon uygulamalarını düzenli uygulamam sayesinde sağlık seviyem üst seviyeye çıktığında müsabık olarak farklı spor dallarında da yarışma imkanı buldum.
Hello, I'm Pınar Ergün, MD, and today I feel extremely delighted to be with you in this session. Welcome to our Congress about pulmonary diseases and COVID-19. And I am together with a very dear friend, Associate Professor Dr. İpek Candemir. Today we are going to talk about a very important topic, respiratory rehabilitation, and a very important therapy that needs to be integrated into the therapies of the patients of lung diseases. We will try to cover your questions as much as possible. We're going to talk about pulmonary rehabilitation. Later on, the details will be elaborated on by dear İpek Candemir. You already heard the previous session, which covered the inhalers. So in the treatment of respiratory patients, pharmacological therapies will not be enough alone. And pulmonary rehabilitation should also occupy an important place in the treatment of all these patients. This rehabilitation should be integrated into the overall therapy. Now, İpek Candemir, would you please define what respiratory rehabilitation is and which patients can it be used? I know there are different components of this kind of pulmonary rehabilitation. Please, we are all ears. Thank you. I am İpek Candemir. I'm also the head of the working group of the relevant field in our society. After a detailed assessment of the patient, this kind of rehabilitation can be suggested in order to improve the health condition of the patient. It is very comprehensive. It also includes change of behavior, change of habits. It's a whole of many approaches. So all the patients of chronic lung diseases can benefit from this rehabilitation. For example, COPD patients, interstitial patients with the thickening of the tissues, COVID-19 patients who are having problems in the lung because of overweight, patients of dyspnea, and smart wire receivers before and after this intervention. And also pulmonary scoliosis patients of this kind of disorders will need the pulmonary rehabilitation. Well, in the introductory video, we have seen a patient of lung transplant. That's another type of case. Right before the transplantation, right after the transplantation, when the patients are still in the hospital, and also sometime after the transplantation, these patients will need rehabilitation as well. Yes. First, rehabilitation was integrated into the treatment of COPD patients, but we know the major complaint of COPD patients is dyspnea, the shortness of breath. So the patient is already suffering from shortness of breath. Then how can we put such a patient into exercise? I would like to hear more details of the pulmonary rehabilitation from you. I know there are many components of this kind of rehabilitation. As you said, change of behavior is targeted by this whole of treatments. However, I also know that the most important component is exercise and physical activity. So also please explain how a COPD patient with shortness of breath can go through these exercises. Well, in the patients of lung diseases, we get this question a lot. They say, okay, I'm already suffering from shortness of breath. Whenever I put myself into physical activity, I suffer more. And how can I carry out these exercises? Yes, this is a vicious circle. You know, all these end up in bigger consequences. For example, shortness of breath, avoidance of exercises, and then weakness in muscles, avoiding the exercise more and more, and more motility, and then the increased need for oxygen in the muscles, and increased consumption of oxygen in case of exercises in the muscles. And then the patient will one day feel more severe shortness of breath when even sure he is eating, more upsetting feelings, and then starts the vicious circle again. The patient is confined to home, and those patients will really remain home in an upset mood. In these patients, respiratory rehabilitation is a must, and exercise training is one of the major components. But of course, there is more than that, there is beyond that, because in those patients, we also see eating disorders. Even if they eat a lot of, a small amount of food, they will get more shortness of breath. And in COPD patients, there are already some respiratory issues because this is systematic disease, and these patients will lose weight. They will be losing from their muscles, and their body composition will be distorted. So pulmonary rehabilitation or the respiratory rehabilitation center will be necessary for these patients. There will be a dietitian there in those centers to see the patients. The dietitian is going to regulate the eating habits and the diet of the patients, and also they check what the patient should be consuming and taking in. They check the water ratios, the muscle ratios, and also they check what needs to be eaten, and also oral nutritional supplements and solutions. They're also checked for. They also check if there's any need for such kind of supplements and solutions. We also check the psychology of the patient, because these patients will isolate themselves from daily life. They remain inactive and they will need assistance. Even when they need to go to toilet, they become dependent on others, and they will have some disturbing psychological mood as well. And that is why in those centers, those patients should be seeing psychologists too. You know, there is another important component of this rehabilitation. It is the training of the patient. That can be individual or group training. In the training sessions, we teach about the disease. We teach about how they need to cope with their the condition. For example, when can they get the exacerbations? When can they have the episodes? How should they cope with the episodes? And we train the families of the patients as well. And we explain how they should be eating, what they should be doing in case of shortness of breath. We tell about how they can improve their quality of life, how they can use and save their energy, how to inhale and exhale, how to effectively discharge the phlegm. All of these topics are covered in this detailed training. So any patient that is referred to the pulmonary rehabilitation unit, in fact, is referred to that unit for a certain reason. And these reasons may be diverse. And according to those reasons, I understand that an individual rehabilitation program is prepared and structured. And then the patients benefit from this therapy in a customized way. The structures may differ. I know hospital center outpatient pulmonary rehabilitation programs are very well known. Some patients come to hospital on certain days of the week, and then they join certain sessions. These programs are called hospital-based pulmonary rehabilitation programs. This is an outpatient program, but there is another group of patients that should receive inpatient program. But we also have home care services, and the teams go and visit the patient home to provide this rehabilitation service. Now, I'd like to talk about the pandemic. With the pandemic, different centers in our country, we started to provide a tele-rehabilitation program. Would you please talk about this tele-pulmonary rehabilitation program? What is it? Why was the demand for such program increased during the COVID-19 pandemic? Would you please talk about this tele-program? Telepulmonary rehabilitation is, in fact, a response to a demand, because we wanted more patients to benefit from the service. But during the COVID-19 period, it was mostly used because of the possibility of eliminating the transmission. Excuse me, I'm interrupting you. You said you wanted this service to be available to more patients. with tele program would increase the number of recipients of pulmonary rehabilitation. But do we have any numbers from Turkey about the users of the service? Yes, you're right. That was the aim, to reach more patients. Telepulmonary rehabilitation, in fact, is a service that the patient receives at its own home by using teleservices. In fact, the patient uses internet connection to get the service. This is an online live session, and the patient can follow certain exercises in this online session. Roughly, this is the definition of tele rehabilitation. And how do we implement this? First, we see the patient, we make the examinations and evaluations in our center, and that has to be in the center. I understand. So this is hybrid. Yes. I also know there are some programs that are conducted through video conferences, but I understand that your approach is hybrid. Yes, this approach is believed to be more effective. So we see individually the patient in our center. We make the detailed evaluation in face-to-face modality, and then we structure our approach. And then the patient is admitted to the telepulmonary rehabilitation program, and they come, in fact, they visit our center twice a week online, just like as if they visited our center physically. They visit us online, and we help them do their exercises during this session. And if they have any questions, they can ask during this session. If they need any guidance, they can get this guidance as well. So 4 patients connect concurrently. So 4 patients, and also we, as the physicians, connect to the session, and then this service is fulfilled. So there are centers who provide pulmonary rehabilitation in Turkey, but the centers that provide telepulmonary rehabilitation program are very limited. Keçiören Sanatorium, Atatürk Sanatorium Research and Training Hospital are using and offering this tele-rehabilitation service. And these are in Ankara, and in Bursa Uludağ University, in the Department of Thoracic Diseases, they have this telepulmonary rehabilitation service. In Manisa Celal Bayar University, they have this tele service. Başkent University have it as well. In Ankara again. I understand this is a novel program for the time being. And in fact, the number of pulmonary rehabilitation centers is about 17 and 18 in Turkey. But these are the centers that are attended by specialists of thoracic diseases. But there are also some centers that are attended by the physiotherapists. Each patient, in fact, should be referred to pulmonary rehabilitation by the physician. That's the important part. In fact, this is why we are taking this opportunity in the conference for the public. And we also hold some other information meetings for the public. We would like to raise awareness about this topic, because we want people to come and apply for this kind of rehabilitation. Pulmonary rehabilitation is about a holistic approach, because there are different components integrated into this approach. Pulmonary rehabilitation can be useful to COPD patients, bronchitis patients, pulmonary thickening patients, and a very wide spectrum of patients can benefit from this. In fact, I would like to talk about something else. During the pandemic, in fact, many people were in need of pulmonary rehabilitation. But what was the real cause? Why did those people become eligible candidates for pulmonary rehabilitation? Yes, you're right. The pandemic hit the whole world. Let me talk about first the chronic diseases. In those patients with increased isolation, immobility increased as well. And immobility, the lack of activities, is very undesirable, because these patients need to remain active. And that's why we want these patients to be referred to the pulmonary rehabilitation centers. These patients are already having this lung disease, and their need for pulmonary rehabilitation increased during the pandemic because of isolation and immobility. And there is another group of patients who got COVID-19, even if they hadn't had any complaints before. After getting infected with COVID-19, some of them needed a long hospital stays, and they remained in the hospital for a long time. They remained immobile. Sometimes they stayed in ICUs. And some patients needed oxygenation without an underlying cause. In this group of patients, there was a developing and growing need of rehabilitation. One of the major long-term effects of COVID-19 is lethargy, fatigue, shortness of breath. These are the side effects, long-term side effects or long-term effects of COVID-19. I think these are important indications for rehabilitation. And in fact, as in COPD patients, if we can integrate rehabilitation into the treatment of these patients, there can be a high chance of success. We can get very good results in those patients. So the pandemic is still prevailing. Unfortunately, many patients are infected with COVID-19, and many need hospitalization. And pulmonary rehabilitation will be a referral need for these patients. They can apply themselves as well. So the negativities can be eliminated and turned into positivity with this kind of rehabilitation. Regarding rehabilitation, we can say a lot of things. There are many important bullet points. One of them is as follows. This patient population, suppose that they may have COPD, they have reduced exercising capacity, they have reduced life quality, they have shortness of breath, they present to the hospitals. And now, after the rehabilitation, we see all of these symptoms improve. And as you said, their body composition may be distorted significantly as well, and that can be even improved. For example, their muscle weakness can be restored, and also anxiety and similar psychosocial problems can be responded with the rehabilitation. So rehabilitation can offer restoration and treatment. In many COPD patients, you see, winter season is not very popular. We all know this, the patients know this, we specialists know this, there will be an increased number of visits to the hospital, and we can really help reduce the number of visits. We can really save many working days with the help of rehabilitation. Not just for advanced age, many people in the age group from 50 to 70 are diagnosed with COPD nowadays. So this rehabilitation can offer many benefits. So about pulmonary rehabilitation, Do you have any other messages to give? We can hear them if you have, because we have very limited time remaining. As you have emphasized, the patients and their families ask this common question. They say, okay, we are on oxygen. Then how can I get this rehabilitation? Sometimes the family say that, okay, our patient is already old. Then how can this patient get the rehabilitation? But we may carry out and conduct many tests. The exhaling test, smoking, oxygenation, and all of these are different patients. All these factors can be there, but still the patients should come for rehabilitation. For example, if the patient is still a smoker, we can encourage that person to quit smoking. If the patient is on oxygen, in fact, all these exercises are done together with the oxygen. We evaluate the patient. Specifically, we offer a customized program to each individual. We do not give the same training template or the exercises template to everyone. We prepare something customized depending on the patient itself and its capacity. This is how we arrange the individual programs. So the severity of the disease and the age, in fact, are not the factors that you are looking at in offering the rehabilitation. So any patient of lung disease can benefit from respiratory or pulmonary rehabilitation. So all lung diseases should be referred to pulmonary rehabilitation centers. Even if they are not referred, they can go and apply themselves, so they can go with their file. Because yes, there's pharmacological therapies, but this is non-pharmacological, and we can really implement this holistic approach. This is an important chance, I guess. Well, I would like to thank you very much for the answers that you have provided. Hope to see you again in many other sessions. Thank you. Thank you.
Ben Kamil Hamidullah. Türk Thoracic Derneği'nin düzenlediği akciğer hastalıkları ve COVID-19 konulu halk kongresine ben ve donörüm birlikte katılacağız. Eforla birlikte nefes darlığı, çabuk yorulma ve sonrasında gelişen akciğer kanamasıyla birlikte 1996 yılında ihtiyaçlarım için bile başkalarına bağımlı hale gelmiştim. Kanı su içemiyordum. Çünkü nefesim yetmiyordu. Su içmek bile lüksmüş, onu öğrendim. Doktorlarım hayata tutunabilmem için bir şansımın daha olduğunu söylediler. O da akciğer nakliydi. Akciğer nakli için uygun bir aday olduğum yapılan tetkiklerden sonra ortaya çıkınca nakil için başvurdum. 13 ay organ bekledim. Hastalığı nedeniyle o kadar öldüm, dirildim. Ama hayatta en zor şey meğerse organ beklemekmiş, onu öğrendim. Tam bana organ yetişmeyecek diye ümitsizliğe kapıldığım anda geldi haberi. 2009 yılında dünyalar benim oldu. Akciğer naklinden sonra kana su içtim. Donörüm sayesinde doğa yürüyüşüne başladım. Şimdi de pulmoner hipertansiyon risk gönderme hasta derneğini kurduk ve arkamızdan gelenlere yol gösteriyoruz. Siz de organlarınızı bağışlayarak hiç tanımadığınız kişilerin süper kahramanı olabilirsiniz. Şubat ayının son günü nadir hastalıklara affedilmiştir. Nadir hastalık, nadir organ nakli, akciğer nakli bekliyoruz sizleri.
Herkese merhabalar. Tüm organ yetmezliklerinde nihai tedavi şeklinin organ nakli olduğunu biliyoruz. Akciğer yetmezliği tüm ilaç ve cerrahi tedavi seçeneklerine rağmen hastalarımızın oksijen bağımlı hale geldiği durumu tanımlamaktadır. Akciğer yetmezliği hastalarımızda nihai tedavi şeklinin akciğer nakli olduğunu biliyoruz. Tüm dünyada son 30 yıldır ve ülkemizde de son 10 yıldır rutin bir program olarak yürütülen akciğer nakli programları yüksek başarı oranlarına ulaşmıştır. Bu hem bizim için hem de hastalarımız için umut olmuştur.
Bu yıl 26-27 Şubat tarihlerinde Türk Toraks Derneği'nin halk için akciğer hastalıkları ve COVID-19 kongresi var. Bu kongrenin oturumlarından biri de akciğer nakli ile ilgili. Akciğer nakli oluyor mu? Akciğer nakli kimlere yapılıyor? Akciğer naklinin başarısı nasıl? Bunları merak ediyorsanız sizleri 26 Şubat saat 18'deki oturumumuza çağırıyorum. 26 Şubat saat 18-18.25 arasında akciğer nakli konusunda çok deneyimli bir hocamız olan Sayın Profesör Doktor Erdal Yekeler bizleri akciğer nakli kime yapılır, kimler için uygun değildir, akciğer naklinin başarısı nedir bu konularda bilgilendirecek. Ayrıca sizlerden gelen soruları da yanıtlayacak. Hepinizi toplantımıza davet ediyor ve sağlıklı güzel günler diliyorum.
Good afternoon. I'd like to welcome you all to this lung transplant session. Our guest is Professor Erdal Yerkeler. Erdal Yerkeler is going to inform us about lung transplants and provide important information about lung transplants. And we will have connection with our patients who have had lung transplants. So, Erdal, who is eligible for a lung transplant? For whom you decide on lung transplant? Are there any situations where lung transplant is not suitable? I'd like to thank Turkish Thoracic Society, and I'd like to wish good afternoon to all participants. Lung transplants, as you know, in Turkey, have been introduced since 1980s. And with great success, like the other organ transplants, but lung transplant is one of the very last transplant that have been introduced in Turkey. So since 2012, it is routinely done among all organ transplant. It is most complicated, most difficult transplant. And because of the process, it is the most difficult transplant, organ transplant. In pulmonary failures, in lung failures, it is the last resort. It is the last radical surgical intervention for patients. As I said before, among all organ transplants, it is the last resort for lung failure. Despite surgical interventions or medical interventions, lung transplant is the last resort. So who is eligible for a lung transplant? A lung transplant is suitable for people who have pulmonary failure. It is the most important indication. COPD is the most important indication for lung transplant. And then idiopathic pulmonary fibrosis, interstitial lung diseases, or lung fibrosis, as we call it. Apart from that, bronchiectasia is the third common indication for lung transplant. But in the Western European communities, cystic fibrosis that develop especially in childhood and may also extend to adults because this is genetic disease. All around the world, it is the third most common indication for lung transplant. As I said before, in the world and in Turkey, COPD, bronchiectasia, also cystic fibrosis, and occupational disease, which is silicosis, which is specific to Turkey, are the most common indications. That is common in coal miners, where Teflon, glass, and denim sanding is used, and also in the marble industry. Most of the occupational diseases, patients with occupational diseases present to us for lung transplant. And for COVID patients, which is a hot topic nowadays, patients with severe COVID infection, after COVID, there may be some damage in the lung. There may be fibrosis in their lungs. So after ICU stay, after first 2 months, if patients are dependent on oxygen, after COVID-19, because of the indication of fibrosis, they present to us. And in order to help these patients, we can consider lung transplant when they are dependent on oxygen, and we may put them in the waiting list for lung transplant if they are eligible. Apart from all these main headings, we can say that lung may have benign diseases where people older 65 that are dependent on oxygen, lung transplant should be considered definitely. So in our province, the chest diseases and thoracic surgery specialists should be consulted for eligibility for lung transplants. Patients referred to pulmonary centers should be evaluated. If there isn't any medical barrier before that, they can be put on the waiting list for transplant, and then when there is a suitable and eligible donor, then they are transplanted. So we can say that there are apart from 5 indications, for the benign pulmonary diseases, there may be hundreds of benign lung diseases. So when we say who is eligible for a lung transplant, there are hundreds of diseases for which patients may be eligible for a lung transplant. Any kind of condition that leads to oxygen dependency and damaging lungs, we can consider lung transplant. Thank you very much, Erdal, for listing these wide indications for lung transplants. As far as we understand, there's an age limit which is younger than 65. There may be some additional problems which are barrier before lung transplant. What is the process of lung transplant? What should be taken into consideration before and after lung transplant? As I said before, if there is a pulmonary failure, if the person is dependent on oxygen, the professors in their locations may refer them to the transplant center. When they are admitted to our centers, transplant centers, for 10 days, they are hospitalized. And then we analyze and examine them for eligibility for lung transplants. we evaluate cardiac situation, angio, renal examination. We also examine for cancer significantly and for the liver, because lung transplant, as we said in the beginning of our session, among all organ transplants, it is the most difficult, most challenging, most complicated and severe surgical intervention. For such a big operation, is our patient's other organs or body eligible, suitable for such a transplant? We try to understand if there are any risks or not. So in 1 week of hospitalization, we try to rule out cancer and also other cardiac situations. We perform angio and also echo and other cardiac exams. We check for infections in the body. Is there any viral infection? For example, hepatitis B, hepatitis C, HIV, and other infections such as tuberculosis. Is there any history of tuberculosis, other sequelae of tuberculosis? Is there any cancer which may constitute a barrier? And renal functions are very important. So we try to check if there are any risks associated with the renal functions that may be a barrier before the transplant. Like 150 tests or examinations, biochemical, hemogram, other cancer screening tests, hormonal panels are run for these patients. We perform so many tests, and after that, based on these tests, we create a file, a folder. We have a lung transplant council that consists of 15 specialists, and in that council we discuss these patients and we evaluate these patients for their eligibility for lung transplant. After that discussion in the council, if they are eligible, we put them on the waiting list. If not, we inform the patients and justify with the medical reasons why they cannot get a transplant. After they are on the waiting list, they wait for the organ. The waiting time in Turkey, especially after COVID, was extended, is longer now. Because in the Western societies, in Western countries like America and Europe, the waiting time is much shorter. But in Turkey, it's like 1 year, 1.5 years in Turkey. Especially COVID had negative impacts on waiting lists, and that put us in a challenging situation. Of course, donors and organ donation are quite important, which should be highlighted with this occasion. After organ is found, especially on the waiting list for lung transplant, contrary to the other organs, we have a certain practice because compared to other organs, this is just one of the peculiar problems of lung transplant. We check the blood group. Whenever there is an organ, definitely we need to give it to a recipient from an A blood group. And also size compatibility is important. So a donor that is 150 centimeter, we cannot put that lung into another recipient which is 180 centimeter, because that lung size will be very small for that person. It will not fill the chest cavity. On other occasion, if there is a donor which is tall, like 180 centimeter, that lung will be very big. For a female patient, that is 150 centimeters. So the size compatibility is important after blood group. For example, if there are 15 patients with A blood group, of course, we take into consideration their entry order. The second criterion is the size of the lung. We evaluate the size, compatibility, and then we accept that donor. Then the surgical procedure starts. After we bring our lung in the surgical procedure, first we have two lungs, you know. We try to do it bilaterally if possible. First, the bad lung, based on the examinations, we know that. First, we excise the bad lung, and then we first right lung is placed with the donor's lung, and after that we do it on the left side. We place the left lung. We should ask a question: if two lungs are bad, after you excise my lungs, throughout this surgery, how can I survive? This may be a question that crosses our minds. So in that case, we have a cardiac lung pump, which is a device. We attach the patient to that device, So oxygenation in the body, in the blood, can be done through that device, and we finalize our surgery in this way. And both lungs are placed. We perform our anastomosis, I mean vessels, the respiration tube, and also the vein and also the artery are attached together, and then our patients become ready for the transfer to the intensive care. Intensive care takes almost 10 days. It may be a rejection, there may be a rejection, and also because of this trauma, because that lung comes from ice, cold chain, and it is placed in the recipient patient, it has to be compatible with the patient. So you can see this in the first week. It is a challenging period. After 1 week of intensive care process, then they are taken to the wards, and we have 1 week of intensive care, and they are hospitalized in the ward for almost 1 month. If everything is all right, if there is no problem, they are discharged. Thank you very much, Erdal. So how many transplants do you do because of the limited organ donations? Is it a problem for you? What is your capacity and how many you do? This is one of the problems in Turkey. In Turkey, last year, 21 transplants, lung transplants were performed in our center. We could do only 7. So in Turkey, in 1 year, the maximum number of lung transplants has been 43, which was in 2018. And in Turkey, the population is 84 million. Compared to Germany, with a population of 80 million, which is a member state of the European Union, they perform 350 lung transplants in a year in Germany. So compared to Germany, the need for lung transplants is like 350. Unfortunately, maximum number of lung transplants is 43. So we are way behind than the need in terms of the lung donations and lung transplantations. How can we overcome this problem? There is a scarcity in donations and donors. Compared to Western societies and Europe, we are way behind in terms of donations. First, we need to increase donations. And the second important problem is, after the organ is donated, the usability level of the lung should be increased. What should I say at this point is that after a donation is done, after a patient becomes a donor, if there are 100 donors, we can use 95% of the kidneys and also 40% of their hearts, only 25% of their lungs at global level. But out of 100 donors, only 12% of them lungs can be used. So the usability of lung around the world is low, but in Turkey it is much lower. First of all, I just would like to appeal to all people in Turkey. We need to increase the lung transplants and to give some air to our patients. And the number of donations should be increased, and we need to also raise awareness of the public in this sense. If one of your relatives, if you have a relative, or your sons, your children, your siblings, fathers and mothers, of course, we don't want this to happen to anyone, have brain death, so please donate the organs of those patients, because one donor or organ donated, we can save 8 lives of 8 people. So we can bring quality to the lives of 8 patients. So this is the area where we can improve the situation with lung transplantation, because those patients cannot even drink their tea, cannot grab their cups from the kitchen. 1 month after transplant, they start walking, go to work. So it is the indication of the importance of organ transplantation. We can clearly say this based on these examples. Indeed, thank you very much for this emphasis. So we have some patients who had the chance to get a lung transplant. First, we have a patient from abroad. We have a video. he was transplanted, and he's going to talk about what he felt, and then we will have some conversations with our own patients. Thank you.
Hello everyone, my name is Steve Jones. I'm the president of the European Pulmonary Fibrosis Federation and also chair of Action for Pulmonary Fibrosis, a charity in the United Kingdom. I lived with idiopathic pulmonary fibrosis, that's IPF, for 8 years until 2016, when I was very fortunate to have a single lung transplant. And as you can see, here I am, almost 6 years later, I'm still healthy and fit after my transplant. For me, the decision to have a transplant was a no-brainer. Why would you not have a transplant if you're offered it? Because as an IPF patient, I was becoming very ill. I'd had the disease for 8 years. I was on oxygen 24/7. I was getting to the point where I probably had only for a person of my age of about 5 years. So it was a no-brainer. I went for it, and I would advise all other patients with idiopathic pulmonary fibrosis, which is a disease from which you decline very rapidly, that a lung transplant is a really great way forward. I waited only a very short time. I was finally, after one full start, I was transplanted only 12 days after going on the list. Now that is exceptional. In the UK, the average is approximately 9 months on the waiting list before you get a transplant. I was done quickly, both because I had a compatible blood type, but also because I think the doctors realized that I was becoming rapidly less well, and they really wanted me to be transplanted as quick as possible. So I was transplanted, as I say, in only 12 days, which was quite remarkable. I would say I run in the UK a transplant patient support group for patients who are waiting to be transplanted with a lung transplant support group. The purpose of that group is to bring people who have had transplants like me together with those who are coming, to help them understand the journey they're on, understand the stages they go through, help them assess risks and the concerns that they have as they're waiting for the transplant. I would say to every patient on the transplant list, you've really got to be patient. You've got to do what you're told, listen to what the doctors ask you to do, make sure you do that, keep fit, keep doing some pulmonary rehabilitation exercises at home, but recognize that it's a patient. You have to be patient. It will take many weeks, if not months, before you'll get the transplant. And it's a very, very anxious period. I know really how anxious it is, but that's the only way to really do it. Keep yourself exercised and keep yourself aware that you have to be patient. And now, as I say, I feel great. I must say there are friends of mine who have done less well than me, and sadly are no longer with us. But I also know many other patients who have done better than me. They've been alive already for longer after a transplant. So for me, it certainly should be considered by all IPF patients and other ILD patients who are offered the opportunity of a possible lung transplant. So if any of you would like to learn more about our transplant patient support group, talk to the organizers of the Congress, the conference, and I'm sure they'll put you in touch with me. So thank you very much. I hope you have a very enjoyable meeting. Thank you.
Evet, akciğer nakli şansını çok
Right.
fazla elde edilmiş.
He had a very good chance of lung transplant.
Gerçekten büyük bir şans bu kadar hızlı.
So he had a great chance to get a lung transplant so quickly. Hopefully in Turkey the number of donors and donations increase and everyone can have the chance of getting lung transplants quickly. So we have two patients with us, Kamil Hamidullah and Pakize Can.
Kamil Hamidullah
Kamil
benim
Hamidullah
yıllardır tanıdığım bir pulmoner
is the one
hipertansiyon olgusu.
is
Kendisi
pulmonary
benim gözümde
hypertension
gerçek bir
case that I have
kahraman.
known for many years.
Hastalıkla
He's a real
savaştı,
hero
nakil
in my eye.
sürecini
He
götürdü.
fought against
Nakilden
the disease. He
sonra
had a transplant. After the
rahatladım.
transplant,
Artık ben
he felt
mutlu,
relieved
rahat
and
yaşayayım demedi. Hasta
he
derneği kurdu.
he just established a patient
sıkıntılarını, sorunlarını çözmeye
society
çalıştı. Ona
association
ulaşan
trying to
hastalara
solve the
destek olmaya
problems
çalıştı.
of the patients, trying to
Kamil Bey,
help the patients
ben sizden
that reached out to them.
kısaca
So very briefly,
nakil
what would you say
sürecinizi sonra
about
nasıl
your
yaşadığınızı
process?
anlatmanızı
What was
isteyeceğim.
the process
Sonra da
like for
Erdal
you?
Hocam,
And then
hastası sevgili Pakize
Erdal's
Can'la
patient Pakize Can
kısaca
will
söyleyecek.
speak.
Buyurun Kamil Bey.
Over to you,
Öncelikle
Kamil.
çok teşekkür ederim. Çok
First of all, thank you very much. You are very kind. You made me survive. Thank you very much, both of you. So I cannot do enough for you. I hope that violence in the medical system will come to an end very quickly. So I was diagnosed with pulmonary hypertension, which was a rare disease, and there was no treatment for that. And till 2009, I could survive with medications, but after a while, I could not see any benefit from those medications because the disease progressed. And they told me that I had another chance, which was lung transplant. After the examinations and tests, I was eligible for transplant and I applied for transplant. I can tell the patients when you learn that you're a candidate for lung transplant and when you're on the waiting list, it doesn't mean that you will get a transplant tomorrow. I waited for the organ for 13 months and there's a preparatory process because your muscles should be strengthened in order to restore your health after the operation as soon as possible. After that, our professors were quite diligent in caring for me, and in a very short period of time I could recover and I could restore my life back. And I can say that it was just half life for us. We had to use full strength to breathe. We were dependent on people. Now we became independent and we have self-confidence now. So we are now like ordinary citizens, ordinary people. Of course, there are certain points that we need to be careful in this process. I'm not going to talk about all of them so that Pakize can also speak about them. But when that hygiene, mask, and other measures that you became familiar with COVID-19 pandemic were much before that for us, because hygiene was very important, because lung is the only organ that opens up to outside because all organisms and particles are inhaled. We are using immune suppressive medications and we are vulnerable to infections. So I'd like to give the floor to our professor and Pakize. Thank you very much.
Evet, burada diğer bir kahramanımız
We
Pakize
have
var.
another hero, Pakize.
Pakize'nin süreci belki Kamil Bey'le kıyasladığımız zaman çok daha
Pakize's
ağır ve
process
çok daha üzücü geçti bizim için.
More severe and very sad.
Kendisi İzmir'de yaşıyordu ve pulmoner hematokrozis dediğimiz tanısı vardı. Bu hastalıkla bize müracaat etti ve biz akciğer nakil bekleme listesini aldık ama tabii ki o zaman oksijen bağımlıydı ve çok günlük işlerini daha yapamaz durumdaydı. Pakize ve bu şekilde akciğer nakil bekleme listesini alındıktan sonra Ankara'ya taşındı. Ankara'ya yerleşmek zorunda zaten tüm hastalarımız. Ankara'ya yerleştikten sonra tabii ki durumu çok ağırlaştı Pakize ve solunum cihazına bağlanmak zorunda kaldı. Belli bir dönem solunum cihazıyla yaşamını idame ettirdi. Tabii ki bizim de çok sevdiğimiz bir kızımızdı Pakize. Bu esnada solunum cihazına bağlandığı için tabii ki acil listesine alındı Pakize. Ve arkasından solunum cihazı dahi yetmez duruma geldi. Solunum cihazıyla hayatını idame ettirirken yoğun bakımda bu şekilde yani entübe halde hayatını idame ettirirken solunum cihazının dahi yetmediği görüldü ve arkasından hasta Pakizemiz ECMO dediğimiz kalp akciğer pompasına bağlanmak zorunda kaldı. Kalp akciğer pompası dediğimiz durum gerçekten bir akciğer hastası için çok ciddi ve bundan daha ötesi olmayan bir noktadır bu. Ve bu esnada artık neredeyse ümitlerin tükendiği bir noktada organ çıktı ve Pakize'ye biz akciğer nakli, çift taraflı akciğer nakli yaptık. Ve hastamız Pakizemiz problemsiz olarak ortalama yaklaşık 1. ayında taburcu oldu. Ve taburcu olduktan sonra belli süre Ankara'da bütün işler düzene girinceye kadar yaklaşık 1,5 yıl kadar tekrar bizim gözetimimizde Ankara'da yaşadı ailesiyle birlikte ve arkasından da İzmir'e taşındı, İzmir'e yerleşti. Ve bütün bu detayları, hissettiklerini, yaşadıklarını kendisinden duymak istiyorum. Ne tavsiyelerin olur, ne gibi tavsiyelerin olur Pakis'e?
Merhaba hocam, iyi yayınlar.
Hello, Professor. I wish you a good meeting.
Öncelikle dediğiniz gibi çok
First of all, as you said, it was really severe.
Ailem de bu süreçten geçti.
And the whole family also passed through that serious situation. But thanks to you, I survived and I'm here in front of you and I'm healthy. As you said, 1.5 years I was under strict supervision, so every 3 months I'm coming for the control to you. And first of all, the reason why I presented to you, I thought that I was going to die. I was so pessimistic. I was in a very bad situation. I didn't feel good. I had to wait on the waiting list, but I'm really good now. I finished my school after transplant. I'm working now for 5 months. For 8 years. I was dealing with IPS. I also had other problems in my childhood, so I could not cherish and enjoy my childhood. But now everything is settled. Like Kamil said, we were paying attention to mask and hygiene measures at all after the transplant, so we were used to it. We adapted to it well. So I got COVID 6 months after transplant. So COVID started in Turkey after I got transplanted. Everyone started using masks, but we were already using these masks, wearing masks, and we had to pay more attention than the other people. Then vaccines came to Turkey and we got vaccinated. I had my 4 doses, and I thank God that I did not get any COVID infection in this period. I don't go to crowded places. I still don't. I do not stay indoors and crowded areas. I try to avoid these places as much as possible. Now, the workplace is quite suitable for us. There are only 3 people in my room. It is suitable for me. So I'm lucky.
Teşekkür ediyoruz Pakize.
Thank you very much, Pakize.
Hem Kamil Bey'in hem de Pakize'nin söylediği gibi özellikle COVID dönemi, COVID enfeksiyonu, akciğer nakli olgularımızda çok daha ağır geçmekte. Ve neredeyse 6 kat normal insanlara göre akciğer nakli olmuş hastalarımıza 6 kat daha öldürücü ve yoğun bakım yatışı itibariyle çok daha ağır hastalık geçirmekte akciğer nakli hastalarımız. Bu anlamda tüm akciğer nakli olmuş hastalarımıza ve tüm organ nakli
transplant patients and all organ transplant patients need to be taking good care of themselves much more than the other people compared to other people. They need to pay attention to the measures more. And as a final remark for the people, I just would like to say that, like Kamil and like Pakize, if you have respiration problems, if you have pulmonary failure, you may consider lung transplant as the last resort. We have such examples. To increase the number of such examples, I just would like to highlight the importance of organ donations. The more organ donations we have, the more patients we can help, and the more patients with respiratory distress and shortness of breath and pulmonary problems, so we can bring air to them and we can touch lives of so many patients in this way. Thank you very much. Thanks a lot, Professor Erdal. We'd like to thank our guests. So this is the last session of the day. In this last session, we can see smiling faces, breathing, inhaling, exhaling comfortably, and they are smiling. I hope that this has been a hope for most of the patients here in Turkey. So tomorrow we will have other sessions as well, and would like to see you all in tomorrow's sessions starting at 12. Thank you very much. Have good, healthy days. Good evening. Good evening. Good evening.